We have some original research work on this area from our institute. I will be showing during my presentation. So the topic is the update on physiology and pathophysiology and isolation. We'll see the latest what is there in modern anesthesia. Can you put the timer as 30 minutes? Timer. Yeah, okay, thank you. So understand modern anesthesia, the four key principles are preoperative workup, pathophysiology of one-lung ventilation, management of hypoxia during one-lung ventilation. It is prevent as well as manage. And let us see what is the update on methods of lung isolation. I'm not going to talk about the preoperative workup, but the preoperative workup is most important. One is the functional capacity of the patient, predict the postoperative FU1. If you assess these two, it is very easy to decide or assess the status of the patient intraoperatively, and you can predict the postoperative morbidity. Now coming to the second part, pathophysiology of one-lung ventilation. You'll see the physiology first, followed by what is the response to hypoxemia, what are the ventilatory modalities to improve oxygenation and treat hypoxemia, and this is very important. Is there a cerebral desaturation episodes during one-lung ventilation? Whether it is coinciding with peripheral saturation or it is different. And finally, I'll talk on use of ECMO for one-lung anesthesia. So this summarizes. Do you have a pointer here? Give me a pointer. This pointer is not coming in. Yeah. So this is a point, and I got the point. So this is three scenarios. The awake spontaneous patient. Second column is anesthetics. You intubate the patient and give relaxant. Third is during collapse, during surgery. So here, you and I, if you lie on the lateral position, you have the maximum ventilation on the dependent lung and less ventilation on the non-dependent lung. And the perfusion also, pulmonary perfusion is gravity driven, so the maximum perfusion also on the dependent lung. So there is a maximum ventilation on the dependent lung, maximum perfusion, there is no ventilation perfusion mismatch. And if you give 100% oxygen, the PO2 you record it is around 500. Now the problem starts when you intubate the patient and give relaxant and put the patient in lateral position, the ventilation switches over to 40%. This is the pulmonary perfusion. Ventilation switches over perfusion to the upper lung. But the perfusion remains best in the lower lung. So that the ventilation perfusion starts and the PO2 drops. And when you collapse the upper lung, that is the operated lung, the perfusion to that lung is cut down by this hypoxic pulmonary vasoconstriction. So 40%, because hypoxic pulmonary vasoconstriction, the blood flow of 50% of that comes to the ventilator. That is good. Hypoxic pulmonary vasoconstriction of the operated lung is good. But still there is a contribution under 20% that contributes to the hypoxemia. But the PO2 drops to 150. So we are not worried about the PO2 up to 60. Hypoxia in one-lung ventilation is called when it is less than 60. But if you have hypoxic pulmonary vasoconstriction in the dependent lung, there we have a problem. So that is what. So we have to manage as anesthesiologists. We have to manage both the operated lung and the non-operated lung. So coming to hypoxic pulmonary vasoconstriction, a little more details is a biphasic response, and the early response starts within seconds as soon as you collapse and peaks around half an hour into one-lung ventilation, and there is a delayed response over next 2 hours. That means PaO2 gradually increases. So this is a practical importance. The last statement is the last statement. Re-expansion of non-dependent lung augments hypoxic pulmonary vasoconstriction. So the PO2 improves as the surgery goes. So in between there is an instant hypoxemia. You give two-lung ventilation, then again collapse, the PO2 will be much better. So that is the importance of this treatment. And what is hypoxemia? It is defined as SpO2 less than 90 or 85 in a perfectly healthy patients, or a PO2 of less than 60 at a FiO2 of 1. Provided the patient has no comorbid illness, no coronary artery disease, no cerebrovascular disease. If the patient is having coronary artery disease, you have to maintain saturation of 95 during modern anesthesia. And all other patients, saturation of 90 is okay. Incidence is fortunately less than 4%. No, we can exactly, almost certainly we can predict who develop hypoxemia during modern ventilation. Right side surgery. Right side surgery, the PO and left lung ventilation. Because the right lung is bigger, the improved pulmonary blood flow to right lung. So if you collapse the right lung, definitely the chance hypoxemia is more. This study has shown that the PO2 difference of 110 millimeters between right and left lung with an FiO2 of 1 during one lung ventilation. So you can note the difference. And secondly, high percentage of ventilation or perfusion to operate lung in a VQ scan. That means a normal patient coming for a non-lung surgery. For example, you want to give one lung anesthesia for a vascular case. In such cases also, you have this problem. And also remember that FiO1 is inversely proportional to PO2. As FiO1 increases, the PO2 decreases. Again, a good lung, it collapses. Chance of hypoxemia is more. And the patient, both lungs are bad. Low PO2 on two-lung ventilation, the lateral recurrence position, then the chance of hypoxemia is more. And finally, patients with small tumors, the operating lung have more perfusion and hypoxemia. That means a patient with a big tumor will have a less perfusion, they have less chance of developing hypoxemia. Whereas a patient with a small tumor, suppose a left lung surgery, a small tumor, that patient has a higher chance of developing hypoxemia. And of course, reports are there that morbidly obese patients have more chance of hypoxemia during one lung ventilation. And the patient has undergone a contralateral surgery preoperatively, and especially when the contralateral surgery has produced lung dysfunction by more than 25%. So these are the patients who develop hypoxemia during one lung ventilation. Now, this is very important. Whether this one lung ventilation, whether this is cerebral desaturation. Profound hypoxia, that means SpO2 less than 65 may produce neurocognitive function. But if you look at this report, cerebral oxygen desaturation during one lung ventilation, correlation with hemodynamic variables, and you look at this graph, the peripheral saturation, SpO2 is remain almost stable, but the cerebral saturation during one lung ventilation is coming down. So this study showed 18 patients, and irrespective of the cardiac output, they studied the correlation between desaturation and hemodynamic variables, and found that there is no correlation, and all the patients develop cerebral desaturation during one lung anesthesia, irrespective of the fact that they have a good saturation in our SpO2 probe. Again, another study, significant decrease in cerebral oxygen saturation during single lung ventilation measured using absolute oximetry. This Himalayan has published a series of articles, and their conclusion is thoracic surgery with single lung ventilation seems to be associated with significant decrease of cerebral oximetry in majority of patients. Peripheral saturation measurements are not sufficient to detect significant cerebral oxygen desaturation. Whether this will lead to a neurocognitive dysfunction, there are not enough studies. One study is there, they found that at 3 hours after extubation, patient with cerebral desaturation has got a neurocognitive dysfunction, which is recovered later. So this is something to learn in the future. Any institutions here can take this up. This is totally different. One of the proposed mechanism is a shower of emboli going into the brain, producing a cerebral desaturation. Now, how you manage hypoxemia during one lung ventilation is non-urgent, if patient develops significant desaturation during, can you switch off this light? Switch off this light? Yeah? Oh, okay, sorry. Because I am going to show some videos. The videos will not be very clear, that's why. Non-urgent surgical procedures to be stopped if there is a significant desaturation, increase FiO2 to 1, and post-tubular ventilation. Most common cause is malposition. We check the DLT of bronchial blocker position, requires an FOB, examination, and clear the secretions. And again, you have to re-establish one-lung ventilation. So this is again a flow chart. So if the patients have a chance for hypoxemia prior to one-lung ventilation, there is a prediction. They can prevent hypoxemia by alveolar recruitment maneuvers. And if your hypoxemia develop, that is saturation less than 90 or at an FiO2 of 1, switch over to two-lung ventilation. And definitely the improvement will occur. And you have to position, look for the position of the bronchial blocker and the double lumen tube and return to one-lung ventilation. Now, you should have a strategy to maintain that oxygenation. So how you maintain that oxygenation? There are strategies for the dependent lung and the non-dependent lung. For the dependent lung, recruitment maneuvers you can do, and PEEP. PEEP can be applied with the dependent lung. So now this is a standard procedure to apply a PEEP of 5 to the dependent lung right from the beginning. And for the non-dependent lung, that is operative lung, you consider apneic oxygen circulation by different methods and CPAP. Varying method levels of CPAP from, if it is a thoracostomy surgery, you start with the 1 to 2, and for a open thoracotomy, you can start with 5 and go up to 10. So, and again, we are saying that you should not maintain the patients 100%. So, what are the problems with the IFO? Oxygenation, this report has shown that oxygenation, inflammatory response, lung injury during one-lung ventilation in rabbits using inspired oxygen fraction of 6.6 and 1. They studied two groups. And what they found that animals that received FiO2 of 0.6 during one-lung ventilation has a less inflammatory response and less lung injury. So extrapolating this data to human being, if a lower FiO2 can maintain oxygen during one-lung ventilation, then it's possible that inflammatory response and less lung edema will occur, less inflammatory response, less thickening of the alveolar wall, and less lower acute injury will occur when using an FiO2 of around 0.5 to 0.6 compared to FiO2 of 1. So what are the alveolar recruitment strategies during one-lung ventilation? So this study, their basic ventilation was 8 mL per kg at 10 to 14 rate, and when the patient was switched on to one-lung ventilation, used 6 mL per kg at the rate of 15 to 18 with a PEEP of 8. Then switched over the pressure control ventilation at the FiO2 of 1. They increased to peak inspirated pressure of 30 with a PEEP of 10 for 5 breaths. They increased to 35 and 15, and finally to 40 and 20. 20 PEEP and peak inspirated pressure of 40, a pressure control ventilation for 10 breaths. And what they found that the PO2 has significantly improved with the alveolar recruitment maneuver. So you can use it routinely, or patients who are prone for hypoxia during one-lung ventilation. So there are many studies about alveolar recruitment during one-lung ventilation. I have chosen these two studies. In the first group, there are 20 in the control and 20 in the study group. And the alveolar recruitment strategy is PEEP of 5 to 20 for 10 breaths before and after one-lung ventilation. And this is the PO2 difference, 181 and 251. So that's a significant improvement in PO2. And again, in this group, again the endpoint of the study was effect on oxygenation, a significant improvement in PO2. Now, what is the optimal tidal volume during one-lung ventilation? It was found that large tidal volume during one-lung ventilation leads to inflammatory response, lung injury, and post-operative pulmonary complication. people have used, studies have shown that the low tidal volume is associated with preserved gas exchange, low incidence of primary infiltrates and ARDS. So the recommended settings are 5 to 6 mil per kg during 1 lung inhalation, and the driving pressure should be, or the peak inspiration pressure should be less than 25 during 1 lung inhalation. If it is more than 25, the pressure goes more than that, there is a chance of, that means there is some problem with your bronchial blocker, or you are using undersized abdominal tube, or the malposition of the tubes. So the next question is, which is better, pressure control ventilation or volume control ventilation? There are two meta-analyses controlling, comparing these two, whether we should use the pressure control ventilation or volume control ventilation. What they found, the summary of the PAO to FAO ratio were better with pressure control ventilation. Peak inspirated pressure was low with the pressure control ventilation. There is no difference in the mean airway pressures, but the post-operative complication is similar. So you can decide what you want, and if you are institutional practice or a personal practice. So what are the other strategies to improve oxygenation during 1 lung ventilation? So there are two techniques which are described. 1 lung ventilation, additional ipsilateral ventilation, low tidal volume, and high frequency in lung lobectomy. This is a recent study, 2016. So what they used two ventilators. The operant lung was ventilated with the tidal volume of 1 to 2 mils per kg at the rate of 40 mils. They have found that the ratio increases, PO2 improves, and this is from our institute. I think the author is somewhere here. So effectiveness of ventilation of the non-dependent lung for a brief period in improving arterial oxygenation during 1 lung ventilation. So what they did is they ventilated with a fixed tidal volume of 70 ml per minute with a rate of 6 per minute for 15 minutes after initiation of 1 lung ventilation. The surgeons were blinded. And they did not notice which patient received the ventilation on the operant lung, which patient did not receive it. So this is a good strategy. And other thing is apneic oxygenation, decrease the incidence of hypoxemia. That means you give suction catheter into the operator lung and give oxygen at 3 liters per minute. And they found that the hypoxemia in the insufflation group, oxygen insufflation group, hypoxemia is less compared to 18% other group. So other technique is using a bacteriostatic filter here. This is called intermittent positive airway pressure. You can give oxygen and give intermittent pressure also. So that is, this is a report has come from Australia, and from Canada, Peter Slinger is already on 1 lung anesthesia. What he said is, the patient is undergoing thoracoscopic surgery in the left upper lung. So you put the bronchoscope in the lower lung and give oxygen to that suction port. So that is another technique. There is another technique described is this arm blocker, and through this lumen you can give high frequency jet ventilation. And they were able to treat hypoxic events during 1 lung ventilation. When CPAP on the non-dependent lung failed to improve oxygenation, they give high frequency jet ventilation through the arm blocker. So these are the techniques. What about pharmacological interventions for hypoxemia? You can vasodilate the ventilation lung, vasoconstrict the operator lung. Different maneuvers are there, but none of the pharmacological interventions are validated, not really found useful. But people are trying that for especially for thoracostomy surgery, where any amount of lung movement is not allowed. Now, very relevant news is dexmedetomidine is useful for 1 lung ventilation. So what they have found is, in patients with moderate chronic obstructive pulmonary disease undergoing lung surgery, they did a randomized controlled trial, and continuous infusion with sevoflurane anesthesia, infusion of dexmedetomidine sevoflurane anesthesia, improved the PO2. So there is a meta-analysis of various reports of dexmedetomidine. What they found that it definitely improved oxygenation during 1 lung ventilation. We have not tried, people can try. But what the proposed mechanism probably reduces the dose of inhalational and IV anesthetics which has a potential effect on hypoxia vasoconstriction. So coming to last part, methods of lung isolation. So this was the position used by our past surgeons when there was no methods to isolate the Harry Brown position where the secretion is not allowed to drain like that, so that it doesn't contaminate the healthy lung. Then single lumen umbilical tube was used way back in 1931. Bronchial blocker was in 1930, but I was personally surprised that FOB was used to position the WBT only in 1980s. Though the rigid bronchoscope came earlier than that. And you know this is the pioneer of WBT, Frank Roberts, who designed red double WBT tube, still being used. He designed it in 1950s. He modified Carline's tube, he removed the hook, made a lot of innovations. He didn't patent it. He thought that it doesn't have any innovation. And he published it in 1962. And in 1979, UK acknowledged him because in 17 years later, they declared that Robert Shaw tube was the most widely used tube in the world for one lung anesthesia. So he is a pioneer of one lung anesthesia. So methods of lung isolation is, the most common is double lumen tube, bronchial blocker, and unilumen tube. Single lumen tube can be used in emergency. These are the commonly used double lumen tube. The modifications are also there. Like for the right endobronchial intubation, they modified the Mallinckrodt tube. You can see the opening in the conventional Mallinckrodt tube is smaller, and the modified is a larger one. But we have found that we had a problem with the Mallinckrodt tube, manufacturing defect. So when we look at the literature, all the manufacturing defects all over the world, which are reported, came from one company, Mallinckrodt. So that we reported in anesthesia and analgesia. One journal, JCVA, refused to publish it, but anesthesia and analgesia accepted publication. You are telling fact. But all were reported from the developing nations, third world nations, not from the developed nations. So something fishy in marketing the product. So this is the latest video capable double lumen tube, Ambu Viva's slide. So there is a light here, and you can see on the monitor. There is no need for FOB. And retrospective analysis that 93% success rate without FOB. Expensive tube. These are the tubes for a pediatric patient. Can be used in infants. And if you have a tracheostomy patient, especially designed double lumen, this is the right side from Poland. And regarding size selection, you know that the men requires 39 and 41, and female usually 35 and that is French. And you can put double lumen tube as in children also as young as 10 to 8 to 10 years of age. Regarding positioning, clamp and declamp, these are the four techniques: clamp, declamp, and auscultate. FOB very important. And airway pressure changes during two-lung ventilation, one-lung is very important to do. That is the first thing to tell you that the tube is malposition. And cotton wool test is absolute physiological isolation. Ventilate through the one lumen, whether it's airly through the other lumen. So these are the difference between double connector and single connector technique. This is a double connector, but you can use a single connector also, which is used for mass ventilation. Connect to one lumen, auscultate, connect to other lumen. So a combination of these can be used to find out a problem with one lung anesthesia. So if there is a problem of positioning and increased airway pressure, you can use this algorithm. This is your partition anesthesia. The existing algorithm was something like 15 to 18 steps here. Come down to 6 steps, and you can easily identify the problem of the tube. Okay, so this. So this is FOB. Is there any problem with the positioning? This is a left endobronchial tube. You can see the bronchial cuff there. Just proximal. That is not acceptable. They have to push a little more. This is the right upper lobe bronchus on the right side. So you can see the trifurcation there. Apical anterior posterior segment, and there is some secretion at the circuit out. That is in the medial bronchus. And now we take out the FOB. And put it in the bronchial lumen. Again, look for secondary carina on the left side. This is a double lumen tube, and that will tell you whether to reposition the tube finally. Okay, it's going with the bronchial lumen, and here there is a secondary carina. This is a little far away from there. You can position it closer. So the bronchial cup was partially herniating. So this is how you can push the tube a little more in. And these are the bronchial blockers on Fuji, Hoop Duct, Univent and Fogarty. Except Fogarty, all got a central channel through which you can apply CPAP. This is arm blocker used in our institution. And this arm blocker is going in. You can see the wire loop going in. You can direct the FOB also and position the bronchial blocker there. And the hook duct from hooks, it's just a torque control mechanism. You can direct it to one side or either side using the torque on the proximal end, and that is now it is going to the right side. Right side. And this is EC blocker. This has got two cuffs, and you can choose which. It's a bifold one. Two cuffs. It's going into either side. You can put it into either side and inflate whichever lung you want to block. Now, I will show this, which is better. Double lumen tube. This is my last one of the slides. So, comparison efficacy and adverse effects of double lumen tube versus bronchial blocker. And this meta-analysis came in 2015. And they compared 39 RCTs between 96 and 2014. And their reports are DLTs could be placed 59 seconds faster than bronchial blocker. DLTs are more correctly placed than bronchial blocker. The odds ratio is 2.7%. The quality of lung collapse is similar. There is no difference. Bronchial blockers are associated with a significantly less incidence of sore throat, hoarseness, and airway injury. And bronchial blockers are more expensive. So I leave it to you to choose your technique. And if there is a problem of managing multi-lung ventilation, significant chance hypoxemia, you can use ECMO, different ECMOs, veno-arterial, veno-venous, and a double lumen veno-venous ECMO. These are the indications of our ECMO. This is given in literature. So to summarize, thorough knowledge of the airway anatomy, skill use of double lumen use of bronchial blockers, skill use of bronchial blockers, and FOB is required to really. This is a challenging anesthetic field, multi-lung anesthesia of all the fields. Anticipating the patients who will develop hypoxemia and use annular abdominal maneuvers to improve oxygenation. And the third point is monitor airway pressure continuously for possible disorderment and use a FOB if hypoxemia occurs. And there is this connection between peripheral saturation and cerebral oxygen saturation. That is, we are looking for more reports in the future. Pharmacology interventions to correct hypoxemia limited value. And in the unique situation when airway is compromised or multi-lung ventilation is not possible, think of ECMO, which is a valuable option to maintain oxygenation. Thank you very much for your patience.
Thank you, Dr. Thomas. We'll take the questions at the end of the 3 lectures. Thank you.
Good morning, friends. Now we invite our second speaker, Dr. Suresh. He is the lead consultant, Esther, anesthesia and critical care services. He is examiner for MD and DNB in anesthesia, FNB and DM in cardiac anesthesia. He has 56 national and international publications to his credit, and he is ex-secretary, Indian Association of Cardiovascular Thoracic Anesthesiologists. He is a Vice Chancellor of Indian College of Cardiac Anesthesia. He is ex-President, Indian Association of Respiratory Care, and recipient of Lifetime Achievement Award, Cochin Heart Foundation. He will speak on the topic post-operative pulmonary complications after non-cardiac surgery, a multifactorial outcome. Dr. Suresh, please.
Thank you, Chairpersons. And first of all, I would like to thank the organizers for giving this opportunity to talk on post-operative pulmonary complications. As you all know, post-operative pulmonary complications is something that we dread in many of our patients because it can affect the morbidity, mortality, as well as the long-term outcome of patients. It is considered as the most independent predictor of third-day mortality of patients. And in non-cardiac thoracic surgery, it is more common than, as far as the long-term outcome is compared, it is more predictive of long-term poor outcome as compared to cardiac complications occurring during the intraoperative period. Now, what we'll do in the next few minutes, we look at the impact of postoperative pulmonary complications, the pathophysiological factors that occur in the intraoperative period, which leads to postoperative pulmonary complications. We will look at to see whether there are any risk predictive indices which tells us or which can predict postoperative pulmonary complications, and then some of the non-modifiable risk factors, and spend a little more time on some of the modifiable risk factors. The definition and impact of pulmonary complications. Now, a lot of studies have been done on postoperative pulmonary complications in the past, but most of these have been criticized because they have not looked at the entire factors, they have left out the intraoperative factors or the preoperative factors. It has been done in separate subgroup of patients, and the definitions of each of these pulmonary complications has not been very clear. So in 2015, a European task force actually developed clinical guidelines to define what is a clinical outcome. They looked at various aspects, cardiac complications, pulmonary complications, etc., etc. And when it came to the pulmonary complications, they said there are 7 things that you have to look for in respiratory complications, which includes respiratory infection, respiratory failure, pleural effusions, atelectasis, pneumonia, pneumothorax, bronchospasm, and aspiration pneumonia. Now, what they did was that each of these factors were clearly defined. For example, a pulmonary infection was defined as a patient who has been given antibiotics for respiratory infection, opacities in the chest X-ray, counts or temperature, etc., etc. Similarly, respiratory failure was defined in terms of PaO to FiO2 ratio or an absolute value of PaO2. Like that, all 7 factors were mentioned, and they said that when you look at pulmonary complications, look at these 7 factors, and they define the development of adult respiratory distress syndrome, pulmonary embolism, and pneumonia as the individual adverse outcomes for these patients. Coming to the incidence of postoperative pulmonary complications, it's a wide range, varying from 1 to 23%. It is more common than cardiac complications occurring in patients. And among the respiratory complications, respiratory failure is probably the most common reported respiratory complications. And to answer for why we have a range of pulmonary complications ranging from 1 to 23%, the answer is that, as I said earlier, we don't know, the definitions were not clear. It was studied in different subset of patients. For example, cardiac patients undergoing surgery developing a pulmonary complication may be different from a person undergoing a low abdominal surgery. So, variety of situations and poor definitions were the cause. Now, what are the long-term outcome? 1 out of every 5 patients who develop a serious pulmonary complications can die. 90-day mortality is much higher when you have a postoperative pulmonary complication. In fact, a large database which was evaluated showed that the incidence, the morbidity and mortality was significantly higher when the patients develop postoperative pulmonary complications. And morbidity is higher. On an average, a patient who develops postoperative pulmonary complications remain in the ICU for about 13 to 17 days on an average, which means that the cost incurred by the patient or the hospital is much higher. Coming to the pathophysiology. Now, we all know that once you induce anesthesia, there is a loss of cerebral control for respiration, as a result of which you have hypercarbia and hypoxemia as a universal feature, unless you support the breathing with positive pressure ventilation. There are some structural changes that occurs in the lung, in the chest. The curvature, the spine curvature increases. More importantly, the diaphragm gets pushed up. Now, when the diaphragm gets pushed up, there is direct compression of the lung tissue, and in this lung tissue, there are many areas where the airways become compressed or totally collapsed, which means that there is a 50 to 20% reduction in the functional respiratory capacity. The closing volume becomes higher than the FRC, as a result of which there is the air that is trapped, distilled to these collapsed alveoli gets absorbed, leading to atelectasis, and which is much more aggravated by the fact that many of us continue to use 100% oxygen during the initial hours at the end of surgery. Add to this, resulting in an increased ventilation perfusion abnormality, which is further aggravated by 2 things. initiation of IPPV decrease the cardiac output, which again increase the dead space ventilation, and all this add to the preoperative settings for developing a postoperative pulmonary complication. Athlete is something that we are always worried about. About more than 75% of the patients who undergo a surgery lasting for more than 2 hours can develop a significant atelectasis. The reasons, as I have said, direct compression of the lung tissue because of the syphilitic displacement of the diaphragm. There is reduction in the functional reservoir capacity which comes below the level of the closing volume. Absorption of gases from the closed or partially closed alveoli, and this is further exaggerated by the fact that we use 100% oxygen, at least in the later when we reverse the patient in the postoperative period. Now, studies have actually shown that this atelectasis is something very, very important. They have used various models of patients, and they used FiO2 ranging from 1 to 0.6 FiO2, and they showed that if you give 100% oxygen, as much as 10% of the lung tissue can actually be atelectated by the end of surgery, compared to only 0.3% atelectic tissues if you use 60% oxygen. However, this does not mean that you should not be using high inspired concentrations of oxygen, because many surgeons use, there is a theory that if you use high FiO2, the incidence of SSI can actually be reduced. The inference from these two findings is that even a small amount of nitrogen in your inspired gases can prevent the development of atelectasis, because if you actually see the first study, if you use 60% oxygen or 80% oxygen, the amount of atelectated lung tissue is significantly low. So you have certain changes that actually occur in the intraoperative period, and let's see what happens in the immediate postoperative period. Hypoxemia continues to remain a significant factor, because although we have recovered the patient from the anesthetic drugs, the suppressive depressant effect of sedatives, opiates, and the residual anesthetics continue to depress the respiratory center, and which can cause hypercapnia and hypoxemia. One important thing that we always have to understand is the role of the neuromuscular blocking agents. Now, studies have actually shown that even when your patient is clinically as well as neuromonitoring wise completely recovered from your effect of neuromuscular blocking action, it continues to have certain persistent effects. The one is the phasic activity of the genioprosis muscles is lost. More importantly, the coordination between the upper esophageal and the pharyngeal muscles is lost, as a result of which video laryngoscopy has shown that when a patient is actually recovered from neuromuscular blocking and he still continues to have swallowing problems, they actually showed that when the patient swallows, the secretions can actually breach the protectiveness offered by the vocal cords. This is something very important, and please understand that this is not because the muscle power is lost, it is because of subtle changes in speed and fine control of muscle responses which actually result in loss or failure of crucial reflexes. So even if your patient has actually recovered from the effects of neuromuscular blocking agents, the post-operative period, all these patients have got significant chance of aspiration. Coming to the persistent atelectasis, there are some studies which have actually shown that patients who undergo major upper abdominal surgery, the atelectasis does not show significant changes of improvement even 3 days after surgery. It actually takes 5 to 7 days for the atelectated lungs to actually start opening up. And this is reflected in an increase in the alveolar to arterial oxygen tension difference in the postoperative period. The residual effects, I want to talk a few things more about the neuromuscular blocking agents. We all know that in the first few days after surgery, your PEFR or FEV1 remains low. It actually reflects the activity of the expiratory muscles. But more importantly, we have to understand is that once an alveoli actually collapses, the pressure or the force that is required to open up a collapsed alveoli is significantly much more than the normal ventilation. It needs good inspiratory muscle power. Unfortunately, most of the muscle relaxants that we use, almost every muscle relaxant that we use, has a more profound effect on the inspiratory muscles. So in the immediate postoperative period, when the patient is actually not fully recovered, the effects of anesthetics and sedatives are still there, he will not be able to open up the atelectatic zones that is actually developed in the intraoperative period. So the late changes, again, most of the changes that you see in the immediate postoperative period continues. There's an increase in the alveolar arterial oxygen tension difference. The FRC is low, it is less than the closing volume. All all the expiratory parameters remain subnormal for several days after surgery. The entire respiratory muscles, including the abdominal muscles, the diaphragm, everything remains subnormal in the first few days after surgery. And remember, this is not because of lack of muscle power, it is because of more subtle changes or lack of coordination between the different groups of muscles. So all these segments, as I see in this, creates a perfect menu or ideal environment for the patients to develop a post-operative pulmonary complication. So let us see whether is there any risk factors or risk predictive scoring systems that we have at the moment that can be used. Now, I said earlier that lots of studies, when you look at post-operative pulmonary complications, you will come across plenty of studies, but none of this has actually been really useful. Till 2015, when the European Task Force actually said that, okay, we have 7 factors which can be looked at as an outcome measure for post-operative pulmonary complication. But there was one study just published in 2010, which is known as the RISCAT trial, which is actually the assessment of risk in respiratory risk in surgical patients in Catalonia. This was this study I am quoting because they used the same 7 factors which the European Task Force has actually recommended. There was a 2-part study. The first one, they developed a developmental sample to develop a logistic regression, and then they validated these samples. The study involved 2,500 odd patients, and they used the same outcome measure just recommended by the European Task Force. And they found that irrespective of the type of anesthesia, general anesthesia, regional anesthesia, whatever it is, the overall complications with post-operative pulmonary complications was about 5%. Mortality was significantly higher in patients who developed post-operative pulmonary complications, 19% versus 0.5%. And they stratified their patients into mild, moderate, low, moderate, and increased risk. In the high-risk patients, the mortality was actually 43%. And they identified 7 risk factors for the post-operative period. A low preoperative oxygen saturation, less than 90%. Anemia, preoperative anemia, age. Respiratory infection within the last 1 month before the elective surgery. Upper abdominal and thoracic surgery. Surgery duration lasting more than 2 hours. And emergency surgery. These 7 factors were considered as fundamental for developing a post-operative pulmonary complication. In 2015, a second study called the Periscope trial, which is perioperative evaluation for risk of a risk score for post-operative pulmonary complications in Europe. Again, these authors actually validated the RISCAT trial first, and then they tried to develop a new scoring system. Much larger study of 5,400 patients. Overall complication rate was again 4%. Mortality was again significantly higher when a patient developed post-operative pulmonary complications. They also identified 7 risk factors, very similar to that of RISCAT trial, with a few differences. Again, post-operative, pre-operative, low oxygen saturation was significant. At least one pre-operative risk factor, congestive cardiac failure, chronic liver disease, and then come back to same thing, upper abdominal surgery and thoracic surgery, surgery lasting for more than 2 hours, and emergency surgery were considered as definitive risk factors for post-operative pulmonary complications. So let us see a few things about the non-modified risk factors. I'll go through this because there's nothing much we can do as anesthetists. Age, more than 80 years, the chance of developing a post-operative pulmonary complications is about 5 times more as compared to patients who are less than 60 years. But what is actually coming up in a big way is something known as frailty index. Frailty means the functional status of the patient. A lot of scoring systems are actually coming up in frailty score, and they have clearly shown that irrespective of the age of the patient, if the functional status of a patient is low, then the chance of post-operative pulmonary complications is significantly higher. Now, frailty is a topic by itself, so I am not going into details of that. Sinus diseases and long-term excess weight loss are significant factors. The procedural factors, I discuss this in a subsequent slide. Laboratory investigation. We are all very fond of looking at spirometry as a pre-operative index of post-operative pulmonary complication. Please understand that this does not correlate with post-operative pulmonary complication. Now, spirometry requires good effort on the part of the patient. Probably because of that, we are not getting a good index. The hypercapnia ABG is again not predictive of post-operative pulmonary complications. Similarly, a routine X-ray is not indicated But if you find an abnormality on the X-ray, then chance of the patient developing postoperative pulmonary complication is high. So in fact, the NICE guidelines has actually suggested that if you want to do a spirometry or an ABG as a pre-operative evaluation for any patient, it should be addressed or instructed by a senior anesthesiologist in patients who are more than ASA score is more than 3 in the presence of some respiratory issues. One of the important things is that no preoperative oxygen saturation, I mentioned, is a very, very sensitive indicator of postoperative pulmonary complications. Patients who have a saturation between 90 to 96% are 5 times more likely to develop postoperative pulmonary complications as compared to patients who have more than a saturation of more than 96%. And if it is less than 90%, the chance of odds ratio is significantly higher. Modifiable risk factors will go into detail. Congestive cardiac failure, please remember that when you ask, as a separate topic, which Gopi is going to do it today, but what I want to say is that when you ask for a cardiac evaluation, please ask them to optimize your patient and give it back to you. How you give anesthesia, what anesthesia you give has to be decided by you because you are the perioperative physician. You optimize the patient based on the 2016-17 guidelines and then you take him off for surgery. Similar with liver disease. And CNS disease, of course, is something which we can't do except that we can modify anesthetic techniques. Obstructive sleep apnea is increased the risk of postoperative pulmonary complications. Now, these patients already have some hypercapnia persisting in them. The residual effects of sedatives and anesthetics further worsen the things. Their pharyngeal tone is less and they can develop postoperative pulmonary complications. Now, these patients, before you take up for initial surgery, initiate them on CPAP therapy in the preoperative period and in the postoperative period. This should be used. That's the best thing that actually can be done for these patients. However, if the patients also have an additional pulmonary artery hypertension, the chances of prolonged ventilation, respiratory failure, and prolonged ICU stay is significantly increased. Surprisingly, obesity does not correlate with an increased incidence of postoperative pulmonary complication. However, if your patient has got obesity hypoventilation syndrome, then significant complications can occur. Again, the causes is because of reduced FRC, the obesity, the thick chest wall, all this add on to the complications. And these patients again may benefit from postoperative CPAP therapy. COPD, yes, acute exacerbations of the inflammatory response occurs following intubations. These patients usually have colonization of their respiratory tract. They are immunosuppressed probably because of steroids that they are receiving. They have increased work of breathing. But what I want to say is that COPD patients should not be unnecessarily ventilated in the postoperative period. These patients again should be, if they are not already on non-invasive ventilation, they should be trained on non-invasive ventilation. Extubate them as early as possible, and put them on non-invasive ventilation. It works wonders, and delaying the extubation of these patients after the surgery can be very harmful. A recent respiratory infection again is a very significant factor because this is something which we all have to tell the surgeons. Elective surgery, if the patient had a respiratory infection in the last 1 month, if it is possible, please delay because their respiratory function is abnormal. They are immunocompromised either because of the antibiotics that they have given or because of the respiratory infection that is already existing in them. They are abnormal pulmonary function tests. Let them rest, let the respiratory function actually recover. The respiratory functions recover before you take them up for surgery. Smoking, again all of you are very familiar with it. Increased mucus secretion, decreased ciliary activity, increased pulmonary reactivity, pulmonary epithelial permeability is increased. Their immunocompromised state because the macrophages, cytotoxic activity is decreased. All this add on to the complications. Now, a large, huge database from the American College of Surgeons, National Surgical Quality Improvement Program, retrospectively looked at it, and they showed that current smokers have a risk of, significantly high, more than 5 times more of developing a postoperative complication compared to ex-smokers. By ex-smokers, you mean patients who have stopped smoking for more than a year, and the ex-smokers have a greater incidence of complications than non-smokers. The complications increase as smoking severity increase. A 60 pack per year smoker will have higher rate as compared to a 20 pack per year smoker. Mortality also significantly increased among present smokers than non-smokers. Timing of cessation. Now, a person who stops smoking for more than 4 weeks reduces post-operative pulmonary complications by about 23%, as compared to a patient who has stopped for more than 8 weeks, where he can reduce his post-operative pulmonary complications by almost as high as 47%. Now, in the West, they have intensive program which helps them to take them off their smoking habits. This helps in multiple ways, because what they have seen is that if you train these patients to stop smoking, this beneficial habit extends into the post-operative period, and there are multiple studies which actually show that they remain off smoking for as long as 1 year after the surgical procedure. GA and surgery, just two things I want to tell, that every surgery more than 2 hours increase the risk of complications. The odds ratio for more than 2 hours surgery is about, or developing a post-operative pulmonary complication is about 4.9. When it is 3 hours, it goes right up to 9.7, odds ratio goes up. So the only way to counter this is ask a surgeon who is going to a long surgery, a senior surgeon, start from the beginning, and if it is possible to finish the case as early as possible. Ventilation, the all important thing. See, normally when you ventilate a patient with 10 to 10 ml per kg, you produce three things. One is volume trauma, because the large volume which produces stretch of the alveoli, barrel trauma because of the high pressures, and then what is known as atelic trauma, because the shear stress between different alveoli of different sizes causes release of inflammatory mediators. Most of you must have heard about the ARDS network trial that was published in 2001. Probably only one of the two studies which has actually shown a mortality benefit using mechanical ventilation. This study in ARDS patients actually showed that low tidal volume ventilation can actually be helpful in these patients. And what is low tidal volume ventilation? Using 6 to 8 ml per kg, keeping the plateau pressure less than 30 centimeters of water, and an optimal peak. Now, this concept has been accepted into general anesthesia, and let us look at each of these factors. A low tidal volume ventilation has clearly been shown to be beneficial in these patients. In this meta-analysis of 15 studies, they compared low tidal volume with high peak or moderate peak versus high tidal volume ventilation without a peak. And they clearly showed the difference in mortality when you use low tidal volume with different levels of peak. However, this study did not show a major difference between using high peak versus low peak. Now, when you talk about low peak, please understand the tidal volume has to be adjusted according to the ideal body weight or the predicted weighted body weight, and not the actual body weight. Then coming to the peak part. Now, although the low tidal volume has clearly been shown, the role of peak is not very clear even today. Multiple studies that compare low tidal volume with moderate levels of peak versus high tidal volume with no peak has clearly shown that low tidal volume with moderate peak, it reduces the atelectasis, it improves the oxygenation, reduces the post-operative pulmonary coagulation, and without compromising the hemodynamics. So, low tidal volume is definitely useful, but the beneficial effects, remember the beneficial effects of low tidal volume is only when you combine that with certain amount of peak. Now, let us see whether high peak is useful. Again, the Provilo study of 900 patients compared low tidal volume with high peak and recruitment maneuver versus low tidal volume with low peak. And there was no difference in the mortality, 39% versus 40%. But what they showed was that when we use high peak, we produce a lot of hemodynamic compromise, as a result of which patients require more vasopressors in the perioperative period. So, high peak is not useful. A low peak with low tidal volume is what is beneficial. So, how do we ventilate a patient during the intraoperative period? The suggested ventilation technique is low tidal volume based on the ideal body weight. What you target is a saturation of more than 92% during the intraoperative period, using the lowest FiO2 possible, preferably 0.4. Use a minimum peak of 2 centimeters of water. Now, in the intraoperative period, you can have patients with different challenging situations in the lung. In such situations, you can increase the level of free until your peak reaches about 10 centimeters of water, which will not cause any hemodynamic compromise. If more peak is required, then a recruitment maneuver should be used in these patients. So, this is what is required in the intraoperative period. Don't use tidal volume without peak. A small amount of peak is required. Neuromuscular blocking drugs, I have talked a lot about it, but please understand that a TOF ratio of less than 0.7 is definitely associated with post-operative pulmonary complications. And again, what they have found, a close association between intermittent dose of neuromuscular blocking agents and post-operative pulmonary complications when the duration of surgery is less than 2, probably the top ratio becomes less. Just 1 minute. Neostimin by itself can cause post-operative pulmonary complications. Please remember, because it releases more acetylcholine, so it can by itself cause a neuromuscular block. Or the second important thing to remember is that the neostimin has got a duration of action shorter than that of a muscle relaxants, and the weak utilization can occur in these patients. Sugammadex, wonder drug supposed to be, but please remember laryngeal spasm and negative pressure pulmonary edema has been reported with the use of this drug. I'll just cut short this, and the use of nasogastric tubes. We are very fond of putting nasogastric tubes because we feel that the residual gastric volume is less, the aspiration pneumonia is less, bowel function may return earlier. But this meta-analysis of 26 studies with 3,000 to almost 4,000 patients showed that there is a direct independent correlation between the use of nasogastric tubes and post-operative pulmonary complications. The take home I want to tell you is that do not use nasogastric tubes unless it is absolutely indicated. If you are using it for laparoscopic surgery, remove it at the end of surgery. The presence does not in any way increase your gastric motility. It in fact hampers and increases the chance of aspiration pneumonia. And analgesia, we all know, we have been familiar with epidural analgesia. I just want to tell you that the ERAS protocol does not recommend too much of narcotics being used. What is recommended now is regional block. All of us have become experts at doing regional block, ultrasound guided regional blocks. These should be encouraged using local anesthetic and very small amounts of narcotics. So to conclude, there is no single best preoperative scoring systems which can predict postoperative complication. More trials are required using the EPOC or the European Society's recommendation. A low preoperative oxygen saturation is definitely a bad indicator. Modified risk factors have to be optimized before surgery. For example, a CCF or chronic liver disease has to be optimized before you take up for surgery. When you have a upper respiratory infection, please tell your surgeon that this is not a good thing to do. Wait for 1 month, let the respiratory functions return to normal before you take up for surgery. Use regional anesthesia techniques as compared to GA whenever possible. A short duration of surgery should be encouraged. Adequate analgesia and avoidance of nasogastric tubes when possible, and complete reversal of neuromuscular blocking drugs. But even after you reverse the neuromuscular blocking drugs, please remember that these patients are still susceptible to gastric aspiration. And post-operative, I think I missed talking about that. CPAP or high flow nasal cannula prevents the further development of atelectasis in the post-operative period. Thank you very much.
Thank you, Dr. Suresh. It was a nice presentation. We will have discussion after the session.
Congratulations team ISACON 2018 for wonderful arrangement. Next talk is perioperative respiratory depression, causes, prevention and management by Abhijit Das. He is the Assistant Professor of Department of Anesthesiology, Silchar Medical College. He is the founder General Secretary of ISA Silchar chapter. All these two state conferences speak. Abhijit Das. Please come. His founder General Secretary of ISA Silchar chapter organized 2 state conferences, speaker at national and state regional conferences of anesthesiology, has international publications, and is interested in critical care, pediatric anesthesia, etc. Over to you, Silchar.
Good morning, delegates, respected chairperson. At the very outset, I would like to thank the organizer for allowing me to speak here. So my topic is perioperative respiratory depression, causes, prevention and management. When I got the mail from the organizers to speak on this topic, perioperative respiratory depression, I was a little confused. So I was thinking how a patient can go into perioperative respiratory depression. Then I went through many books and journals and all, and I found it. The perioperative period actually starts from the admission of the patient in the hospital up to discharge from a PSU unit. So the perioperative period can be defined as is the time period of a patient's surgical procedure. It commonly includes ward admission, anesthesia, surgery, and recovery. Perioperative may refer to the 3 phases of surgery: preoperative, paraoperative, and postoperative. Although it is better used for the first and third of these only, that is around the time of surgery. The goal of perioperative surgery care is to provide better condition for patients before operation and after operation. The perioperative period is a term used to describe the 3 distinct phases of any surgical procedures, which includes the preoperative phase, the intraoperative phase, and the postoperative phase. The preoperative phase. The preoperative phase is used to perform tests, attempt to limit preoperational anxiety, and may include preoperative fasting. Now, what are the general recommendations in preoperative phase? A mnemonics has been suggested for pre-anesthetic assessment. It runs alphabetically: A for affirmative history and airway, B for blood test and hemoglobin, blood loss estimation, and blood availability and breathing. C is the clinical examination and if any comorbidities. And the D is the drug used by the patient, details of previous anesthesia and surgeries, evaluate investigation endpoint to take the case for surgery. F is the fluid status and fasting. G is the physical status and get consent. So physical status will be given by an anesthesiologist. The second phase or paraoperative phase involves the surgery itself. It starts when the patient is wheeled into the surgical suit and ends when the patient is wheeled back to the post-anesthesia care unit. During this phase, the patient will be pricked and typically given some form of anesthesia, either general anesthesia, local anesthesia, regional anesthesia, or the regional block. The postoperative phase, that is the most important and the final phase of these 3 phases. Postoperative care is mainly focused on monitoring and managing the patient's physiological health and aiding in the post-surgical recovery. This may include ensuring hydration, cardiovascular and respiratory monitoring, monitoring urine or bowel movements, assisting with mobility, providing appropriate nutrition, managing pain and preventing infection. Now there was a survey in France from 1978 to 1982. And it showed that the incidence of death and coma was 1 per 2,400 anesthesia. The 58% complication occurs during paraoperative phase, very important, and the 42% during recovery. So the persons who are responsible to look after the PSU unit, that is an anesthesiologist and the nurse and the residents, they should be always vigilant. And this is a department, that is the PSU, where a patient's morbidity can be avoided. Half of the coma and death are attributable to anesthesia due to post-anesthetic recovery, respiratory depletion. Now, respiratory depletion can be defined as the respiratory rate less than 8 and the peripheral oxygen saturation less than 90 in the PSU. Now, what are the general causes of respiratory depletion? The acute pulmonary edema, ALI, pulmonary embolism, pneumothorax, acute severe asthma, myasthenia gravis, hypokalemia, drug overdose, poisoning, head injury. Now, factors influencing the respiratory function is we should see during preoperative period and intraoperative period. The spontaneous breathing. Functional residual capacity decreases regardless of spontaneous breathing or if the patient is ventilated. It is due to the cranial shift of the diaphragm. The same is responsible for development of atelectasis. Shunt is increased during anesthesia from 1% in awake patient, 11% in anesthetized, button spontaneous breathing to 14% in mechanically ventilated patient. Now, inspiratory oxygen fraction. When FiO2 is increased, shunt increases in direct proportion. When FiO2 is 0.21, the shunt is 1 to 2%, and when FiO2 is 0.85, the shunt is 10%. Oxygenation is less efficient in older patients. CT study of infants shows greater degree of atelectasis. The major cause of impaired gas exchange during anesthesia in younger than 50 years is shunt, and beyond 50 years is VA-VQ mismatch. How regional anesthesia modifies this thing. The ventilated response of regional anesthesia depends on the type and extent of motor blockade. When all the thoracic and lumbar segments are involved, then respiratory capacity is reduced to 20% and expiratory reserve volume approaches 0. Obesity. Obesity worsens oxygenation because of reduced FRC, resting, resulting in early airway closure. In addition to high FiO2 promotes rapid atelectasis formation in alveoli distant to closed airway. A decrease in FRC can be prevented by applying CPAP during induction. Application of PEEP has been advocated to reduce atelectasis. Smoking and lung disease. In smokers and in patients with chronic lung disease, deterioration of oxygen is greater than healthy individuals. In normal individuals, the alveolar capillary membrane thickness is thin compared to smokers and in patients with chronic lung disease. Here I want to mention something. In normal individual, the blood in the capillary doesn't need the whole length of the capillary to get saturated by oxygen and to give out the carbon dioxide in the alveoli. But in patient with smoking history and in COPD, the whole length of your capillary is required to get oxygenated and release carbon dioxide. So these patients tolerate hypoxemia very well. This thickened membrane hampers oxygenation and they tolerate hypoxia badly. Body position. FRC is reduced dramatically in supine position, I told earlier. In the lateral position, differences in lung mechanics, resting lung volumes and formation of atelectasis causes further disturbances of ventilation perfusion mismatch with severe impairment of oxygenation. In prone position, the inhomogeneity of perfusion distribution is less marked, possibly reflecting regional difference in vascular configuration that promote perfusion of dorsal lung regions, regardless whether they are dependent or non-dependent position. Finally, distribution of ventilation may be uniform in anesthetized subject when prone. Atelectasis and airway closure during anesthesia. Atelectasis is an important cause of hypoxia. There is a strong and significant correlation between degree of atelectasis and the size of the pulmonary shunt. Atelectasis develops in approximately 90% of the patients who are anesthetized, unrelated to the choice of anesthesia. You give regional, you give general, you give a block, you give a spinal or a epidural, there is always a chance of developing atelectasis. The atelectatic area near the diaphragm is 5 to 6% in the total lung area, but can easily exceed up to 20%. Degree of atelectasis is larger, 50% of the lung volume after thoracic surgery, cardiopulmonary bypass, that can last for several hours. Abdominal surgery can add little to the atelectasis, but after such surgeries, it can persist for several days. Now, how to prevent? The application of PEEP, 10 cm of water, has been demonstrated to reopen atelectatic area partially. Some atelectasis may persist and may require higher PEEP. A psi maneuver or a large tidal volume has been suggested for reversing atelectasis. However, atelectasis is not uniformly reduced by a tidal volume increase or a psi up to airway pressure of 20 cm of water. Instead, airway pressure of 30 cm of water is required for initial opening and 40 cm of water for complete reversal. This is called hypercapacity maneuver. Inflation pressure with a airway pressure of 40 cm of water for 7 to 8 seconds appeared to successfully open almost all anesthesia-induced atelectasis. The prevention of atelectasis during anesthesia. To prevent atelectasis, anesthesia-induced atelectasis, a PEEP or a vital capacity maneuver is enough, but a continuous application of some level of PEEP is required to prevent rapid recurrence of atelectasis. Nitrogen, an insoluble gas, can splint the alveolus if the alveolus is already open. The B CME maneuver followed by ventilation with a gas mixture containing 60% nitrogen and 40% oxygen reduces the propensity of reaccumulation of atelectasis. Finally, treatment of postoperative hypoxemia considered to be due to atelectasis is associated with better outcomes when CPAP is used instead of 100% oxygen only. The postoperative causes of respiratory depression and management. The Harvard Medical School in 1985 said one anesthesiologist must be present all the time during anesthesia. And recently it is suggested that in the PSU there should be always an anesthesiologist. At least the PSU should be under supervision of an anesthesiologist. The post-anesthesia care unit. The most common early post-operative disturbances after emergence from anesthesia are PONV, hypoxia, hypothermia and shivering. In the PSU, the post-operative complication rate is as high as 24%. The need of upper airway support are 6.8%. The upper airway patency and effectiveness of the patient's respiratory effort must be monitored while transporting the patient to PSU. From operation theatre to PSU, if the people think that our job is over and now the PSU people will take up, this is bad. It should be monitored while transporting the patient to PSU. Now, what are the recovery room incidents? I am not going to all through this. I am concerned about respiratory is 23% and airway is 21%. It is quite high. Upper airway obstruction. The most frequent cause of upper airway obstruction is the immediate postoperative period is the loss of pharyngeal muscle tone in a patient who is isolated, who is sedated or obtunded by sedatives or narcotics. Simply opening the airway with jaw thrust maneuver or continuous CPAP applied via a face mask or both can relieve airway obstruction secondary to the loss of pharyngeal muscle tone. In selected patient, placement of an oral and nasal airway, LMA or endotracheal tube may be required. Overdose of narcotics and sedatives. Depression of medullary center that regulates the sympathetic nervous system can blunt the signs of acidemia or hypoxemia such as hypertension, tachycardia, agitation, concealing, hypoventilation. Special concern is required for obese, extremes of age and in COPD. If hypoventilation from opioid is excessive, forced arousal and careful titration of 20 to 40 microgram at a time of IV naloxone reverses the respiratory depression without affecting analgesia. Flumazenil 0.1 mg titrated to effect up to 1.5 mg directly reverses the depressant action of benzodiazepines. Laryngospasm. During emergence, stimulation of pharynx or vocal cord by secretion, blood, foreign matter or extubation may generate laryngospasm. Laryngeal constriction occludes the tracheal inlet and reduces gas flow. Smokers or tobacco users are at higher risk. Laryngospasm can easily be overcome by providing gentle positive pressure of 10 to 20 mm in the oropharynx by mask with 100% oxygen. Prolonged laryngospasm can be relieved with small dose of succinylcholine, that is 0.1 mg per kg or depending sedation with propofol. An intubating dose of succinylcholine should not be used to break postoperative laryngospasm. Severe laryngeal obstruction can occur secondary to hypocalcemia following bilateral parathyroid surgery. Here I like to mention something. When the vocal cord is closed, forced intubation is not advocated at all. Soft tissue edema. It worsens airway obstruction, especially in children and adults recovering from procedures of NAC. Nebulization and vasoconstrictor helps, but steroids have little effect acutely. Patients with C1 esterase inhibitor deficiency can develop severe angioneurotic edema even after slight trauma of the airway. Now, pathologic airway obstruction. Pathologic airway obstruction, that is severe edema, epiglottitis, retropharyngeal abscess. Any airway encroaching tumors might require emergency tracheal intubation. But airway manipulation is dangerous because minor trauma from intubation attempt can convert a marginal airway to a total obstruction. Sedatives or muscle relaxant used to facilitate intubation can worsen the obstruction by compromising the patient's volitional effort to maintain the airway and by eliminating spontaneous ventilation. Equipment and personnel required for cricothyroidotomy or tracheostomy should be available. Needle cricothyroidotomy using a 14-gauge needle or a commercially available kit permits oxygenation and marginal ventilation. Till the necessary kit persons are available, maintain the patient with 100% oxygen with face mask and reservoir. Small airway resistance. Reduction in the cross-sectional area in small airway increases resistance because resistance varies inversely with the fourth power of the radius during laminar flow and fifth power during turbulent flow. Pharyngeal or tracheal stimulation from secretion, suctioning, aspiration or tracheal tube can trigger a reflex constriction of bronchial smooth muscle in emerging patient with reactive airway. Histamine release by medications or allergic reaction can increase airway smooth muscle tone. Decreased radial traction on small airway reduces cross-sectional area in patient with COPD or with decreased lung volume secondary to obesity, surgical manipulation, excessive lung water. Smokers and patients with bronchospastic condition are at high risk. Treatment is directed at an underlying etiology. Airway or laryngeal stimulation should be eliminated. Patients often respond to their pre-existing regimen. The history should be taken and the pre-existing regimen should be started as soon as they develop bronchospasm. Levoalbuterol, metoprolol nebulization, nebulized in oxygen results postoperative bronchospasm with minimum tachycardia. Racemic epinephrine nebulization relaxes smooth muscle tone with mild tachycardia. Bronchospasm resistant to beta-2 sympathomimetic medications may improve with an anticholinergic medication such as atropine or ipratropine. The residual neuromuscular blockade, my previous speaker told on this. The postoperative airway obstruction and hypoventilation are accentuated by incomplete reversal of neuromuscular relaxation. Residual paralysis compromises airway patency and ability to spontaneous ventilation. The residual neuromuscular blockade may not be evident on arrival of the patient with the PSU, but the diaphragm recovers because the diaphragm recovers from neuromuscular blockade before the pharyngeal muscles do. With an endotracheal tube in place, end-to-end carbon dioxide concentration and tidal volume may indicate adequate ventilation, while the ability to maintain upper airway remain compromised. Patient treated with intermediate or short-acting neuromuscular blocking drugs may exhibit residual paralysis in the PSU. The 10:4 ratio is routinely used to evaluate neuromuscular function in anesthetized patient is unreliable because it is a subjective assessment, especially when performed by touch or visual sensation alone. Pharyngeal function is not restored to normal until an adductor pollicis 10:4 ratio is greater than 0.9. 5 seconds of sustained tetanus of 100 Hz stimulation has been regarded as a more reliable indicator for adequate reversal of drug-induced neuromuscular blockade. In a weight patient, clinical assessment of reversal of neuromuscular block is preferred to the application of painful 10:4 or tetanic stimulation. Clinical evaluation is most important. Often we do it by grip strength, trunk protrusion, ability to lift the leg of the bed, ability to lift the head of the bed for full 5 seconds. The manifestation of weakness in the patients in the PSU may be respiratory distress or agitation. Now, what are the factors that contribute to prolonged non-depolarizing neuromuscular blockade? Drugs, inhaled anesthetic, local anesthetic, cardiac antiarrhythmic like procainamide, antibiotics like polymyxin, aminoglycoside, mitomycin, metronidazole, calcium channel blocker, and dantrolene. Metabolic and physiologic state like hypermagnesemia, hypocalcemia, hypothermia, disease condition like myasthenia gravis, Eaton-Lambert syndrome, idiotic paralysis. Prolonged depolarizing block, excessive dose of succinylcholine or reduced plasma cholinesterase activity. Now, decreased level of plasma cholinesterase is the extremes of age, hepatic or renal failure, malnutrition, plasmapheresis, hormonal changes in pregnancy or patients who are taking contraceptive or the patients on glucocorticoids. So there is rare genetic variants, atypical plasma cholinesterase. The manifestation of weakness in the patient in the PSU may be respiratory distress and or agitation. Prompt review of the possible etiological factors as mentioned and necessary correction to be done. Common factors include respiratory acidosis or hypothermia alone or in combination. Upper airway obstruction due to residual effect of opioids or sedative may result in progressive acidosis. Simple measures such as warming the patient, airway support, correction of electrolytes, abnormality if any, can facilitate recovery from neuromuscular blockade. Now the causes of postoperative arterial hypoxemia. The atelectasis, ventilation perfusion mismatch, congestive cardiac failure, pulmonary edema, diffusion hypoxia, aspiration, pulmonary embolus, pneumothorax, shivering, sepsis, transfusion-related acute lung injury, ARDS, advanced age, and obesity. Monitoring and treatment of hypoxemia. Routine supplementation of oxygen to all patients in PSU is costly and unnecessary practice. So when it is not required, it should not be given. The surgical procedure, the degree of hypoxemia and patient's compliance determine the oxygen delivery system of choice in the PSU. As a general rule, each liter per minute of oxygen flow through nasal cannula increases FiO2 by 0.04, when 6 liter per minute delivering an FiO2 by only 4.4. Maximum patient require oxygen with face mask with rebreathing bag, requiring more FiO2. The newer high flow nasal cannula can comfortably deliver oxygen at 40 liter per minute at 37 degrees centigrade temperature and 99.9% of relative humidity. An estimated of 8 to 10% of the patients who undergo major abdominal surgery require mechanical ventilation at PSU. The application of CPAP at 7.5 centimeter of water pressure is a good way to obtain hypoxemia. In patients with atelectasis, volume overload, splinting from pain, diaphragmatic dysfunction, OSA benefits significantly from CPAP. Patients unresponsive to CPAP may require non-invasive positive pressure ventilation. Now, oxygen delivery system by nasal cannula, if you give a flow rate of 1, the FiO2 goes to 0.2 to 0.2.5, and when it is 6, so it goes up to 0.39 to 0.45. So it is a waste of gas. With simple mask, with a 5 liter flow, the FiO2 is 0.3 to 0.4. Partial rebreathing bag, 10 liter flow, the FiO2 is 0.5 to 0.65. Non-rebreathing mask, 10 to 15 liter, is almost near 1. So non-rebreathing mask is a better option. Non-invasive positive pressure ventilation. Even with application of CPAP in the PSU, a number of patients will require additional ventilatory support. NIPPV has been shown to be a promising alternative to endotracheal intubation in ICU and PSU. But the contraindication of application of NIPPV is the patient who undergone gastric or esophageal surgery, hemodynamic instability, life-threatening arrhythmia, altered sensoria, high risk of aspiration after facial and nasal surgery. Non-invasive positive pressure ventilation can be delivered by face mask using pressure support mode of ventilator. Now, what is the protocol for starting NIPPV? Choose the appropriate patient, head end of the patient to be raised at least 45 degrees. Choose correct size mask, explanation to the patient and reassurance. Set CPAP at 0 centimeter water, pressure support at 10 centimeter water. Hold the mask till the patient is comfortable. Apply dressing to nasal breathe. Secure mask with strap. Slowly increase CPAP. Adjust pressure support to adequate tidal volume. If hypoxia persists, increase CPAP at 2 to 3 centimeter of water until FiO2 is less than or equal to 0.6. The conclusion. The postoperative period begins with the preoperative evaluation and formation of appropriate perioperative anesthesia plan. The time of anesthetic influence respiratory complications. The respiratory risk of a patient must take into account of the pre-existing respiratory disease status. Residual anesthetics, opioid and sedatives all impair responsiveness to increased carbon dioxide and decreasing oxygen level. Pain itself can decrease respiratory or minute ventilation, leading to carbon dioxide retention and hypoxemia. Supplemental oxygen application alone does not guarantee that hypoxia will not occur. Thank you.
Thank you, Dr. Abhijit Das. It was a wonderful presentation. Now we can have the discussion. I request Dr. Thomas Koshi and Suresh Nair to come to the stage. Abhijit, Doctor, you remain the stage. We can have discussion. Please come to the stage. We can have discussion. 1 or 2 questions we can make.
House is open for discussion.
Mike.
Kindly identify yourself and put the question to the speaker.
Working probably. Not working anything. Yes.
Please identify.
I am Dr. Vedugopal from RCC Trivandrum, Regional Cancer Center Trivandrum. So, good morning to all. And nice presentation by all the morning speakers. They are updating their respective fields. I found that the information given by Suresh sir was very useful. Like the problems can occur, perioperative postoperative issues like cardiovascular issues can occur immediate postoperative period. So, sir pointed out certain issues regarding the subtle changes in the respiratory system and muscles recovery during the early postoperative phase. So, I work in a cancer center where we do a lot of major surgeries, prolonged surgeries. So, we most of the time we try to extubate the patient immediately after surgery. So, that critical period can have problem like microaspirations, like cardiac insults like MI or angina can happen. So, don't be in a hurry to extubate patients, particularly following a long case. That you often see problems. So, in the recovery period or in the early ICU period, so don't be in a hurry to extubate. Though the patient looks like adequate muscle power and all, conscious and all, but still they can have go for aspirations and go for cardiac issues in the possible period. So I tell my residents and juniors not to be very enthusiastic on extubating early itself. So good idea. Then I also questions are regarding any role for bronchial diameter checking to select the tube size for DLT insertion. Is there any role in bronchial diameter, left bronchial diameter to be looked into, or this tracheal diameter is zero?
Tracheal diameter you can measure on the CT scan, or if you have a chest X-ray in the PAC system you can measure it easily. Bronchial diameter also one study has shown, but you should know that the practical way of it is what is the oversized tube is if the bronchial cuff inflated with less than 1 cc and there is no leak, that is an oversized one. The bronchial cuff requires more than 2 cc of air, that is undersized bronchial tube. That is a practical way of doing it. Measuring the bronchial diameter, there is a study. I don't remember it exactly, but it is there. But this is a practical way of choosing the appropriate field. If the bronchial cuff requires more than 3 cc of air,
it is undersized.
Next one.
So that's okay. Thank you.
See, unfortunately, there is a strong feeling among the anesthetists that extubating the patients in the immediate postoperative period makes you a good anesthetist. It is not so, because very often we find that most of the patients who undergo, particularly those who undergo long surgery, are hypothermic at the end of surgery. And as I said in my earlier slides, repeat doses of neuromuscular blocking agents. There's a close association between repeat dose of neuromuscular blocking agents and postoperative pulmonary complications. So, what I would advise is if you have a long surgery, get the patient to the ICU, get them warm and fully awake, and then reverse them and extubate. That would be a better way to manage this.
Hello. Good morning all. Myself, Dr. Shumanta Bashmoni from Bardhaman Medical College, West Bengal. Sir, my question is to Nair sir. Sir, you have very nicely presented the concept that the inspiratory muscles are more important in the postoperative period to increase the vital capacity. Sir, can you suggest any maneuvers by which we can preoperatively improve the inspiratory muscle functions, just as we optimize the patients or during the, say, for 5 to 7 days if we have got time?
See, if you look at all the recruitment maneuvers, the recruitment maneuver starts off with a peak level of 40 centimeters, or your pressure control is 40 centimeters, which means that once your annula is closed, the force that is required to open up this collapse valve is very, very high. And in the immediate postoperative period, you cannot, with the muscle relaxants acting more on the inspiratory muscles as compared to extra, they cannot generate this kind of pressures. The only way we can counter that is probably because before we actually extubate this patient, you can do a recruitment maneuver and then take them off the ventilator. Even then, it doesn't prevent, because the moment you take them off the ventilator, alveoli can collapse. But to some extent, you can mitigate the amount of atelectasis that is actually produced in the lungs. The advantage of a long surgery and atelectasis is that you can come to the ICU and on a ventilator just before extubation, you can do a recruitment maneuver and then reverse the patient and immediately put them on either high flow nasal cannula or a non-invasive ventilator.
Thank you.
Good morning all. Myself Dr. Amit Borke from Asian Cancer Institute. My question to Dr. Nair sir, very informative lecture. But the question related to last questions: is there any role of pre-operatively non-invasive ventilation to reduce the post-operative pulmonary complications?
Definitely a role is there in patients who are obese, who those who have obstructive sleep apnea. Definitely, in fact, what I said is that when you have such patients, if you can stabilize them on non-invasive, when COPD patients, you stabilize them on CPAP. They're not already on CPAP. Stabilize them, and then take them take them up for surgery, and immediately put them back on. This is very, very important because COPD is something that we see regularly, and these patients behave excellently, very nicely if you initiate non-invasive ventilation, CPAP therapy or bilevel ventilation in the immediate post-operative period. They do very well, and you don't have to prolong the ventilation just because they are COPD patients and you expect airway problems. Do not ventilate them for long periods of time. Extubate them, immediately put them on non-invasive ventilation. This includes lots of studies on cardiac surgical patients where they have shown that post-operative NIV is a very useful modality.
So pre-operatively?
Pre-operatively, as I said, subset of patients, COPD, obesity and obstructive sleep apnea patients, definitely there is a role. Pre-op stabilization.
Thank you.
Thank you very much for a wonderful session. If there are no questions, we'll conclude the session. Thank you all the speakers.
Good morning, everyone. I would like to congratulate the organizers for having everything in place in time. So we'll start at time. I'll not waste much time speaking. Dr. Jagannath will deliver his talk first. Sir, please start.
Good morning, everybody. I thank the organizers for giving me this opportunity to be here today. Basically, preoperative evaluation is an extremely important phase, and this is more so for patients who have pre-existing disease, and if the disease is a cardiovascular condition, it's much more important. Though the title of this slide is part of the top part is evaluation or assessment, the bottom part is, I'll talk about the bottom part first. Because this is standard, that you have a patient who has a cardiac problem, you tell them get it evaluated. So when you do look at problems, if you see that cardiac patients coming for non-cardiac surgery, almost 42% of the patients the complications are essentially cardiac related. So when you do evaluate, you need to answer some questions. What are the risk factors A? And if evaluation will change further management? And will this favor resolving the cardiac disease so that surgery can be deferred in the meanwhile? And will it change the perioperative mortality, and how will it change the post-operative management of this patient? So if you can address these questions, you need to go through some process. The first process which we talked about was the cardiac consultation. Though we do send all these patients, most of them are sent for a cardiac referral without our asking or without our knowledge of the surgical colleagues. Usefulness of this is very unclear. So, Groot et al. From the Netherlands did a small study last year in which they looked at nearly 24,000 patients, and they saw that out of them, 1% of those patients had gone for a cardiac referral. So they reviewed the patient's problems, the reasons why the patient was referred, whether it changed management, what were the diagnostic tests that were asked for, and also whether this affected the major adverse cardiac events and the 30-day post-op mortality. So what did they find? That the most common consultation cause or reason was a murmur which was picked up with the preoperative period or a pre-anesthetic period. This was about 95 patients. Out of all those patients who were referred, only 6 of them went for an intervention, either cardioversion or maybe a balloon or a surgical exercise. And the average delay before the patient came back for a surgical problem for which he was listed was about 2 weeks. So essentially, an echo was done on all these patients who were referred to see if any further optimization was possible or not possible. And a massive 167 patients, that is 60% plus, patients had no change in their therapy and they were sent back with various risk stratification, low risk, moderate risk, high risk, avoid GA, avoid anesthesia, avoid spinal anesthesia. So that is the kind of insult we get from the consult that is sent for. So why is it so? It is basically because the cardiologists essentially focus on long-term care and not on the specific post-operative or perioperative workup that we ask for. Which brings us to the point that if you do make a referral, please make it clear to the cardiologist why this consultation was sought. So that is very important in terms of seeking a cardiac consultation. Do guidelines tell us anything? Any of the guidelines I looked at, they are not all specific about whether somebody should be referred for consultation A. And there has been no evidence-based criteria which mandates whom should be sent and when it is required and who should do the consultation. So technically what it boils down to, the second part of my title, is that decisions are often left to the discretion of the surgeon or the anesthesiologist. Invariably, the surgical colleagues, what do? They generally say, this patient has come for a workup, it will get cancelled if he doesn't get a cardiac consultation, so get a cardiac consultation. When it comes to us, PAC clinic, you pick up something, and if you are undecided, then you say send for a cardiac consultation, because you are playing safe. So medical legally also, there is probably a small issue here which shall mandate or might say that yes, this patient did not or was not given appropriate consultation, so you are just covering your back. So I will clear the cardiac consultation in that aspect, in the sense that it should be only sent or done when it is required or when we feel it is safe enough for them to do. So what exactly do cardiologists also look, or what can we look for in terms of preoperative evaluation? The first thing that comes up is the risk stratification. So we have a lot of risk stratification tools, among which 3 are very important. So before we do risk stratification, you essentially need to classify what are the surgical procedures that these patients are coming for based on the time available for the evaluation. So it could be an emergent procedure where there is minimal or no time, life or limb saving surgery as we say, less than 6 hours available to us, or you have urgent procedures, limited time for evaluation, between maybe 6 to 24 hours, and time sensitive procedures. This is where it gives us adequate time for optimization. The other first 2 don't give, the next 2 give us time for optimization. So this is where you can change some management which can affect the outcome. And obviously elective procedures, you can delay up to 1 year and get the patient with the best sort of procedure. This also has to take into consideration the risk of the procedure. ACC, AHA guidelines are very clear, low risk, elevated risk, less than 1% is low risk procedures, less than 1% risk for MACE or death or MI. So what are the risk stratification procedures that you can do? The three of them I am going to mention is, one is the revised cardiac index. You have those 6 criteria, and if somebody has cardiac disease, he automatically gets 1 point. Most of them have some other comorbid disease, because cardiovascular disease or endothelial disease is not restricted to the cardiac bed. It involves the entire body. So he could have any of these problems, including high risk. So he automatically goes into the risk of major cardiac event of 0.9% with a range of 0.3 to 2.1. The other one obviously is the American College of Surgeons, the NCQIP program or surgical risk. This has a host of characteristics, 10 of them. So what is important is that this patient looks at number 6, which is the ICD code, ICD-10 code, which is the current procedural terminology code, and also 7, which is the ASS status. So these two are important in terms of risk stratifying patients coming for non-cardiac. The next is the MICA score, or the same ACS NSQIP MICA score. This is an online risk calculator you can use. It's very easy. Just log in and click, and you'll get, you can put in all the factors and you'll instantly get a risk calculator. So the MICA score is basically, again here, it gives about the ASS class. So if you look at MICA and RCI, surgery is the same, dependent functional status, usually a renal dysfunction, ASS stratification, which is not there in the least revised. Increased age is a very important factor in the myocardial infarction and cardiac risk calculator. So these 3 scores are currently the most often used and online available. Are there any other risk factors which need to think of? Yes, atrial fibrillation, if it's present, especially in the elderly, this risk is higher than a diagnosis of coronary artery disease. Obesity, a lot of previous speakers spoke about it. Increased risk for adverse cardiovascular events. But what is uncertain is whether the preoperative approach should be any different from normal patients. Dr. Nayak did tell us that they were less at risk for, or not at higher risk for post-op pulmonary complications, but this might be for those with a BMI of less than 35. The other risk factors that he also mentioned, or we should be thinking about in current day times, is frailty. So frailty is a very important aspect in today's life, and obviously obstructive sleep apnea, which we do not think or consider on a normal basis, these also become risk factors for perioperative cardiac risk. So what we standard now follow is the 2014 ACC/AHA guidelines, and this is what I'll sort of allude to in the next coming slides. So in the cardiac disease part, you have 2 problems. One is the coronary artery disease, and the second is heart failure. Dr. Mahesh will talk about the heart failure part of it in the next lecture. So if you have coronary artery disease, the rate of post-op MI decreases as time passes, and if an intervention has been done, and this gives improved 30-day mortality. And non-cardiac surgery should ideally be performed at least 2 months after an MI if there has been no intervention. And if somebody has had a recent MI, it is a very independent risk factor for perioperative stroke and has a very high mortality of 8-fold increase in mortality. So anything which is less than 6 months, if he has had no intervention, kindly avoid doing any anesthetic experience for that patient. Heart failure, active or history of heart failure, higher risk, and compared to coronary artery disease, which is about 3%, non-ischemic heart failure or ischemic heart failure have a very high risk in terms of almost 9.3% of complication rates, the 30-day post-op mortality. Same thing applies to EF of less than 35% if the patient has no symptoms. Diastolic dysfunction without systolic, again associated with higher incidence of MACE. So anything related to the heart and dysfunction, both systolic and diastolic, you have very high rates. So you should evaluate all these. So how do you go about evaluating? One is subjective. So if you look at the subjective status, the first thing you ask is, what are we able to do? You ask them, are you able to do your normal routine? Are you able to climb a flight of stairs? Are you going shopping? So the patient tells you, yes, I can do all that, but I'll come to it later. This has to be taken with a pinch of salt. Subjective assessment of functional capacity always has to be put into proper perspective. So we normally look at good functional capacity, low risk of adverse events. And obviously metabolic equivalence is how we look at it. poor metabolic is less than 3, moderate is 4 to 6, good is 7 to 10, and excellent is more than 10. So we generally don't bother about those in the good to excellent, we are worried about the poor to moderate. So obviously less than 4 METs, very high risk of post-operative complications. So patients with good or excellent functional capacity, more than 4 METs, and those at low risk procedures do not require any further testing. If somebody has less than 4 METs, pharmacological stress testing is recommended so that you can optimize or manage them better. And those with a positive stress test, what can you do? You can improve, that is, you can do revascularization, or you can change the surgical condition to an alternative surgical exercise. Maybe it can be medically managed. So this is how you should approach a patient, or you can suggest, see, we are perioperative physicians, so we are as good as anybody else, and we are equally good at talking to or discussing if you have appropriate evidence-based guidelines and risk management strategies. So this is what I was alluding to, Lancet a couple of months ago. Assessment of functional capacity. So this was a MET cohort study. They looked at subjective assessment, and patients had a very low sensitivity, 19% for evaluating or identifying inability for 4 metabolic equivalent with cardiopulmonary exercise testing. So subjectively assessed functional capacity should not be used for preoperative risk evaluation. Please put them to some further testing. So the message is asymptomatic patients undergoing non-cardiac surgery, low risk of perioperative MACE, high functional status, no further evaluation. What about ancillary tests? ECG, if they have known coronary artery disease or any other cardiovascular bed, you can go ahead except for low risk procedures. So routine use of post-op preoperative lead ECG, not useful, not recommended. But still, every patient more than 45 has a rhythm strip in it. Assessment of LV function, both systolic and diastolic, any unknown cause of dyspnea, or in patients with heart failure or worsening dyspnea, or a change in clinical status. So it is reasonable to assess the LV function. And if it has been more than 1 year since you had it, it is reasonable to reassess. But routine evaluation, not recommended. Exercise stress testing, patients who have unknown or poor status, less than 4 METs, reasonable to assess functional capacity. Those with excellent exercise tolerance, like I said, no need to just proceed for surgery without testing. So routine testing is not recommended. So how do you know that this person had a positive stress test? You look at the J point, and at some time points on the ST segment, so a depression of 0.1 or an ST segment sloping of plus minus 1 millivolt in 3 consecutive boots is what you look at. I don't have a pointer, but you can easily make out that's J point, and you assess the magnitude of ST depression on your ECGs. The importance is that first you look at the maximum heart rate the patient can develop, and that is basically the heart rate is age minus 220. So age minus 220. So this is basically as a safety measure during the stress test, and second is estimates the adequacy of the stress to evoke inducible ischemia. The idea of knowing this value is that this sets the limit that you should not exceed during the perioperative. If he has manifestations say at 120, that is the perioperative cutoff that you should not exceed at any point in the perioperative. If the patient achieves 80% of his maximum, predicted maximum, it is excellent, and more than 90% is better or even more excellent. Coming to other evaluatory strategies, echocardiography, so many things you can screen, transthoracic, pericardium to endocardium. Cardiac output, valves, LV, regional wall, chamber dimensions, pulmonary hypertension. So any of these you can always look at. So what are we interested in systolic function is the LV function, basically EF more than 45, mildly reduced 45-54, moderately reduced, and these two, the last ones would be the ones which are problem patients for us. Again, regional wall changes, you have to look for normal hypokinesia, severe hypokinesia, akinesia, dyskinesia. So any of this information is so useful for us to tell us that this patient is probably not in good shape, especially those who are asymptomatic. You will find that a lot of these patients, suddenly you do an echo and you have a poor ejection fraction. Yes, it could be subjective on the cardiologist side, but still. And these are some couple of representative videos that are there: apical hypokinesia, anterior wall, and basically apical hypokinesia. And more important, in every patient beyond 35 to 40 years, please do evaluate diastolic dysfunction. I'm sure Dr. Mahesh is going to talk on it very elaborately, but this is what we are interested in. The E by A ratio is usually E is more than A, and deceleration time is more than 150. And in patients who have restrictive cardiac dysfunction or poor compliance, you have delayed relaxation, E becomes less than A. So if you just look at this value of diastolic function screening, when a cardiologist gives you, it gives you a lot of information about the patient's systolic as well as diastolic dysfunction. So diastolic is as important a phase as systolic. So what further can we do for these patients, or however can be estimated or evaluated? Pharmacological testing. Basically, pharmacological testing, poor functional capacity for elevated risk non-cardiac surgery. It is probably better to do a vitamin stress or a perfusion scanning. Only if it changes further management. So screening is not recommended for those with low risk surgeries. So what do you look at during the stress regional wall mode changes? So you can look at both the systole and diastole. And dobutamine is preferred rather than dipyridamole, which is used mostly for the radionuclide imaging part. In a normal perfusion study has a very high negative predictive value for perioperative MI or cardiac death. So in these terms, stress cardiography or echo is slightly superior in predicting the post-op cardiac events. Radionuclide image is sometimes looked at if the patient has very poor LV function. So the tracer, which is usually technetium per technet 99, areas of ischemia absorb less tracer, so it shows as a defect or a fainter image than the surrounding myocardium. So a second scan done for after a few hours, it will tell you if the ischemic area is reversible or is restored. So just a couple of images, which is all normal, you see completely filled, there are no defects. Whereas if you see the next one, you will see a defect in the inferior wall, and here there is a fixed defect. So this is how you look at this radionuclide image to see if it helps any further. Maybe we won't order this, but if it's available, you can always look at it. So interpretation being that presence of moderate to large areas of ischemia predict the increased risk of MI or death. So a normal study, again like stress, the dobutamine stress has a very high negative predictive value for perioperative. So where do we use this to, at least the stress echo? So you can use it in some patients say coming for high risk surgeries. So angiography definitely not recommended unless the patient is going for a kidney or a liver transplant. So a cardiac patient coming for solid organ transplant, this is where you would probably ask for a coronary angiogram, because that is also considered as non-cardiac surgery. So typically the left one is normal, whereas you can see some blocks in those arrows pointing to blocks, same here. And sometimes you may come up with this particular value on the angiographic screen, which is the study followed the thrombolysis and myocardial infarction study. So 0 is complete occlusion, whereas TIMI-1 flow is penetration of obstruction by contrast but no distal perfusion. TIMI-2 flow is perfusion of entire arteries there but delayed flow, whereas TIMI-3 is normal. So TIMI-1 at 0, 1, 2, probably 0 would be a person going for thrombolysis or something, but TIMI-1 and 2 is a problem for us. So right now it's a fashion, everybody goes for a CT angio. So CT angio is good in the sense that it is safe and less invasive alternative to coronal angio. So how does this look to us? So this is how it looks to us. Basically you have calcification in various territories, LAD, LCX, mid-LAD segment, and they give you a calcium score in each of these. So basically if you look at the calcium score, it has a good risk stratification. It's a good risk stratification tool of in risk for the next 10 years. Originally about 5-6 years back it had a validity or shelf life of 5 years. Now it has been extended to a full 10 years following much more evidence. So these are the risk implications of a coronary angio, CT angio. So if it is 0 calcium score, there is less than a 1% 10-year risk of a cardiac event. So it is a very low risk. Whereas if you have 400 or greater, the 10-year risk is 24% with a very high risk interpretation. So, but right at this moment of time, we have very limited data regarding significance of CT angio and calcium risk scoring for risk stratification in the perioperative. But as a tool, this is the risk for cardiovascular disease or events. So this brings us to the next one, cardiopulmonary exercise testing. which is also known as cardiopulmonary stress testing. So this is a topic which we don't talk about normally in terms of routine cardiovascular evaluation. The basic thing is that it tests the functional capacity of the whole patient, including the ventricular system, respiratory system, cellular function, so respiratory pathophysiology. So most of the other tests or other tests we know assess only one organ. So the abnormalities that are not apparent at rest are frequently revealed when you do a CPET. So this is better for prognostication and other therapeutic options, especially when they come with thoracic surgery. So the current recommendation is that it is a class 2B recommendation with a level of evidence of B as far as the ACC-AHA is concerned. So there are a lot of tests that you can do in a CPET, almost 10 of them, but we will only look at a few of them. One is the VO2 max, or the maximum aerobic capacity, and this is defined as the highest oxygen uptake despite work rate increment. So even if you give up, like Bruce protocol, you keep on increasing the exercise. So it defines the limit of cardiorespiratory response to exercise, and the mortality is very closely related with peak VO2. So peak VO2 is basically a way of quantifying METs. So you quantify METs, 1 MET reduction is 15% increase in mortality, which is patients with a peak VO2 of less than 14 ml have a worse prognosis. So the other part of the CPET is the anaerobic threshold. So anaerobic threshold is the point at which aerobic metabolism is no longer adequate and anaerobic metabolism takes over, and this is the point called the AT, or the anaerobic threshold. So it defines the onset of a supply-demand mismatch in muscles leading to lactic acidosis. So if you look at this graph, the VO2 starts less than 1, the VCO2 starts more than 1, and a point at which it diverges is called the anaerobic threshold. And this is what, that point is what is important to us. VO2 max is usually expressed as a percentage of the maximum oxygen uptake. So if we have 50, it is normally about 50 to 60 of the VO2 max, and values below 40% are indicative of severe exercise limitation. This is something which is used exclusively or quite often in assessing patients these days, more so for patients who have had lung surgery or one lung ventilation or thoracic surgery, as we talked about in the first lecture today. So at 80 of less than 11 kilograms and 8 milligrams has very poor and extremely poor post-operative outcomes. So the interpretation of data being that VO2 max is equal to cardiac output multiplied by the AV oxygen difference. So one has to understand that as the VO2 max changes, the cardiac output also increases accordingly. So cardiopulmonary exercise testing is a very important tool in the preoperative evaluation of a cardiac patient coming for non-cardiac surgery. So this brings us to something entirely different. Can I use something else? Biomarkers. What are the biomarkers available to us? Troponins and proBNP and anti-proBNP. So elevated values preoperatively definitely corresponded with increased risk of post-op cardiac complications. So you can probably club this with your Lee's index and then come up with something. But at this time, their use in preoperative risk stratification is unclear. But the Canadian Cardiac Society has come up with an algorithm like this. So if you have patients older than 45 years and or those within or less than 45, you can look at the troponin values. So if they are more than 300 or if they are more than 300 or BNP is less than 92, you measure troponin daily, obtain electrocardiogram in the post-anesthesia. So you can use this algorithm with biomarkers also, but right now it doesn't fit into any evidence-based guideline. Maybe the next one, which is due next year, 19, the ACC-AHA after 5 years, might include this. So what are the strategies that you can adopt? They can be surgical strategies to risk or pharmacological. So among the strategies, surgical, coronary revascularization, not recommended except as per guidelines for acute coronary syndrome. But for those who have time-sensitive procedures where you have a few weeks to do this, a bare metal stent or just a balloon angioplasty can buy you a lot of time and can be a preferred way of management because they are not an antiplatelet, so they might not require to have any deaths or any other things. So those with already established or having a stent, you have all your BMS surgery within 30 days, yes, delay, no proceed, yes please. Almost finished, last couple of slides. So the other ones of course are currently is we don't wait for 1 year, you finish off, or you can at the end of 6 months on death you can do it. Pharmacological strategies, antiplatelet, continue aspirin, anticoagulants, risk benefit for bleeding, beta blockers, continue on chronic beta blockade, but if tests suggest that he is at risk of ischemia, please consider restarting or starting beta blockers. Statins continue. Vascular surgery, there is a new trial called the LOAD trial. Yes, it does not show benefit, but for those for vascular, you might try it. Perioperative dysrhythmias, Holter monitoring might be prescribed. Those who have implantable devices, the very presence indicates that he has got significant cardiovascular disease. So obviously everything related to that, cautery, type of surgery, programming. So interrogation of the device and procedure of reprogramming should be followed in the perioperative period. So this is the final slide where it's the same algorithm, for the ACC one. So if you have step 1 risk stratify, we as ACS do something, assess MACE. Fourth step is assess functional capacity and if required do stress testing. So to summarize, one has to be very careful when you are asking for the potential benefits of a consultation, because at times it can lead to further testing, unwanted testing, more expense to the patient and more delay in the surgical experience. So perioperative cardiovascular evaluation has utmost significance and it improves outcome and reduces health costs, but the benefit is only in a specific group of patients undergoing high risk or high risk procedures, and routine use in low risk is of no benefit. So what is important is, please use established guidelines, prescribed guidelines to determine the best approach possible. Thank you for your attention. Sorry, I see the time.
During the preoperative assessment that we have to come through. There are major issues between cardiologists and cardiac anesthetists, because what we want is cardiac opinion and they don't give opinions, they give advice.
Yes.
So we are stuck up in a lot of patients that are delayed because of that. That is a different topic of debate altogether. We don't fall into that. So we'll take a few questions. One maybe because we have run out of time, so only maybe 2 or 3 questions we will be taking.
Yeah, my opinion is basically that yes, if the patient has an established ischemic heart disease, is on management, current practices of maybe whatever, if you talk about the medical legal implications, as an anesthesiologist, am I qualified to start a further treatment modality for the patient or advise another intervention? In which terms, with established ischemic heart, if he is at risk for a high risk procedure, I would definitely ask for a clearance from a cardiologist in terms of risk assessment.
Now we have the mic, please, for the questions. Anybody having the mic?
Already established ischemic heart, I am saying.
See, in an established ischemic heart disease patient, like coming for a herniorrhaphy, if PCI or CABG is not needed, then how you are going to proceed? You want a clearance from a cardiologist?
No. Established coming for a high risk procedure. The idea is basically it is not, that's why I said clearance basically, because I am not asking for an opinion. What we want is basically in case it requires an intervention in the middle of the surgery. Basically, if he wants to have, if he need to have, maybe if he has a perioperative MI, if he has a let me say not clearance.
That is, then I accept. Thank you.
Yes, please. No.
But simultaneously, if he has a MR, then your AF value.
Yes. This is not the scope of this. Obviously, MRs are always, the EF is always overrated. So just to clarify that, for a normal patient, yes, if we say 0.5 is the normal EF, 0.5 above. In patients with a valvular incompetence, especially at the mitral level, 0.6 and above is supposed to be normal. So less than 0.6 is abnormal in patients with an incompetent mitral valve.
Okay, I think with this we close down this first talk, and I must confess, this is last note after this.
Good morning, sir. I just want to know if there is a patient of bilateral osteoarthritis knee and has a history of diabetes and hypertension, but ECG is normal. Then how should we evaluate the patient?
I just don't know. I mean, I was told at I just put this exact slide as a case example when I was in the preview room. it just vanished from my presentation here. This is the same scenario I put, and this is typical. Why I put that was basically because, like I said, the functional status evaluation subjective is very bad. ECG being normal is nothing, because somebody who's 70-year-old cannot walk, he's not stressing himself. So an ECG which is normal without a stress, which is unable to do, is impossible to assess. So these would be absolutely fantastic candidates for a stress echo. The dobutamine stress. So dobutamine stress is supposed to be the best way of evaluation, because physical Bruce protocol they can't do. So a pharmacological stress you should ask for in these patients, especially with the background of hypertension and diabetes. So I just put that case study. It didn't come here. Sorry. It was meant to be same situation.
Okay, I think I must congratulate Dr. Gopinath and thanks a lot. It was really a exhaustive account of this wonderful talk. Now, without wasting time, I will call upon the next speaker, Professor Pravat Tiwari. Oh, sorry. So yours is last.
Next speaker is Dr. Mahesh. He doesn't require too much of introduction. He is a well-known figure. He has done his MD from EMC Manipal. He is in the institution at Shri Ramachandran Institution of Higher Education. Areas of interest are pediatric cardiac anesthesia, anesthesia for patients with cardiac diseases or non-cardiac surgery, management of difficult cases. He has many publications, almost 10 international, 40 national publications. He is also the past secretary and past president of ITA. He will be speaking on evaluation and anesthetic considerations of patients with right side heart failure and non-cardiac surgery. It's a very interesting topic. Sir, please.
Yeah. Thank you, Chairperson, for your kind introduction. A very warm good morning. I was a little surprised when I actually got this topic from the organizers to be dealt with. It's not very common that we see in CME programs to be asked to talk about exclusively on the right heart failure and non-cardiac surgery. Well, as an anesthesiologist, it's a little difficult for us to understand why is that we should look at right heart failure in independency, apart from the regular heart failures that we talk about. Right heart failure, normally you should remember that it definitely can complicate the non-cardiac surgery. It also influences the mortality and prognosis. It creates a situation where it can lead to a left heart failure later. We'll see it in the next slides. As I already said, it is also a very important key determinant in cardiac surgery, though that will not be discussed in my topic today. It determines outcomes in patients with pulmonary hypertension, probably the most important precursor condition that probably which produces the right heart failure. To begin with, I would probably talk about a very important concept in cardiac physiology. Whenever we talk about cardiac function, we need to remember the heart works in series. Heart has two ventricular chambers. I'm teaching very basic physiological stuff, but no anesthesiologist should never forget this particular concept. Otherwise, you will not understand why right ventricular failure is such an important topic to understand. Heart has two ventricular chambers. One is right heart and the left heart. The left ventricle and right ventricle, actually both ventricles work in tandem. It's called they're connected in series. They do not work in parallel function. That means the cardiac output of one ventricle becomes the preload of the other ventricle. So the right heart ejection fraction, if it drops, it affects the preload of the left ventricle. Similarly, the left heart actually has a dysfunction, it affects the right heart preload. So that's how they work. But there is another important factor that for all of us need to understand. It's a very peculiar thing, Right ventricle, as long as it's working in normal conditions, it works as a passive conduit. It does not majorly contribute to the systolic function or the ventricular functions of the heart. Whereas as soon as there is an increased offload to the right ventricle actually forms, the right ventricular function becomes a very important determinant factor in maintaining the active part of the circulatory homeostasis. You will understand this when I actually talk about the next 3 slides about the 2 or 3 important things that you need to understand for the right ventricular pathophysiology. To understand this, you need to understand a little bit on the anatomy and physiology of the right ventricle. You need to remember that right ventricle is slightly different in shape from the left ventricle. Left ventricle is ellipsoid, whereas the right ventricle is triangular. It is thin walled, it is 2 to 5 millimeters, versus the left ventricle, which is 7 to 11 millimeters. And it has poor contractile reserves. It is much more susceptible to apoptosis whenever it is faced with a challenging situation than the left ventricle. That means the chances of the right ventricle to fail when it is faced with the challenging scenarios, whether it's ischemia, afterload or anything, the chance of failure of the right ventricle is much higher than the left ventricle. Well, if you see this, that's what it is. If you see it very carefully, the right ventricle is a very crescentric ventricle and not unlike the spherical shape or ellipsoid shape of the left ventricle. It's very, very important for you to remember. So every time you enter into an operating room and you're handling a case with heart failure, you should remember the right ventricle is not a circular ventricle, not spherical or ellipsoid. It is a crescentic ventricle, and whereas the left ventricle is a spherical or ellipsoid in shape. The quick differences between the right ventricle and left ventricle, the end-diastolic volume, if you see here, both are same, 75 ml and 66 ml, almost similar, whereas the thickness is 2 to 5 millimeters and 7 to 11 millimeters. That means right ventricle is at a structurally disadvantageous situation than the left ventricle. If you look at the ventricular elastance here, can you have a better pointer, please? If you look at the ventricular elastance, it's about, almost about 1/4 of the ventricular elastance of the left ventricle. So it's a very important thing to understand. The reason why we can get away with this situation in normal life scenarios is because if you look at the pulmonary vascular resistance or the systemic vascular resistance, there it's about 1100 on the systemic vascular resistance, whereas the pulmonary vascular is 70. So basically, the right ventricle is able to get away with a disadvantageous situation that it is present. It is basically because it's actually working against a low resistance pulmonary circuit. When you actually look at the Frank-Starling's relationship mechanism between the right ventricle and left ventricle, you can't make anything different. If you look at it absolute terms in terms of the graph. But if you actually look at the moment you look at the x-axis here, if you see the right ventricle and the right, if you look at it for a given preload, the right ventricle is at a very, very disadvantageous situation. The left ventricle is much more effective and efficient than the right ventricle for a given amount of the preload and afterload management. So what happens, it's a very important step. What happens if the right ventricle faces an afterload situation, increased afterload situation? These dotted lines are not which are yellow in color are for the left ventricle, and if you look at the x-axis, as the afterload or the pressure increases, the cardiac output of the left ventricle does not drop too much, whereas the right ventricle cardiac output drops drastically down when the afterload increases. The moment your afterload is increased on the right ventricle, it does not have the compensatory mechanisms too much to actually compensate so that the right ventricular output actually drops. So if you actually look at this graph, if you look at this bottom graph, if you constantly keep increasing the pulmonary artery pressure, at one point of time, the right atrial pressure shoots up a lot and then the cardiac output drops. So whenever you see a patient, the reason I put this slide is for all of you to remember when you see handling a patient with right ventricular dysfunction or right heart failures, if you see a patient with a high CVP in those patients, remember the chance of these patients having a perioperative collapse or hemodynamic issues will be very high. If you find that the CVPs are okay, you probably may not have so much of a problem as you are dealing with a compensated state. Well, when you look at this is normal, as I said already, it is a crescentic shape, and then there is a spherical shape of the left ventricle. But if you find the afterload is increased in an end diastole, there is a squashing of the left ventricle, the right ventricle actually increases in size. In end systole, there is a much more squashing. This is an important topic that we need to remember, is what is called a ventricular interdependence. The moment the right ventricle faces an increased afterload, septum, always remember this again, another important dictum, septum belongs to the left ventricle. Septum does not belong to the right ventricle. So the moment the right ventricle's afterload goes up, septum is actually pushed into this. So the left ventricle becomes crescentic. and then the right ventricle becomes spherical and becomes, it impedes the left ventricular function in many ways. It impedes its systolic function, it also impedes its diastolic function, it impedes its preload filling, and the preloads actually drop. This is actually what is called a very important phenomenon in right ventricular failure, which produces severe low cardiac output. This phenomenon is called the pathological interdependence of the right ventricle. Well, it's a paper that's published. We all know that the right ventricular dysfunction has been associated with increased mortality in cardiac surgical patients, in the cardiac surgical patients, in the non-cardiac settings, and in the ICU. In all three settings, it actually increases the mortality. There are three conditions that are basically associated with right heart failure or right ventricular failure. One is the decreased RV contractility. There is the right ventricular volume overload, and then there is the right ventricular pressure overload. The right ventricular contractility can be affected because of the right ventricular infarctions, or right-sided cardiomyopathy, or perioperative right ventricular injury. And the right ventricular pressure overload happens in situations where you have a pulmonary embolism, or even cases with left-sided cardiomyopathies, pulmonary stenosis, pericardial disease, persistent pulmonary valvular diseases, and left-sided valvular heart disease, pulmonary hypertension, and ARDS. And the right ventricular volume overload you find in patients with tricuspid regurgitation, pulmonary regurgitation. You have both decreased RV contractility and pressure overloads in sepsis, post-cardiac transplants patients. You can have all three conditions in patients with adult congenital heart diseases coming from non-cardiac surgeries. When you have an intracardiac shunts, you can have right ventricular volume load and a right ventricular pressure load. If you actually look at how the pathophysiology generates, when there is an increased right ventricular outflow, there are three important pathological mechanisms that develop. There is an increased RV dilatation, decreased right ventricular stroke volume, and increased RV wall tension. That leads to the increased RV dilatation leads to increased tricuspid insufficiency, and increased transperial pressure, pericardial constraints. Tricuspid regurgitation leads to high CVP, increased congestions of all your solid organs, most of your abdominal organs. And then the transperial pressure actually and pericardial constraint leads to leftward septal shift. As I said, ventricular interdependence gets affected. Decreased left ventricular distensibility and elastance, that leads to decreased left ventricular preload, that increases the left ventricular end diastolic pressure, decreases the left ventricular cardiac output, decreases the blood pressure. The decreased right ventricular stroke volume also leads to the decreased cardiac output. And wall tension, increased wall tension on the right ventricle increases the oxygen demand, produces right ventricular ischemia, and decreased cardiac output. All of them actually works like a vicious cycle. One of the important things that happens whenever your the right ventricle actually starts failing is not only decreases the cardiac output, it also initiates a vicious cycle of decreased cardiac output, decreased blood pressure, and coronary perfusion for both the ventricles starts coming down. So coming to the pre-anesthetic evaluation, you can divide them into symptoms, signs, and risk. Symptoms would be fatigue, dyspnea, chest pain, syncope, associated symptoms or comorbids. Signs is severity of the signs of the right and left sided failures. You might find both right and left sided failures in these patients. Assessment of organ condition, you should focus on this. Intravascular volume status is another important thing that you need to specifically focus in the patients with right ventricular failure. Risk is assess the risk severity in terms of modifiable risk factors that would optimize patient's condition. Well, one of the important evaluation is ECG. You find that there is a right axis deviation, tall always in V1, V2 signifying the right ventricular hypertrophy. You also sometimes find the peak P waves, right axis deviation, as I said, the dominant RV1 and inverted P waves in V1, V3. Wide P waves signify the right atrial enlargement, which again indirectly signifies that there is a right ventricular dysfunction or an enlargement. Chest X-rays, always remember, when you find a chest X-ray like this, the base of the heart is formed by the right ventricle. If you find a right hilum like this is the right pulmonary artery, the left pulmonary artery, they all give you an indication that there is a right heart dysfunction on a pre-op chest X-ray which is like this. Diagnostic evaluation, you can follow this algorithm of a suspected RA failure associated with pulmonary hypertension, history and physical ECG, chest X-ray, echo. There may be no evidence of pulmonary hypertension. It can echo if in case there is a left heart disease or a valvular heart disease or a congenital heart disease. Serology and autoantibodies in patients with liver function tests, thyroid function tests, and other lab tests. If you have a patient presenting with collagen vascular disease, HIV, liver and thyroid diseases, PFT and chest for parenchymal lung disease, chest CT for parenchymal lung diseases, chronic thromboembolic disease, you need to do a perfusion, lung perfusion scans, and sleep study in case if you find a patient with pulmonary hypertension and sleep apnea, then you may have to do a sleep study. And right heart catheterization sometimes in patients. I just put this slide for you to give you a small list of what are the possible investigations that you may have to think about in patients who are presenting to you an overt failure. As Gopi talked about, the PNP is a very important biomarker. Sodium gives you an indication that there is an increased risk with a less than 136, creatinine, C-reactive protein, transaminases signifies, elevated transaminases signify the liver congestion. Biochemical markers, increased lactate levels, elevated natriuretic peptides, cardiac troponins, abnormal liver biochemistry, abnormal renal function, D-dimers levels in patients with pulmonary embolism. It's very, very important. Whenever you find a patient with right heart failures coming compensated or decompensated, remember one investigation that we forget to do is D-dimers. Please get into a habit of actually getting the D-dimers done in these patients. Well, you have multiple echocardiographic findings. You should focus on these findings when you find, because you normally omit these findings in looking at the preoperative echo when you look at the right heart failure. One is the pericardial fluid. It is more than 5 millimeters in diameter. The RV wall thickness more than 5 millimeters. IVC diameters more than 21 millimeters, and with inspiration collapse of less than 50%. TAPC is a very, very useful parameter in the echo to find out about the RE function. Less than 17 millimeters signifies the problems. Intraoperative management, you can look at using in the invasive arterial blood pressures for patients with RE dysfunction and pulmonary hypertension can be probably indicated. Central lines, major surgical procedures, you can insert, it's useful for administration of the vasopressors and nanotropes. Pulmonary vasodilators, it also helps you, gives you a trends in CUP, helps you in preload optimization and volume status. For all major surgeries with RA dysfunctions, probably both monitorings are indicated. Pulmonary catheter, I do not really suggest because it's probably not very useful. You know that most of these patients might definitely have a high pulmonary pressures and pulmonary vascular resistance. And then in the presence of high PA pressures, your pulmonary or left-sided information that you get on pulmonary catheters is not useful. If you have the opportunity or the facilities available, it's extremely useful inside your inside your operating rooms for major surgeries. Coming to the anesthetic techniques, the general anesthetic, you have probably three choices, RA and MAC, depending upon the type of the situation. Impact of the anesthetic agents and interventions and pulmonary vascular resistance and RE functions are probably the most determining things. Your goal should be to maintain the RE preload. The one important thing that if you're entering into an operating room with an RE dysfunction patient on board, one important thing that you need to remember is to make sure that you have an RE preload perfectly there. You have to have a well-filled right ventricle inside your patient when you are dealing with RE dysfunction. Of course, RE contractility has to be maintained. You should always focus on minimizing your pulmonary vascular resistance and avoid RE hyperperfusion. Neuraxial blockade, remember it can acutely reduces the systemic vascular resistance and drops your preload acutely. So anything that you actually do, suppose for example it's a high subarachnoid clog, you can actually have problem with your preload. So decreased preload and systemic perfusion pressure is always will be a problem in patients with more problem in patients with RA dysfunction than in LA dysfunction. Adverse impact on RA because it has an adverse impact on RA perfusion function. Gradual drug administration, invasive monitoring and vasopressors, you should always have them as a plan. Titrated LA for the local anesthesia for the epidurals is probably the best choice. Target minimum block level necessary for procedures. Vasopressors should be used for hypertension very early. General anesthetic, you have choice of both inhalational and intravenous. Remember, inhalational anesthetics worsen the RA dysfunction. It can reduce the preload depending upon the type of the inhalation anesthetic used, especially a drug like something like a halogen or isoflurane. Afterload, it can also reduce afterload. Isoflurane can reduce afterload and contractility. Nitrous oxide, remember, can increase your pulmonary vascular resistance. So it's probably avoid nitrous oxide in patients with RA dysfunction. Etomidate is probably your intravenous anesthetic of choice in these patients, less hemodynamic changes. Remember, thiopentone actually drops the preload significantly, probably not indicated. It can also decrease the contractility. Role of ketamine is probably should be reserved only in patients with severe RA failure, completely decompensated, coming for emergency surgeries maybe. Ventilation versus RA dysfunction. I think one important point to take home from this lecture is about probably this. You should always remember that your pulmonary vascular resistance is lowest at the functional residual capacity. That's very, very important, ideally. That means if you have a collapsed lung, your PVR is high. A hyperinflated lung, your PVR is high. So minimize your plateau pressure, minimize your PFs. Rate of inspiratory pressure rise should be slow. Maintain your normoxia and normocardia. That all these things will maintain your PVR low. So you should always focus on the type of ventilation inside your operating room in patients with RA dysfunction. Very often, if you have a bad ventilatory parameter set, that itself can lead to a RA dysfunction inside the operating rooms. So early extubation should be a focus because IVPV decreases venous return, increases PVR, impairing on the underlying vulnerable heart. So postoperative ventilations are detrimental. Postoperative ventilation is detrimental to the heart, right ventricle function. What about the pneumoperitoneum? It produces, remember we all know that it produces hypercarbia, it is bad. High peak pressures is required and PEEP is required for ventilation, so it's bad. The effects of Trendelenburg position will be bad on the RV. RV preload is reduced and RV afterload is increased. So in effect, pneumoperitoneum should be avoided in patients with RA dysfunction. If somebody is asking if you have on the verge of an RA failure, about to decompensate, a patient you are trying to anesthetize, if they want to do a lap, please tell the surgeon it's not highly advisable to do a lap on those patients. Well, coming to the recommendations for the patients in terms of the interventions, this is just a slide, something which you suggest. You can actually differentiate a patient with RA failure, with pulmonary hypertension, with severe PH without RA failure, and severe pulmonary hypertension with right ventricular failure. So by and large, you have lots of anesthetic agents. As I said, etomidate is probably the best. Desflurane or sevoflurane could be used. Nitrous oxide should be avoided. Just of it. Use the PS is not very useful. Pulmonary catheter, invasive blood pressure monitoring, and CEP are useful. Coming to the pulmonary vasodilators, I think there are three important drugs in this table that would be very, very helpful for us. One is sildenafil. Now IV sildenafil is available, so you should actually have it in your operating rooms. Prostacyclin is also very, very useful in these patients. The third one is the nitric oxide. Coming to the pharmacotherapy for the perioperative right ventricular failure, you can use your vasodilators, as I already said, nitric oxide, iloprost, milrinone, and sildenafil. You have to use your vasopressors very, very judiciously, especially if you use drugs like milrinone or levosimendan. So you should probably look at having your drugs like noradrenaline and vasopressin. There is a small advantage of using vasopressin in patients with high PVR because vasopressin actually would help in reducing your pulmonary vascular resistance. If you ask me honestly, most of the times if you ever have to have a situation of using inotrope, prefer adrenaline at low doses. But if it is not enough, if you have to add anything, then you can think about milrinone or levosimendan. If it is an overt right ventricular dysfunction, you are actually handling a patient with severe failures. Levosimendan is a good drug for right ventricle. It's a better usitropy than milrinone in many effects. But you should mandatorily add. We normally add noradrenaline for levosimendan, definitely mandatory. But ideally, in patients with severe pulmonary hypertension and high PVR, I would suggest you add vasopressin directly to levosimendan to maintain your systemic arterial pressure. It's very important. Coming to the, this is just a kind of a final slides, one of the final slides for me. The right ventricular failure, it just gives you just of it gives you, if he has an excessive preload, then you talk about volume reductions in diuresis and ultrafiltration. If there is an excessive afterload, you correct the factors that increases the pulmonary vascular resistance, hypoxia and hypoxemia, acidemia and hypercapnia, abnormal lung volume. Three things that you need to remember. Hypoxia, hypercarbia and abnormal lung volumes actually seriously affect the right ventricular function. So decreased RF perfusion, there is a low cardiac output, reverse systemic hypertension, decreased right ventricular wall tensions, decreased RV contractility, maximize myocyte function or heart functions. Look at the metabolic. Very often, the moment you find there is a hypertension, you find the cardiac output is low, we actually do not look at if there is any metabolic changes. So keep following the lactates on these patients because that gives you a very good indication of your cardiac output. So if there is RF failure is resolved, if it is not resolved, look at extracorporeal lung supports or lung transplantations. Of course, that's a very late stages of RE failure. Postoperative pain management, postoperative management, you should look at the control of pain, preload, heart rate, and systemic blood pressures and ventilation and temperature. Oral agents such as sildenafil should be restarted. Remember this always, because if you anesthetize these patients and you leave and you do not remember to actually make sure that your sildenafil or any of the pulmonary vasodilators these patients would have been on before your surgery or not restarted, they're bound to have a rebound pulmonary hypertension. So it's very careful, you should be very careful about it. Chronic regimens, in case if there are any for the treatment of pulmonary hypertension, should be restarted. One important point to remember again, most of these patients would have been on an anticoagulant. So remember, you would have definitely stopped these anticoagulants. Remember these patients to be started on anticoagulants in post-operative stage because they have a very high risk of pulmonary thromboembolism post-operatively until 72 hours. The moment you find very often patients who anesthetize with right heart failures, actually you'll get a call at 48 to 72 hours that this patient has started ambulating, has gone to a restroom and collapsed and died in a ward. This is very common things that happen. So one of the reasons is the surgeons would not have started them back on the anticoagulants. Extubate, yes, it should always be the goal. As I said, postoperative ventilation is bad for these patients. If there is no intraoperative hemodynamic instability, hypoxia, hypercarbia, I think you should extubate at the end of the procedure. Require ongoing infusion or inhalation of a pulmonary vasodilator agent sometimes. Continue controlled mechanical ventilation and cardiopulmonary function until it stabilizes. If the patient does have no intraoperative event, you can actually extubate. If there is an intraoperative event, maintenance of your cardiac perfusion or systemic output, cardiac output takes the precedence over your ventilation or the issues that you have with ventilation. So you should ventilate them for post-operative optimization. Just as a conclusion, I would tell you there are three things that you need to remember to take home as a message. One is preload optimization in patients with right ventricular failure. Then there is an offload optimization. As I said, I already talked to you about the hypervolemia and hypovolemia limbs. Hypovolemia can be because of the RV infarcts and you have to consider a fluid bolus challenges, and then you can actually have a goal of CVT of 8 to 12 millimeters. If it is hypervolemia limb, then you need to look at the use of diuretics or ultrafiltration. Offload optimization, you should look at basically pulmonary vasodilators. And RV contractile support, you should have looked at all the other drugs that I talked about, epinephrine. Remember, epinephrine, vasopressin, levosimendan as the anatropes that you should have a recall and make sure that this is not levosimendan is not a regular anatrope that you keep in your operating rooms, but you should remember when you actually have the patient getting anesthetized for the right ventricular failure. Thank you so much.
Thank you. Very excellent presentation. Now we can have a couple of questions, if any.
Any questions, please?
If not, I would like to have a little query. That do you have any personal experience of using levosimendan? Levosimendan in this kind of patient setting? Yeah.
We use it in cardiac cases quite often.
Okay. And alloplast spray or nebulization?
Yeah, I mean you can both use in both routes. IV prostacyclins are available and also inhalation routes. Inhalation is probably better in patients with reactive pulmonary hypertension.
Okay.
And it's much faster. Its systemic effects are much less with inhalation.
Okay. Yeah.
Sir, excuse me. Sir, hello.
Please come on the mic. You have a question.
Sir.
Dr. Rajiv, please, there is somebody asking a question. You can ask her.
Sir, during intraoperative period, how will you suspect that RV is failing? Except,
one of the important things that you could think about this reason I talked about the CUP trending. If it is a major case, definitely you should put in a central line, as I said, central venous pressure, and look at your trends of the CUP. Number 2 is your systemic pressures actually will start dropping. When your systemic pressure drops, it's not necessarily the left ventricle is actually getting affected. It's the right ventricle, which is, as I said, interventricular dependency. Your septum is being pushed, the left ventricular preload is getting affected. That is the reason why you have a systemic hypoperfusion. A patient with RA dysfunctions, compensated, you're anesthetizing, they're fine, and then you suddenly find intraoperative hypertension is happening, lactates going up, CEP rising, sign of RA failure.
Dr. Rajiv, you
Sir, yeah, I did mention about the TE there, sir. Actually, TE is extremely useful in case if you have. Even if you don't have a TE inside your patient and your operating rooms at the time of the start, in case if there is a hemodynamic issue, as what sir is asking, if you have a TE, you should probably put in a TE and ask for help at that particular point. It gives you fantastic information. It's a real time. You actually know what exactly is happening to the patient. Definitely.
Normally, I would like to add a bit. Normally, whenever we are doing a cardiac assessment, the main focus is on the left ventricle. And right ventricular normally you don't focus that much on that. And this definitely plays a major role. So P waves, excess deviations in the ECG, and your cardiac, your left ventricle, right ventricle, dilated right ventricle, all these things should not be overlooked. They should be properly evaluated so that we don't get stuck up in the surgeries and post-op surgeries. Thank you very much, Dr. Mahesh, for a wonderful presentation.
Now we call upon the next speaker, Professor Prabhat Tiwari. Very important topic, cardiomyopathy and anesthetic challenges. He needs no introduction because he is very popular in the circle. He is a cardiac anesthesiologist. He has been the past president of ACTA. He is presently editor-in-chief of Annals of Cardiac Anesthesia. And he has already delivered more than 400 guest lectures. So I request him to deliver the topics.
Thank you, Colonel Singh. Well, I thank the organizers of this meeting for a wonderful venue. And of course, we are in Taj Nagari. So, well, yesterday evening's Valentine has probably made everybody a Valentine. Well, okay, so let's go ahead with patients with cardiomyopathy. Well, we know now that how you actually work up your patients who present with cardiac problems. Well, what is so unusual about cardiomyopathy? Is it so rare? Today, yesterday I was moving with a junior colleague, here in Agra, and he was doing a case in the morning. And he is a trained cardiac anesthesiologist. So why he was concerned with that? Because that patient has cardiomyopathy. It means it is not common. If you see or look into it, then you will find that cardiomyopathy is a force to reckon with. And there are many patients roaming around as they come for your own anesthetic implications. So let's see what cardiomyopathy is. Can we have the lights off? Lecture will become more enjoyable. Well, whatever echo clips you find here in this presentation, they are of my own patients, right? Try to cover up the machine company name because I do not want to actually advertise for them. Few images were taken from internet.
Put the lights up, please.
And my travel registration and stay in Agra is actually given by our institution. Well, so when we have a patient with cardiomyopathy, what are the ultimate consequences? right? Well, it is actually a maze of diseases. I'll tell you what it is actually. But the final outcome is either systolic dysfunction or diastolic dysfunction. Now, these two are two different things. Systolic dysfunction means your heart is probably weak enough to pump out blood, enough to carry on day-to-day functions of all the organs. It may be a toenail as well, right? Perfectly proper. Diastolic dysfunction because this heart has to fill up. If it doesn't fill up, it will not throw out the required amount of stroke volume. Therefore, this heart has to relax, and then it will fill up. That is what diastolic dysfunction is. And when a patient develops cardiomyopathy, actually these two functions get affected severely, right? And they, in total, is called as heart failure. That at the end of its tenure of this kind of heart will need a heart transplantation. Now, when you have these kind of patients, there are certain complications which you must always remember. One is the heart failure. That may be because of left ventricular overloading. Overloading means it is full of blood, volume. And it may develop various gradients inside. Gradients means some pressure loss. Now that will affect its function. Why cardiomyopathy develops? So what actually happens? What does it do to the structure of the normal heart? It actually remodels it, changes in shape and size. And what it leads to, because it is not what has happened during the development of the heart. It has occurred afterwards. It causes arrhythmias primarily. It may develop valvular pathologies. And then all may culminate into low cardiac. And a stroke, of course, means ischemic stroke because of low stroke. Now, whenever you have this kind of patient, how these patients actually present? Well, effort intolerance is the prime thing. See, we always go for ECG and chest X-ray. But whenever your patient says, well, he has got effort intolerance, means if he walks, I get tired, right? ECG X-ray, well, that may be routine, but always ask for echocardiogram because you want to look into the heart and it's really functional. And you look into the function evaluation, there is a whole battery that evaluates its function, both systolic as well as diastolic. You do not miss the valves. You ask the cardiologist to tell you about the valves also. Is there any regurgitant lesions? Because regurgitant lesions are very common to develop in these patients. And when they develop, they just increase the overloading of the heart. We were talking about that the heart is overloaded. And these regurgitant lesions of the valves, they just further overload the heart, increasing your problems in perioperative period, right? And these patients, supposing they already have a long-standing cardiomyopathy, they might be having pacemakers, sometimes they may have a desynchronization therapy pacemakers, right? Or automated cardiac defibrillators, right? Because of arrhythmias. Life-threatening arrhythmias coming with that. So, when we talk about cardiomyopathy, what are the basics of perioperative? Pre-op preparation has to be meticulous with a proper understanding of the disease, what kind of cardiomyopathy you are looking into. And that I am going to actually touch and go today so that you can understand. Knowledge of drug therapy, especially the AC inhibitors and receptor blockers. Because these are anti-remodeling drugs. All the patients with cardiomyopathy will be taking these drugs, right? And they may cause hypotension when they interact with your anesthetic agents, right? And your patient is already fasting. So that reaction is more profound. Regional or general anesthetics all need to be practiced as an art based on sound physiological principle. In this case, you have to listen to the heart. What heart demands. That is how you are going to actually weave your anesthetic fabric around this kind of heart, right? Hemodynamic monitoring is essential, but don't say no blood pressure monitoring. No, even that is good. If of course the functional class is more, right, 3 and 4, then you think about invasion monitoring, otherwise not. Point of care ultrasound, if you have got, it may be helpful to see throughout the course of this patient. You may need infusion of certain drugs. And one more thing, I asked some of the private practitioners, and what they do, they give regional blocks, and once the skin suturing is being done, they just move away to other patients. A very common practice in this Uttar Pradesh, you see. So never leave the side of the patient being armed. At any time, arrhythmia can come. Patient may die immediately. He was behaving very well, but it dies, right? And post-operative care, you see, cut down on any stress. That is very important. And at least 1 nurse has to look after this patient for that much of time till he is with you. That is very important. So, what is that? Means these cardiomyopathies, right? They are really come in different characteristics in them. And we are going to look into those one by one. So what are the pathophysiological types? It may be a dilated cardiomyopathy. Here mass has increased. Now this dilated cardiomyopathy could be a global general variety, right? And one of its offshoots is non-compaction variety. Forget about that. Don't go into that. It's not for you. It could be a regional dilated cardiomyopathy, right? What we call as a Takotsubo cardiomyopathy. I'll show you what it is. Then the other major part is hypertrophic cardiomyopathy. So dilated cardiomyopathy, hypertrophic cardiomyopathy. Here also the mass has increased. There may be restrictive cardiomyopathy, right? Mass may not increase. It may only be a restrictive cardiomyopathy. And of course, the right ventricle has got one cardiomyopathy, right, associated with it, what we call as the arrhythmogenic right ventricular dysplasia. So quickly we go through these. Now dilated cardiomyopathy, always remember this is a normal heart. Normal heart is a bullet-shaped heart with a narrow apex and the broad base. Always remember, when your pump starts dilating, it starts dilating from the apex. Because true apex of the heart does not have muscle. There is no muscle in the true apex. Why? Because heart is actually a woven muscular bands. Right? So the true apex has no muscle. Therefore, heart always dilates from the apex. And it may take the shape of an apple or a tomato, depending on how fast and how much the dilatation has taken place. Okay? So that is what a dilated cardiomyopathy. And it is commonly seen in dogs. It is a dog cardiomyopathy, dilated cardiomyopathy, especially the Doberman variety, right? They die off most of the times with dilated cardiomyopathy. Okay? Now, here it is. You can very well see here, this is the left ventricle, hardly moving, totally dilated, and even apex is dilated. So this is a dilated cardiomyopathy. Another picture, you can very well see here, another huge dilated cardiomyopathy, and with right ventricular dilatation as well. And here you can see, LV is hardly moving, and shows here that there is some spontaneous contrast here in left atrium. And why it is coming? It shows that there is stasis in left atrium, means the blood actually is not flowing into the left ventricle. It is already dilated. It is already working at the peak of the pressures, peak of the volumes. It can't accept more blood from left atrium, right? And you can see it has affected the right ventricle as well and affected the right atrium as well, right? Ejection fraction is only 26%. Alright, so this is again a very severe case of dilated cardiomyopathy. When we are looking at the heart in the transaction, you can very well see it's hardly moving and severely dilated left ventricle. Here, this dilatation causes what? I say regurgitant lesions of the MR. Always ask the cardiologist, tell me about, quantify the MR for me, right? That is very important. So here it is, you can very well see here, what has happened. LV has dilated and is throwing back into the blood into the left atrium. I'll show you why it happens. So in dilated cardiomyopathy, dilated there is increase in mass. Alright? Increased volume, the end diastolic volume, and therefore the end diastolic pressure. Contractile dysfunction is always there, right? Myocardial wall is normally or it may be thick. Dysynchrony is there. Means all the wall, though it may look that they are moving in a sync, they are moving, all of them are moving in a synchronized fashion, but actually it is not so, right? And arrhythmias and various kinds of bundle branch blocks, they develop and they further affect the total output of the stroke volume. Now what is this syndrome? This is one of our patients, you see. And here in this area, you can see here, this is not working very well. We make a 3D model, right? Systolic, the outside wall, the cage is the diastolic volume, and inside this cast is actually the systolic volume. So we can very well actually corroborate how much is that. And here, the ejection fraction is around, I think, 44 or 45%, you see. And this area, this region is hardly moving. So that is how you can actually corroborate with this one. And what dysynchrony means, you see, you think that this patient is doing well, you immediately jump on an inotrope. Inotrope means either dopamine or adrenaline, most common cheap, right? They can be used, and usually people think about that. And look here, when you give some inotropy to this heart, dysynchrony means every wall is moving in its own. They are not contributing to a common end result, and that end result is the stroke wall, right? And you can see here, every line depicts one of the walls here. There are at least 17 segments of left ventricle. That is how we divide. And every segment is, after putting the inotropy, is moving on its own. The stroke volume falls further down, right? If you use inotropy in these kind of patients. And if you look into these, if we evaluate them further, right? Then you find that, well, things are becoming good. Why? Because we have removed the inotropes and started inodilators. What Mahesh told you, right? Dobutamine, bilrinol. You add that and you find things are falling back. You are achieving your stroke volume. So that is how, if you have knowledge of what cardiomyopathy is, it becomes easier for you, right? And you can see here, severe mitral regurgitation has developed. Now, why this develops in a cardiac dilatation, which is a cardiomyopathy? Because it increases problems. Whatever you do, you are not able to actually decongest this left ventricle. Because when you are dealing with a dilated cardiomyopathy, the first and foremost thing is you decongest this area, and things will become nice and easy for you, right? And this reinsufficiency is not able to let it be done. Why it is happening? I told you. In dilated cardiomyopathy, if this is normal, it starts dilating from the apex. So what happens? You know, left ventricle has got two papillary muscles. Papillary muscles give chordae tendineae. And chordae tendineae hold which valve? The mitral valve. When this area is moving out because of dilatation, the papillary muscles are moving out. They are pulling the chordae tendineae like this. And it is pulling the mitral valve into the left ventricle, right? Even in systole, this mitral valve doesn't go back to the normal place. So what happens? Then it remains open. And the blood volume from left ventricle, instead of going into the aorta, which is called as the stroke volume, actually leads back into the left atrium, right? So it is not contributing to the stroke volume. It is increasing the resident volume of the left ventricle. Now that is fact. So what are the NS that give you? They do not tolerate slow rhythm. Always remember, when you have a patient of cardiomyopathy, always look at the or take heart rate in your stride. Right? Heart rate will do wonders in management of your patient having cardiomyopathy. Those who have dilated cardiomyopathy, they do not tolerate slow rhythm, right? So always keep them fast. They do not tolerate arrhythmias, okay? They like reduced systemic vascular resistance. Why? Because if you reduce the resistance, every will throw more into the aorta instead of throwing backwards into the left atrium. So reduce your SVR, and that is what dilators are doing. Judicious fluid use, right? Very important. Means you have to fill them up, right? Do not jump on the dilators immediately. Fill them up. Your patient might be fasting. Give them enough fluid. Calculate and what you want, give them. Don't fear that you give fluid and the heart will bloat further. No, it's not like that, right? They are used to work on the upper part of the Frank-Starling curve. They know it, right? So, judicious fluid use is there. Early use of cardiotonic, especially the iron dilators, right? Do not like a scaling of blood pressure. If the patient is at around 60 mean or 70 mean, you just keep that pressure like that. Don't try to increase the pressure, because pressure is actually the shadiest thing to happen in these kinds of patients, because that will just decrease the perfusion and also the coronary perfusion. Not too bad to handle during anesthesia, but try not to topple oxygen balance, right? Either general anesthetics or regional anesthetics, dilated cardiomyopathies do well. The regional anesthesia is also well taught, right? And there are certain predictors of the poor outcome. Well, there are lots of things. If you have arrhythmias, if you have actually increased age, if you have other of the laboratory findings like hyponatremia, right? If in electrocardiography you find your patient have left bundle branch block or any kind of other heart block, then it is a problematic patient. Okay, you have to sound your cardiologist or send your patient to a center where you have good cardiology, cardiac anesthesia services so that they can manage this patient well. Well, the other one is if you have coronary artery disease, if you have increased cardiothoracic ratio, right, and very high left ventricular dimensions, well, all these things are there. And of course, cardiopulmonary exercise testing, well, it is very rarely done. And so, if you find that the oxygen uptake is reduced, all those things are there. And luckily, if your patient has sometimes in the past has got intracellular, this endomyocardial biopsy, and if you find that there is enormous loss of intracellular elements, and you get the report, then you discuss that with your patient. So that is about, in a nutshell, the dilated cardiomyopathy. Now, regional dilated cardiomyopathy. Actually, it is called what you call as the taco soup, and it is also a stress cardiomyopathy. Well, what is this? This is a normal heart. When the heart becomes pear-shaped, right, means only this area dilates. The basal area works very well, normally. Then it is actually a regional cardiomyopathy, which is called the Takotsubo. Takotsubo is a Japanese word. They use this basket to catch hold of octopuses, right? And it is like this. So naturally from there, this word has come up, that the Takotsubo cardiomyopathy. It is actually a regional dilated cardiomyopathy, which is stress induced, okay? And you can very well see here, one of our patients, you can see, if you get every angiogram, you can very well see here, this area moves out, and when this area contracts, means the basal area contracts, the middle part and the apical part of the left ventricle actually bulges out. So that is actually regional cardiomyopathy. Well, commonly in postmenopausal women, well, young persons may be involved. It is, well, exact etiology is not known, but hormonal misbalance and genetic predisposition, people say. Well, there may be raised thrombin, diffuse ST elevation may be there, low blood pressure is there, and these patients have to be kept in ICU, and well, complete recovery is there. That is the best part of this regional cardiomyopathy, right? And you can very well see here what emotional physical stress is actually doing. It is a kind of disbalanced, especially the action of catecholamines on the different beta receptors of the left ventricle. And they act in this way. The difference is that basal beta receptors, they are causing contractility, whereas the apical areas, they are not causing contractility. See, they are causing a negative inotropy. And probably this disbalance is causing it. But it is, the best part is, it is actually the totally reversible coronary microvascular dysfunction. You give this patient 4 to 8 weeks, and it will just go away, right? Management, normal coronaries, they may present like angina and MI, right? In perioperative period. Treatment, well, you can give aspirin, beta blockers, EC inhibitors, and diuretics, okay? And short-term anticoagulation. Anticoagulation is very important in cardiomyopathy. Why? Because if the blood is not moving out of LV the way it should, right, there is a stasis, and when there is a stasis, there is formation of thrombus. Always remember, right? Hormonal therapy, well, you can't, still we don't know. And person may develop immediately before surgery, right? Because he is stressed, she or he may be stressed out, or post-surgery in the wall. So keep suspicion of this variety of DCM in your mind, right? Patient may be unnecessarily having severe dyspnea and all that, was operated in the morning, you go in the evening and look after him, and you find patient is unusually dyspneic. You put the stethoscope, there may be some trends, right? Immediately ask for an echo. You may find a regional cardiomyopathy. It is good for the patient. Next one, hypertrophic cardiomyopathy, right? This is the normal heart. And usually, the wall thickness is less than 10 millimeters. But if the wall thickness moves up, like an avocado, you will find that it becomes a hypertrophic cardiomyopathy. You may say hypertrophic cardiomyopathy. Oh, we are getting lots of more cardiac cells, myocardial cells. Our heart is very strong. An athlete's heart. This is actually, it may be an athlete's heart, right? Well, it's not too good. It's the only one which is congenital or acquired. In young age, if you have a cardiomyopathy, most often you may have a hypertrophic cardiomyopathy. Well, this is the heart of one of the patients, and you can see here, septum is so thick, right? It is around 22 millimeters. It has really gone. Hardly there is cavity, right? This is hypertrophic cardiomyopathy. So what happens? You can very well see here. In this specimen, the septum of the left ventricle is extremely thickened, very thick, very thick. And what it causes? Primarily not systolic function, primarily the diastolic dysfunction. Very difficult for this heart to actually accommodate ample amount of blood volume. And why it is so? Why there is a relaxation problem? If you take a new balloon and try to fill it, right, you will put in lots of effort. And once it starts dilating, then your effort goes down and balloon really comes out very well, right? Very beautiful. So similarly, to begin with, it is a restriction and gradual. But here in hypertrophic cardiomyopathy, that balloon actually never gives way, right? You keep on filling in, it will never stretch out like a balloon. Fact is this. So we are looking at some kind of filling parameters. So how do we measure whether heart is actually just filling or not, right? Well, we look into the mitral area and see what is what. Always ask. This is one of the best parameters. Ask the cardiologist, he will tell you what is going on. Nowadays, cardiologists are also doing the tissue Doppler imaging, a very good parameter, right? It is not affected whether patient is fasting or not. Means it is not affected by your volume. We are measuring, looking at it as one of our patients, we are doing tissue Doppler imaging, and actually it is not dilated. And you can very well see here how we can see how the muscle is moving. So, in hypertrophic cardiomyopathy,
sorry to interrupt. Sorry to interrupt. Very good session going. So please try to sum up as soon as.
Yeah, just one or two. Let me go ahead because we have a lunch afterwards. Increased LV mass, thickened LV walls, normal or decreased left ventricular and diastolic volume, normal or slightly decreased systolic function. Okay, systolic function may be normal, ejection fraction may be normal. Severely compromised diastolic filling, myocardial ischemia, inside LV mid-cavity gradients. See, these are important. I was talking about the gradients. So when we talk about gradients, actually we talk about hypertrophic cardiomyopathy. So actually here, what are the consequences of hypertrophy of the heart? Elevated interventricular pressure, prolongation of ventricular relaxation, increased myocardial wall stress, right? Increased oxygen demand. You increase the wall stress, oxygen demand goes up, and decrease forward cardiac output. Clinical presentations may be dyspnea exertion, angina, syncope, right? And all these things. And important thing is sudden cardiac death. You know, athletes, they die suddenly. It is because of the developed hypertrophic cardiomyopathy. And here also, mitral regurgitation develops. But the action, why it develops, it is different than dilated cardiomyopathy. The problem here is, because the septum is extremely hypertrophic, it pulls mitral valve into its output, and therefore disfiguring of mitral closure occurs, and therefore MR develops. Here is the example. You can very well see here the anterior motion of the mitral leaflet towards this severely hypertrophic septum, and it causes mitral regurgitation. And you see here, if your patient has got obstruction, then actually you are affecting its lifetime. And well, these patients are usually treated with calcium channel blockers, beta blockers, right? One of our patients, mid-cavity gradient, see, such a huge hypertrophic LV. It's 68, that is the gradient inside the cavity. This heart will never fill up. And always remember I said, ejection fraction may be normal in this type of cardiomyopathy. So how to ascertain that myocardium is affected? There is one more parameter, and that is called the spectral tracking. Nowadays, gradually cardiologists are going into this direction. They will tell you about what is happening to the strain, right? So this is longitudinal strain, and this is actually the radial strain. And it immediately tells you that your heart is sick. Well, disease progression, there may be sudden death, AF, symptom progression, and instinction, right? So, anesthetic implications, do not tolerate increase in HR. Always remember, do not tolerate hypovolemia, tolerate rising blood pressure, do not tolerate inotropy, light cause of constriction, difficult to handle during anesthetic environment, central regional anesthesia is poorly tolerated. Quickly, restrictive cardiomyopathy. Well, this is a normal heart. This is actually your acrote, right? Very hard shell to eat. So this is restrictive cardiomyopathy. A cat cardiomyopathy. Cats are actually predestined to have this kind of cardiomyopathy. Alright? And they said that there is always a cat has 9 lives. Probably. If you live for 9 lives, you will die with restrictive cardiomyopathy, of course. Probably that's it. It's a rare entity. Always occurs. We cross beyond the age of 60, we all will be having restrictive cardiomyopathy. Sporadic or familiar form, normal or decreased volume of both ventricles, biatrial interval, severe diastolic dysfunction. Okay? This is a normal heart, but it has severe restrictive problem, right? It's one of our patients. Physiology, left ventricle normal size, left atrial pressure rise, high heart rate is normal rate, no tolerance to liberal fluid infusion, develop pulmonary congestion immediately, not much intolerance to fall in systemic vascular resistance, right ventricular enlargement canal. Anesthetic implications, just like hypertrophic cardiomyopathy. Do it, right? Lastly, arrhythmogenic right ventricular dysplasia. You can very well see here right ventricle is involved, one of our patients, right? Well, clinical features, right and both ventricles may be involved, right? There may be total dysplasia, there may be total fatty infiltration. Important thing is, look at the post-QRS complexes, right? This may have some kind of unusual electrical impulses, what you call as the epsilon waves. So epsilon waves, whenever it is present, always try to look into if patient has got this kind of cardiomyopathy. Implications, RV needs supports, immunodilators, beta blockers and diuretics. Reluctant to tolerate central regional blocking. It is very difficult to deal if hypertension develops during anesthesia. Always remember. In our life, in my life of 30 years of practice, we have only seen one case of this emergency. We published it and we lost this patient. So conclusions. So where are we as per cardiomyopathy? Difficult to handle in perioperative period. Good knowledge of pathophysiology makes management easy. Preoperative progression is the hallmark of therapy, right? One side doesn't fit all. Intraoperative phase, do not ignore red flags. Change in heart rate is one such flag. Always remember that. Enhance post-operative care, HDU, invasive monitoring. And don't miss my last slide, right? So cardiomyopathy is one thing, right? Whenever your has got this cardiomyopathy, you dance with the heart. Then for a successful outcome, always remember. Thank you very much. Thank you for
Thank you, Ram. It's a lot of time and it was such a wonderful lecture and a talk. So we take just one or two questions, if any. Anybody wants to ask a question? Yes, you're most welcome. But please be fast. I think everybody is feeling hungry and wants to go for lunch. So we can have the question answers in the lunch itself. Thank you so much. But just we end this session. Thank you.
Good afternoon, ladies and gentlemen. Let us start the session. The first lecture is by Dr. Akhilesh Gupta, who is Professor of Anesthesia and Critical Care at Cambridge. From Ram Manohar Hospital, New Delhi. He is in charge of clinic in RML Hospital.
At the outset, I'd like to thank the organizers for giving me the opportunity to present this topic, and it becomes an honor for me to present a topic about trauma, head and spine trauma in front of LD Mishra sir and Aditya sir, who are stalwarts in neuro anesthesia, and they all were my teachers. So coming on to management of severe head and spine trauma. When we talk about head and spine trauma, there is some census by Indian Head Injury Foundation, and they say that more than 1 lakh lives are lost every year, which is a significantly good number, with over 1 million suffering from serious head injuries. And 1 out of every 6 trauma victims die. While when we compare the census from United States, it's 1 out of 200. So there is something we need to do more about it. And half of those who die from traumatic brain injury do so within the first 2 hours of injury. So we have certain interval and we have certain golden period in which we can do something so as to prevent the further deterioration and death from the traumatic brain injury, because that's something which we can prevent. So as an anesthesiologist, why we need to know this? Where is our role? Because we all are sitting in the casualty, we all have been called in ER. So at a part of resuscitation team, when these patients come for surgery, so as for pre-operative optimization, intraoperative management in the part of control of intracranial pressure, neurological monitoring, and after that when we come out with post-operative care, the elective ventilation, when to ventilate, how to ventilate, and what all monitorings are required. So grossly I will be covering all those parts. So I will be talking more of evidence, what all evidence is there, and the evidence are Advanced Trauma Life Support Report, latest edition, 10th edition, and the guidelines from Brain Trauma Foundation, which came in just 2018, 4th edition, guidelines for management of severe traumatic brain injury. So starting with the scenario, there is a 30-year-old male, not an uncommon scenario, who was riding a bike and had a head-on collision with a truck. And he presented in the ER in the unconscious state and he was tachypneic. So how should we proceed? So first, talking on the goals of management, first is that we have to prevent the secondary brain injury. There is a primary brain injury and subsequent to it there is a secondary brain injury. I will be talking about it. And we have to prevent the patient going from primary brain injury to secondary brain injury. And for that, two important things are required. We have to maintain oxygenation and maintain perfusion. And for that, we have to avoid hypotension. One thing I like to emphasize that it's highly unlikely that if a patient has traumatic brain injury, the patient to have hypotension. So if a patient with brain injury present to us with hypotension, we have to be a little skeptical that there might be some other causes which are leading to hypotension, because per se brain injury doesn't lead to hypotension unless we talk about a very small child or there are lacerated lot many wounds or oozing of blood. So if the patient has hypotension along with brain injury, we have to look for other injuries like pneumopericardium or pneumothorax or any other cause, any other area of blood loss. So coming on to what is actually primary or secondary brain injury. Primary injury is injury to scalp, skull fractures, surface contusion, intracranial hematoma, diffuse axonal injury. And the secondary injury is because of hypoxia, swelling, edema, raised intracranial pressure, meningitis or abscess. So if we do not take care of those primary injuries, gradually it will lead on to secondary injury. So our whole management of head injury depends on the how to categorize these patients. So there is a modified Glasgow Coma scale, and in the next slide I will be talking about what is that modified. So based on that, we categorize the patients into three or triage the patients into three groups: mild, moderate and severe. Patient with mild head injury which have GCS score of 13 to 15, moderate with score of 9 to 12, and severe with GCS score of 8 or less. So what is actually modified GCS score? This is the original score, three components: eye opening, verbal response and motor response. Eye opening, it was initially spontaneous. To speech it was initially there, now they say it is to sound, and initially it was to pain, now they say to pressure. And there is a new category added in each group which is non-testable. Suppose patient has got some eye injury, so we cannot see the eye response. So in that we write that normally when we write VT, so in each category they have a new category called non-testable. Coming on to the verbal response, not much change in this. Confused conversation has been changed to only confused, inappropriate words have been changed to words, and non-testable has been added. Coming on to the motor response, obeys command, localizes pain means localizing, flexion, withdrawal to pain means normal flexion, abnormal flexion is abnormal flexion, and again non-testable, we cannot test the motor response. So based on those modified GCS, we categorize the patient into mild, moderate and severe. So coming on to the patient, we have the mild head injury like GCS score of 13 to 15, what to do? So if the patient is asymptomatic, fully awake with no neurological abnormalities and no indications for CT scan. In the next slide I will talking about what are the indications for CT scan, when should we ask for CT scan in a patient with traumatic brain injury and GCS of 13 to 15. These are the indications for CT scan in mild traumatic brain injury, like when GCS is less than 15, even at 2 hours after injury, or there is suspected open or depressed skull fracture, signs of basilar skull fracture, or more than 2 episodes of vomiting. Even if GCS is around 13 to 15 and there are 2 episodes of vomiting, you will get the CT scan done. Age more than 65, patient using anticoagulant, loss of consciousness more than 5 minutes, or amnesia before impact of more than 30 minutes, or any dangerous mechanism of injury. So in all those things, we will get the CT scan done, and if the CT scan is abnormal, then the patient remains symptomatic, then admit the patient, otherwise we can discharge the patient. Coming on to the moderate head injury, after stabilization in the moderate head injury and the severe head injury, we always get the CT scan done. But remember, we have to do it after stabilization of the patient. So we first stabilize the patient and then CT had to be done in all the cases. Patient should be reassessed for at least first 12 to 24 hours and a follow-up CT scan within 24 hours is recommended if the initial CT scan is abnormal or patient neurological condition deteriorates. Coming on to the topic severe head injury where the GCS scale is less than 8. So main primary aim is that to prevent the patient going into secondary brain injury. So correct hypotension if there is, prevent hypoxemia and prevent hypercarbia. We have to maintain normocarbia and we have to go for the ABCD approach. So what is that ABCD approach? First is we have to take care of airway and breathing. Since GCS score is less than 8, so there are chances that patient will not be having patent airway reflexes. So we have to go for early tracheal intubation. Oxygen saturation more than 98% is desirable. And in general, we try to keep PaCO2 at approx 35 mm Hg and hyperventilation has to be avoided. There are few indications where we could go for hyperventilation. I will talk about them later on, and take care of cervical spine. They say that it's a highly likelihood that if the patient comes with traumatic brain injury, there are very high chances that patient has cervical spine injury. So unless you rule out completely, it's always better to take out the precautions for cervical spine. So take care of cervical spine while intubating the patient. Regarding intubation using manual inline stabilization of spine, we can use various adjuncts like intubating laryngeal mask airway, which we can use in the neutral head position. We can use video laryngoscope. There are video laryngoscopes, CMAC D blade, which we can use in the neutral head position, or we can insert supraglottic airway device and use intubate through that supraglottic airway device either blindly or using fiber optic guided, and avoid nasal intubation. Coming on to management, after managing A and B, we move on to the C. If the patient has hypotension, rule out other comorbidities, rule out other signs of injury, ensure fluid resuscitation using isotonic fluids and blood products. And these are the endpoints of maintaining systolic blood pressure. For a patient of 50 to 69 years old, it should be more than 100. And for a patient of 15 to 49 or more than 70 years, the target should be more than 110 mm. Now coming on to choice of fluid, what to avoid is hypotonic fluids to be avoided or glucose containing fluids to be avoided, as they can further harm the injured brain. Normal saline is a preferred and oral can also be used. So coming on to what the guidelines of Brain Trauma Foundation, which came out in 4th edition 2018, says, they talk about prophylactic hypothermia, what is the evidence of it, hyperosmolar therapy, ventilation strategies, seizure prophylaxis, whether we should give it or not, and what should be the BP threshold. So coming on to each thing, what they say about prophylactic hypothermia, they say that early and short-term prophylactic hypothermia is not recommended, and there is a level 2B evidence that it should not be given to improve outcomes in patients with diffuse injury. Hyperosmolar therapy, mannitol is effective for control of raised intracranial pressure at doses of 0.25 grams per kg to 1 gram per kg. And arterial hypotension should be avoided. That's the important thing we have to take care when we are giving mannitol, that hypotension has to be avoided. And there, if we are not using intracranial pressure monitoring, so in case we find some signs of transtentorial herniation or any signs of decreased intracranial pressure, then restrict mannitol use because it will further increase the herniation part. Ventilation therapy, prolonged prophylactic hyperventilation should be avoided, is not recommended. As a level 2B evidence to it. Use of barbiturates, should we use thiopentone or other barbiturates? They say that administration of barbiturates as prophylaxis against the development of intracranial hypertension is not recommended. There is no evidence. There is a level 2B evidence which says that this should not be given. And high dose barbiturate is recommended to control elevated ICP only when the maximum standard medical and surgical treatment has been used. So only that situation the high dose barbiturate administration can be given, but again with the rider that hemodynamic stability is essential before and during barbiturate therapy. We have to take care that the patient will not go into hypotension because that is more hazardous. Coming on to seizure prophylaxis, prophylactic use of phenytoin or valproate is not recommended for preventing late post-traumatic seizure, and there is a level 2A evidence to it. So coming on all those things, we manage the patient, we manage the ABC, then coming on to neurologic assessment, patient GCS score we have done, pupillary light response and focal neurological deficit. Then proceeding on to CT head, done after hemodynamic resuscitation. We have stabilized the patient, we have done the resuscitation part, then moving on to CT head. It is repeated whenever there is a change in the patient clinical status, and the shift of 5 mm or more often indicates the need for surgery to evacuate the blood clot or contusion causing the shift. So if there is a shift of 5 mm or more, then surgery is indicated. So coming back to our patient from which we have started, the patient had severe head injury, we have done the primary stabilization, we have taken care of airway and breathing, we did the intubation using mills. We ruled out other causes, there was no evidence of pneumothorax or pneumopericardium. We secured 2 large IVXs, BP was 120/90, we did the resuscitation with the help of NS. GCS was even BTM4. We got the CT scan done after stabilizing the patient. CT scan showed acute SDH with right frontoparietal area. So the plan was more than 5 mm shift, so plan was craniotomy with evacuation of SDH. So how should we proceed and what extra precautions should we take? So when we talk about anesthesia, so we have talked about what steps we should take care when we are dealing with a patient in the emergency, in the casualty, and how to optimize. Because see, everything is from ER to OR. We have to optimize the patient and then continue all those things in the OR. So about 1/3 of the patients with severe traumatic brain injury require surgical intervention. And acute subdural hematoma has reduced mortality from 90 to 30%. That's a significant number when the surgical evacuation is done within 4 hours of injury. So that's the urgency, it has to be done early. Again, there are certain goals of anesthesia which we should take care of. Maintain cerebral perfusion pressure and avoidance of intracranial hypertension. We have to take care, there is no increase in ICP. The thing which I highlighted earlier, the prevention of secondary brain injury, we have to avoid hypotension, avoid hypoxia. Again, this is a very important step, and we have to keep on taking care of it at every step, starting from ER, OR, post-op, everywhere. Avoid hypoglycemia, hyperthermia, maintaining normocapnia, adequate analgesia and anesthesia. So coming on to pre-op evaluation, we take a focus history, do the physical examination, rule out any other comorbid diseases, any other signs of injury, then rule out cervical spine injury. All the patients should be presumed to having unstable cervical spine until proven otherwise. A thorough neurological examination should be done, and it should include baseline sedation and GCS, because we should know what is the baseline status, because then that becomes an indicator that when should extubate the patient, or one of the indicators of extubating of the patient. So baseline sedation and GCS, motor functions and presence of any neurological deficit. Recognize other trauma related injuries like pneumothorax, bleeding from other source of cardiac tamponade. Then securing the airway, intubation should be performed in manual illness stabilization. Various airway techniques can be used along with this, like video laryngoscope, Buji, intubating LMA. Blind nasal intubation should be avoided in suspected fracture base of skull. When we have to use certain anesthetic agents, there are certain goals we have to take care of. All those, we have to choose those anesthetic agents which decreases CMR, cerebral metabolic rate, maintain cerebral perfusion pressure, and should not have any seizure potential. So in brief, I will be talking about what all anesthetic agents we can use. Regarding muscle relaxants, we presume these patients to be full stomach, and rapid sequence induction is usually followed in such patients. Succinylcholine is a neuromuscular agent of choice. Though succinylcholine causes transient increase in ICP, but the benefits of rapid onset and short action outweighs the risk. So we can use succinylcholine. Rocuronium, yes, it can be used in the doses of 0.9 to 1.5 because we can achieve similar intubating condition in 60 to 90 seconds. Regarding intubating agents, we have 4 major groups of induction agents. Barbiturates, the advantage is they cause hypnosis, depression of CMR, reduction of cerebral blood flow, so all the good things, anticonvulsant activity. Etomidate, it is good, it has a better hemodynamic profile, so less chances of patient going into hypotension. Advantage of being cardiostable, and also it decreased CMR, cerebral blood flow, intracranial pressure, all good, but it is associated with myoclonic and seizure activity, so avoided in patients with history of seizures. Propofol, again all good things, decreases CMR, cerebral blood flow, it has got significant anticonvulsant activity and short elimination half-life, so better assessment of patient post-operatively. But again, there is a disadvantage, or we have to use it with caution, that it can cause hypotension, which we have to avoid. So we have to use propofol in an incremental dose. Ketamine, little skeptical about use of ketamine because it increases cerebral blood flow while no change in CMR, and can lead to increase in intracranial pressure. Regarding inhalational agents, all inhalational agents causes concentration dependent decrease in the cerebral metabolic rate. They dilate cerebral blood vessels and impair autoregulation, and this thing can be reversed with hyperventilation, can blunt the vasodilatory effects. Important thing is that inhalational agents causes coronary steal phenomena. Now what is that coronary steal phenomena? That it increases the blood flow in normal areas of brain but not in the ischemic areas. So wherever there is a normal area, it increases the blood flow, so it steals the blood from the ischemic area to the normal area, which is the opposite of when we use barbiturates, because they increases the blood flow in the ischemic area. So that's the reason why we should use more of IV induction agents and less of inhalation agents. Opioids do not increase intracranial pressure despite transient decrease in mean arterial pressure. That opioids have an advantage of blunting the sympathetic response during intubation and surgical stimulation. So they are good. Again, fluid therapy, systolic blood pressure should be kept more than 90, and fluid resuscitation and vasopressors may be needed to achieve the adequate pressure. Mannitol we have discussed, we can use it in the dose of 0.25 to 1 gram per kg body weight. Avoid mannitol in hypotensive patient because it does not lower ICP. Acute neurological deterioration, when patient is under observation, develops a dilated pupil, hemiparesis. So we have to take care that in the patient which have decreased ICP, we should not give mannitol because it can further. In some patient there is some brain herniation, so we should avoid using that. The evidence is coming of use of more hypertonic saline because they say that it is a preferable agent for patients with hypotension, because it does not act as a diuretic, and it also used to reduce elevated ICP in concentration of 3% to 23.4%, and adequate blood products have to be kept arranged. Ventilation, hyperventilation to be avoided. PaCO2 should be kept between 30 to 35 mmHg. Reserve hyperventilation acutely in patients with severe brain injury only those with acute neurological deterioration or signs of herniation. So only in such subset of patient hyperventilation can be given, and that too in a very short span of time, restricted to 2 to 6 hours. And prolonged hyperventilation with PaCO2 less than 25 is not recommended, and there is no evidence for it. When to extubate, decision to whether to extubate the trachea at the conclusion of surgery depends on these factors: that what was the severity of injury, what was the preoperative status, what was the sedation of the patient, how patient was in the preoperative, what was the motor deficits, blood loss, and presence of other concomitant injuries. So based on all those things, we decide whether to extubate or not. Coming on to the second part of my presentation, the spinal trauma. Acute spinal cord injury requires urgent stabilization and prevention of secondary injury. Again, as we talked about traumatic brain injury, the same thing goes with spine injury, that we have to prevent the secondary injury. Cervical spine injury are the most common among all spinal injuries. High level of cord injuries causes more motor, sensory and autonomic disturbances than lower cord injuries. And after acute spinal cord injury, spinal cord autoregulation is impaired. So whenever there is an acute spinal cord injury, there is an impairment of autoregulation, and there is hypotension and development of neurogenic shock. So when should we suspect the cervical spine injury? If there is a presence of paraplegia or quadriplegia as a presumptive evidence of spinal instability. There is a Canadian C-spine rule which talks about many things, whether it is a tenderness, how is the mechanism of injury. So seeing on all those factors, we decided whether we need to get the radiograph, we have to get the X-ray cervical spine done or not. If we get the C-spine film, we have to look for bony deformity or fracture of the vertebral body or the process. Loss of alignment of the posterior aspect of the vertebral body, we have to see this alignment line. Increased distance between the spinous process at one level. See here the distance between the two spinous processes, and see there is an increased distance between the spinous process. So there is an injury, narrowing of the vertebral canal and increased prevertebral soft tissue space. Coming on from cervical spine to thoracolumbar spine injury, presence of paraplegia or a level of sensory loss on the chest or abdomen. Patients who have spine pain or tenderness on palpation, neurological deficit, and altered level of consciousness or significant mechanism of injury. So these all are the conditions where we should proceed on with CT scan, and if CT scan is unavailable, better to obtain AP and lateral radiographs of the entire thoracic and lumbar spine. Coming on to what is neurogenic shock and how should we deal with it. If there is an injury to cervical or upper thoracic spinal cord, that T6 and above, it causes impairment of descending sympathetic pathways. This lead to vasomotor tone, vasodilatation of visceral and peripheral blood vessels, pooling of blood and hypotension. So loss of sympathetic innervation to heart also can cause bradycardia, and physiologic effects of neurogenic shock are not reversed with fluid resuscitation alone. There is a vasodilatation, so we need to give something besides fluid resuscitation. So the judicious use of vasopressors may be required after moderate volume replacement. So first we have to replace the volume, and then we can use vasopressors, and atropine may be used to counteract hemodynamic significant bradycardia. Now again, management of spine trauma. The patient comes with spine trauma and comes in the ER. So depending on the level and extent of injury, patient can have respiratory or hemodynamic compromise. A detailed neurological evaluation is to be done. We have to take care of cervical spine. If we have to maintain the airway, we have to use manual illness stabilization. Succinylcholine is safe in the initial 24 hours of spine injury, and fluid resuscitation and anatomes may be required in case of neurogenic shock. Target should be mean arterial pressure should be maintained above 85 mm Hg. Initially, it was advocated to use of corticosteroids when we talk about any spinal trauma. But now all the guidelines, all the associations, American Association of Neurological Surgeons and Congress of Neurological Surgeons, all people say that high dose steroids are no longer indicated. Coming on to the anesthesia management, suppose such patient comes on for anesthesia. So again, if you are suspecting cervical spine injury, use manual inline stabilization. Positioning surgeries are for the thoracic and lumbar spine are done in a prone position. So we have to take care of all precautions. Adequate padding should be ensured. Hemodynamics have to be maintained. Spinal surgery may be associated with blood loss because if there is no proper positioning. So mean arterial pressure should be kept above 85 mm Hg. Use of fibrinolytics can be done, and neuromonitoring we can use. There are certain post-operative complications when the patient go for spine surgery, like post-operative visual loss, spinal artery syndrome, or autonomic dysreflexia. But autonomic dysreflexia is a late complication of complete spinal cord injury, and this is characterized by hypertensive response to any stimulus below the level of injury. But that's not the acute post-operative complication. So to summarize, management of head and spine trauma in the ER is a continuous process from ER to OR. We have to optimize the patient in the emergency before taking up the patient for surgery, and it has to be continued in the operating room. The steps have to be continued in the operating room. Hypoxia and hypotension to be avoided in traumatic brain injury. We have to take care to prevent the secondary either brain injury or secondary cord injury, and spine stabilization and fluid resuscitation plays a vital role. Thank you so much.
The topic is now open for discussion. The questions are invited from the audience.
We have about 5 to 7 minutes, so you're welcome.
Post-lunch session, sir.
Sir, please highlight the medical legal aspects as per our anesthetist is concerned about head and spinal injuries.
Pardon, sir?
Medical legal issues
regarding, sir?
Head injuries and spinal injuries.
Medical
anesthetist is concerned.
Yeah. Medically, if we take care of all the steps, like suppose patient comes and first we stabilize, we get the CT scan, so everything is very documented, everything is there in the guidelines. So if we take care of all these steps, I think there is no issue medically.
Are we treated as a party in medical legal cases as anesthetist? If suppose any medical legal problem arises, then is anesthetist is also treated as a party?
I think so, because if it is involved in the resuscitation and everywhere, so it can be taken as a party.
What are the precautions that could be taken?
So we have to take care, we have to move as per the guidelines. Suppose what normally happens, the patient comes with severe spine injury. Okay, first thing we think of is get the CT scan done. So if we do such blunders, we can get into medical legal trouble. First thing is we have to stabilize the patient. CT scan is to be done, but only after stabilization. Again, most common thing we take care is that we forget about hypotension. Whenever there is a hypotension, we think that this hypotension is because of traumatic brain injury. No, this hypotension, we overlook other injuries. So whenever there is a hypotension in traumatic brain injury, we have to look for other injuries. So these are few things.
Actually, more importantly is that you should document whatever you had to do resuscitation in the initial period itself. You had to do CPR, but patient was presumably very serious and probably was hyperventilating or his blood pressure was not recordable or very low. Then you have to do resuscitation. Then document it. Documentation is very, very important. Sorry, mic please. कहाँ माइक है भाई? कौन है माइक मैनेज कर रहा है? हेलो माइक.
Do you monitor ICP regularly in individuals?
In our setup, we are not monitoring, but ideally it should be monitoring if the patient comes with a severe traumatic brain injury, because the guidelines say that before giving mannitol, it's always advocate to use ICP monitoring and then give mannitol.
What are the indications for ICP?
Not aware, because we are not using it.
Monitoring ICP is a very invasive procedure. Is done when available, and available means there are people who can constantly monitor and who can interpret. Because single-handed resuscitation, anesthesiology in the ER or single-handed anesthesiology in the ICU, please do not try to do ICP and leave other important smaller things beforehand. So ICP is good in a big organized institution where there are neuroanesthesiologists and neurointensivists and all. Otherwise, not a single MD anesthesiologist doing anesthesia as well as ICU in a nursing home or hospital should ever try to do ICP monitoring, because that will go against you. Where you are not trained, you are not equipped, and you are trying to do so invasive procedure without being prepared for it. There are minuses.
So, what did you mention regarding the dysreflexia characteristic symptoms in a spinal cord injury?
See, if there is a spinal cord injury, we have to take care of how the reflexes are there, lower motor neuron changes are there, upper motor neuron changes are there, and based on it, we will manage further.
Most important is neurological, from spine, the cervical spine until the down there. And secondly, in spinal injuries, with or without spinal cord, more important is initial resuscitation, immobilization, and transportation to proper place, suitable place. Surgery comes very late. Surgery has very small role and very, very specific role for removing the obstruction or pressure on the cord, or for that matter, stabilizing the spine. These are only two small indications of surgery.
Sir, how is that intubation characterized in this kind of spinal cord surgery? What were the precautions we will be taking to intubate these patients?
Of course. But this is beyond the scope of this lecture. Manual inline stabilization before the immobilization of the cervical cord, that's beyond the discussion of this.
See, whenever there is a cervical cord injury, we suspect the patient comes with traumatic brain injury, so we have to think of cervical spine injury. Unless there are absolute things that there is no palpation, no spinal tenderness, and the mechanism of injury is very less, and we are not suspecting only that, even then they say that it's always better to take care of cervical spine. And when we take care of cervical spine, we do manual inline stabilization. When we do manual inline stabilization, we can use normal laryngoscope, but little difficult. Then we can use McCoy, we can use supraglottic airway device, we can intubate through intubating LMA, we can use supraglottic device, and then those through supraglottic device we can use fibroscopy and then intubate through those devices. So, and we can use video laryngoscope. There are plates which helps us in intubation and neutral respiration. So we have to take care of all those things to avoid the spinal inturbation. For not intubating, see, if there is a patient, we need to intubate because the patient comes with severe traumatic brain injury. GCS is less than 8, so we have to take care of airway reflux. So we have to have a definitive airway.
There is no absolute contradiction.
The intubation has to be done.
It has to be done, it has to be done. You have to take all precautions.
Somewhere it is mentioned that cervical cord injury.
Cervical cord injury, what you do is that you keep the neck in neutral position. Do not move the neck and use manual inline stabilization technique. And use the laryngoscope with which you are most practiced. Do not go for fancy things like video laryngoscopy or for anything else back. Use the laryngoscope which you have been using regularly. That is very important, so that you do not move the neck too much. The neck movement has to be minimal, so that you do not add further injury.
Yes,
that is very important.
Thank you. No, doctor. When intubation is required, it has to be done. You cannot get away.
Intubation is not possible. We can go with the tracheostomy. We have to secure the airway. That is not the question. We have to secure.
You can go for tracheostomy. You can go for cricothyroidotomy. It has to be secure. It has to be secure.
Tracheostomy is not an emergency procedure. Be in anybody's hand. You may be very, very expert. This is not time to go for tracheostomy. Tracheostomy is only after definitely airway has been established. And there is problem in managing that, and you think now is time, you have taken initial precautions and patient stabilized, this is time, you may think of tracheostomy, not as an emergency measure. Please.
Thank you, Akhilesh sir, for the nice and precise presentation of head injury and spine injury. Sir, I want to add a few points. In the management part, we should not restrict ourselves to ER, to OR. We have to go with the intensive care also, because the main part in management is intensive care also. Although we have to do the same things. The second point, in the medical legal aspect, we have to label these head injury and spine injury the MLC, and accordingly we should manage. And the third part, and for the ICP management, the invasive ICP is not the only thing we can do. Now the era of the ultrasound is there, so non-invasive ICP like optic nerve sheath diameter and transcranial Doppler. These are two popular things we can do to measure the ICP, and without measuring ICP, we should not go ahead with the hearings. Thank you.
Sir, my question is because the drink and drive cases are very common in our India. So the problem is the initial neurological assessment is very, very difficult if the patient is under severe alcoholic intoxication. Recently, I have encountered such a case of a serious car accident which happened in our state in Hyderabad, and the patient was literally extracted by removing the back seat of the car and taken out, and the patient arrived in the emergency room, and nobody was around.
Your problem. Your question.
The question is how to assess the neurological, the GCS, because the like CT is advised if it is moderate to severe. So how to decide, because the patient is not in a position to.
CT is to be done whether the patient has when the moderate or severe in both of the situations. CT has to be done.
Yes.
Even in mild head injury, in the majority of the situations, if the patient is intoxicated, you have taken care of primary management, then you can go for CT scan. See, CT will not cause any harm to the patient, provided you have done the primary stabilization. So it will say, okay, the CT scan is normal. In the meantime, the patient will regain normal consciousness and everything, and then you can observe. And if the patient regains normalcy within 12 to 24 hours, then if the patient doesn't regain normalcy, then you have to go for repeat CT scan after 24 hours. If the patient becomes normal, then you can proceed further. So,
but the initial assessment is very, very difficult. So there should be some way out of it.
Yeah, the only thing is first to stabilize the patient and then get the CT scan.
You have to wait and watch. That is the only way. Please.
Thank you, Dr. Akhilesh.
Thank you, sir.
I thought you would talk about, and I thought somebody will ask about, but it has not been covered, so I will ask you, what is the role of steroid in spinal cord injury patients?
So there is no role of steroids per se as per the recent guidelines in spinal cord injuries. Steroids should be avoided.
Some say that the patient comes early, within first 8 hours, there is a spinal cord transaction, there is a role. What is your opinion about it?
So as per the guidelines which says that initially they say that it should be given, but they say that it doesn't cause much of a benefit, but yes, you can give.
In transaction, there is as such nothing much that can prove, and so there is no need to create any controversy because many give. So there is no harm in giving. But the thing is, you should give, if you give, if possible, within the first 8 hours. Thank you very much, sir.
Sir, one more question.
No, sorry.
Enough time has passed. You can ask me.
After the session, Dr. Akhilesh is here. He is very sincere. He will be here for 3 days. My pleasure to introduce Dr. Zulfikar Ali, a renowned neuroanesthesiologist who did his neuroanesthesia training, neuroanesthesiology from World Institute of Medical Sciences, as a regular speaker in our neuroanesthesiology annual conferences, and often he comes here in ISACMAR as well. He is presently Division of Neuroanesthesia Critical Care, Srinagar, the Kashmir Institute of Medical Sciences, Srinagar. He is a really renowned researcher and academician. Don't go by his age, he is really good, and I'm very happy to have him here, with us. And I'm sure you will like his presentation on the topic, which is quite interesting to all of us. Over to Dr. Zulfikar.
Thank you, sir, for such a nice introduction and overall.
Zulfikar has 85 international publications.
Thank you, sir. Good afternoon, everybody. I'll be briefly discussing with you the interventional, the anesthetic implications for managing a patient who is posted for interventional neuroradiological procedures. Greetings from Kashmir Institute of Medical Sciences. This is the place where I work now, and this is a small picture of one of my cath labs where we daily do various interventional procedures. If we see the interventional neuroradiological procedures, there has been a rapid upsurge in these over the last 2 decades. And the introduction of the modern technology with the implementation, with the introduction of digital subtraction angiography, with the introduction of various microcatheters, improvised glue substances, there has been a tremendous popularity and there has been a dramatic improvement in the patient outcome once we deal with these procedures. So there has been a rapid upsurge in these procedures where we have these procedures mainly. We have the diagnostic procedures and we have the therapeutic procedures. This is a brief classification. Commonly, the commonest diagnostic procedure that we do in our interventional neuroradiology, that's the diagnostic angiography. And then we do one more diagnostic procedure commonly in our day-to-day clinical practice, that is for the detection of the cerebral vasospasm. These are the 2 commonly used diagnostic procedures. And in addition to these, all of us are acquainted with the daily computerized tomography, CT angio, MR and MR angiography. Then we have various therapeutic procedures, and the commonest therapeutic procedures that is in vogue nowadays is the embolization for the aneurysmal subarachnoid hemorrhage. And this is followed by embolization for injection of glue into the AV malformation. And quite a number of patients across the country who present with strokes, we go for carotid stenting. So these are some of the therapeutic procedures that we do in our day-to-day clinical practice, in addition to embolization of various intracranial skull-based tumors. If we see the extracranial tumors that we have, juvenile nasoangiofibroma is one of the commonest extracranial procedures where we do embolization, and then we have the various stereotactic and functional neurosurgical procedures that we do in our clinical practice. So if we see the anesthetic management, we start seeing these patients from the preoperative period, and most of these patients, they land up with us in emergency for emergency neuroimaging, and we get them in a very pretty bad condition with a low GCS, and we have a focal neurological deficit. So if we have an impaired level of consciousness, we need to document the GCS before we start the sedation or we anesthetize these patients. And then we have to have an idea about the focal neurological deficit. The focal neurological deficit in itself may give a clinch about the diagnosis. If we have a sylvian-Fisher bleed or we have a middle cerebral artery aneurysm, we can have a hemiplegia or a hemiparesis. And if we have a posterior cerebral bleed, we can have a weakness of the lower limbs. Then Some of these patients, they may come with tremendous headache and vomiting, which signifies that the intracranial pressure is dramatically increased, and we have to have an idea about the renal function in these patients. They, elderly patients, diabetics, particularly those patients who are taking metformin, they may be at risk of acute renal injury, which may get exacerbated by the contrast injections. And again, we have to have an idea that whether there is any prior history of the allergic reactions to the contrast media. If we see patients because of catecholamine release, whenever we have a aneurysm which has bled, it's accompanied by a rapid increase in the epinephrine levels. So these patients, they can have neurogenic pulmonary edema, which needs to be taken care of. These patients can have hypertension, which may be, as we discussed, because of catecholamine release, or they can have Takayama-Sogo's myocarditis, which may cause myocardial stunning and hypotension. So they need to be optimized. And if we have women of childbearing age, we have to rule out the pregnancy before we subject them to the interventional radiology procedures because of the excessive radiation. Briefly, some of the investigations which we should not miss. We have to have an idea about the hemoglobin before we order for blood products, and then we have to have an idea of the electrolytes. Sodium in itself may provide enough information about the underlying endocrinological disorders. If we have hypernatremia, our patient may be in diabetes insipidus. Or if we have hyponatremia, we need to rule out cerebral salt wasting syndrome and SIADH. Then we have to have an idea about the baseline ECG. There may be non-specific change because of catecholamine surge and renal dysfunction. Before we go for contrast injection, we have to have an idea that will have an impact on the volume of contrast we are subsequently injecting during the procedure. And on CT scan and DSA, once we are going for a definitive procedure, two things we should always keep in mind. First, on CT scan, we should see if there is any amount of blood in the ventricles. If we see the amount of blood in the ventricles, it may predict the incidence and severity of cerebral vasospasm, which will have a bearing on the mortality and morbidity in the intensive care unit. And again, we have to have an idea on the DSA. We have to have whether there is some collateral circulation present. Patients who have a poor collateral circulation, they are not able to tolerate the temporary clipping occlusion. And again, it affects the morbidity and mortality subsequently. Briefly, some of the diagnostic interventions that we do is computerized tomography, which we do daily. It's nothing but an X-ray. But what we do on computerized tomography, we obtain an image which we present in terms of voxels. That's a three-dimensional volume depiction of the brain on a CT image, where an X-ray gives a picture in the terms of pixels. That's two-dimensional image. And once we inject contrast to such patients, we get an idea about the vessels, that's the CT angiography. And if again we have the movement of the CT scan around the axis of our interest, it gives us a much better image with a conical 3D representation. That is what we call a dynamic CT or DynaCT. Recently, for the management of stroke, there has been a popularization of the CT perfusion imaging, and this gives us three things. That's the cerebral blood volume, the cerebral blood flow, and the mean transit times. This is very important once we take up these patients, particularly the middle cerebral artery strokes. In this picture, we see, if we see conventionally the red areas, these are the areas where we have an overflow of the blood. They are hyperperfused. And conventionally, if we see the blue areas, these are the areas which are underperfused. So, as an anesthesiologist, our target should be to turn these areas, these blue areas, into yellow areas which are optimally perfused. So, in this situation, we should improve the blood flow so as to optimize the cerebral circulation. Magnetic resonance imaging, it gives us better depiction of Maris image, particularly imaging of the posterior fossa structures. And again, if we couple it with the contrast injection, we obtain magnetic angiography, magnetic resonance angiography, which gives a better delineation of the vesicular structures. And last of all, commonly what we use in our interventional neuroradiology is the digital subtraction angiography. So before we go into the anesthetic implications, we need to have an idea what is this basically. Digital subtraction angiography, what we do, we start with the plain image that we call as the mask picture. So this picture, it contains the bones and the soft structures and the vessels. Then we take another image. This second image is superimposed on the previous image. We subtract everything except the vessels. We subtract the bones and the soft tissue. So we keep only the vessels in view. And once we give contrast, the vessels are delineated. So once we inject the contrast, we have what we call a clear-cut road, a road map. And it is on this road map we manipulate our microcatheters and we do the designated intervention. So coming to the preoperative considerations, if we see the neuroradiology suite, it's usually situated away from the OR. I have just taken this picture from my personal life. I had gone once to a lake in the mountains in Kashmir. This is Kausar Nag, and we moved on this glacier. And unluckily the glacier moved away from the shore and we were trapped. So you can see there's the army helicopter which came to rescue us, and here we were, 2 or 3 of our friends, and they rescued us. So once we have an anesthesiologist, particularly a novice anesthesiologist, who is in the interventional radiology suite, the situation is something like this. There are a lot of complex issues. We have a remote site with minimal assistance from the surroundings. Then we are scared about the ionizing radiation many times, particularly in many setups. In our scenario, we do not get adequate protection against ionizing radiation. And then the most vital part, our endotracheal tube, there's a lot of movement going around the endotracheal tube. The C-arm, the fluoroscope, it keeps on moving, and we feel threatened that there may be accidental extubation. And many times once we are doing the angiography, particularly in confused conscious patients, sometimes if we have not intubated, the neuroradiologist keeps on asking, I want apnea, I want apnea. So it becomes a very tricky situation. The second issue that we have in such a situation is anticoagulation, which we have to be which has to be addressed consciously. So we need to, after the femoral catheterization, we need to give heparin to such patients. So we usually give around 100 units per kg of heparin to such patients, and we maintain the activated clotting time about 3 times the normal. Many patients we should give them aspirin and clopidogrel before we start doing such procedures, so that the patients, they get enough time for these drugs to act. And intra-arterial antithrombotics, abciximab, it's commonly used. On one side, an anesthesiologist, he uses anticoagulants, and on the other side, one has to be prepared for a catastrophe that may occur while doing such procedures. So if we have a spontaneous bleed, it can turn out to be a catastrophe, and we have to be ready to reverse this anticoagulation with protamine. Then radiation protection, we have to have an adequate radiation protection in terms of lead aprons, thyroid goggles, and eye cover protection. This slide, this gives a rough idea of how much exposure we are being exposed to while doing these procedures. We see if we do a diagnostic angiography, we get around 5 millisieverts of that radiation. That is around 250 chest X-rays. And if we are doing this procedure where we are doing intervention, we are getting exposed to a radiation of 500 X-rays. So this is a considerably good amount of radiation that we need to protect ourselves from. And then many a times the neuroradiologists, they keep on flushing the patient with injecting the contrast and flushing this contrast. So on an average, around 2 liters of IV fluids goes into the patient, and we have to keep track of these fluids, particularly once we are dealing with patients who have a compromised cardiovascular reserve. And second, and more important, is we have to limit the amount of contrast that we are injecting. Commonly what we use is iohexol 350 for neuroradiological procedures of the brain. So it contains around 350 milligrams of iodine per mil, and we can safely give 5 ml per kg of this contrast. That is around 300 ml of this contrast. Once we exceed this limit, it may create issues for the patient in the post-operative period. So once we have this patient in the intensive care unit, this derangement of the kidney function tests, it may manifest itself after 72 hours. So we should not forget to do repeat a kidney function test after 72 hours in such patients. These are some of the neuroanesthesia goals that we need to keep in mind while doing these procedures. We have to ensure the patient is immobile. Then we have to manipulate the various cardiovascular parameters, particularly the blood pressure, and at the same time ensure that we are maintaining an optimal blood pressure. We should be ready to manage rapidly any complications. Most of them are very life-threatening. We have to be able to effectively and rapidly manage them, and we have to ensure that we are maintaining an adequate cerebral perfusion pressure, and once we are extubating, a smooth emergence has to be ensured. One of the basic goals during induction is we have to maintain an adequate transmural pressure. So it's not only the hypertension that can be deleterious to these patients. Even hypotension can cause a decrease in the transmural pressure, and the aneurysm, it can rupture. Then the cerebral protection techniques should be used. The blood pressure should be optimally placed between a systolic blood pressure of between 100 to 160 millimeters of mercury. These are some of the specific procedures. I'll just briefly go through them. The commonest procedure in the interventional radiology is the intervention for subarachnoid hemorrhage. So we see some of the common complications that we can have in such patients is the rebleeding, we can have obstructive hydrocephalus, and we can have vasospasm. These are the 3 common complications, and we can have an asymptomatic deterioration in such patients in the form of delayed ischemic neurological deficits due to vasospasm again. So the treatment we do for such patients is we obliterate the aneurysms directly. This is one of the image where we have a patient with posterior inferior cerebral aneurysm. So we have now placed the coil in this aneurysm and it has got obliterated. So we can occlude the aneurysm itself, or we can occlude the parent aneurysm, the feeding artery, if it is possible to occlude the feeding artery. So we can do any of the 2 interventions. There are some common steps that may help us while in the anesthetic management. I will just briefly delineate. First of all, we hit the femoral artery. Once we hit the femoral artery, we start with anticoagulation. We pass then the microcatheter and we go to the area of interest, and in the area of interest we detach the platinum or the gadolinium coils and occlude the area of interest. Many a times we put stents, particularly in carotid stenosis, and these stents, they once we place these stents, an anesthesiologist has to be ready that parasympathetic stimulation may occur at the time of the stent placement, which may manifest in the form of bradycardia and hypertension, which has to be promptly treated. And then many a times we place flow diverting stents. These flow diverting stents, they divert the flow across the aneurysmal wall, and at a later stage they cause thrombosis of the vessel and they occlude the aneurysm. In the recent years, there has been a surge in the endovascular coiling, and a large multicentric randomized control trial was done. We showed that the patients who undergo coiling, they have better results, particularly in the posterior cerebral circulation stroke. So clipping has been mainly used for patients who had a difficult anatomy while negotiation of the catheters or where we have a wide neck. These are some of the complications that we do get while coiling of this aneurysm, and as anesthesiologists we have to be effectively be prepared to handle these complications. The commonest is we can have rupture of the aneurysm. So first of all we have to detect how this rupture occurs. We have to promptly detect it. There are various modalities. The first and the foremost is the clinical signs. The patient will have a sudden bradycardia or hypertension. And once the radiologist injects the contrast, we see leakage of the contrast. This is one of the patients that we had. We were using BIS in this patient, and suddenly we saw the BIS drop suddenly to 0. So if we are using BIS monitoring and we see there's a sudden decrease in the bispectral index, this is probably because of the decrease in cerebral perfusion pressures. This should alert us to the rupture of the aneurysms. So the immediate management we should lower the blood pressure by deepening the depth of anesthesia or various pharmacological managements, various antihypertensive drugs. Promptly an AVD is to be placed, and if possible an emergency craniotomy is to be done, where we have to secure definitive control over the bleeding aneurysm. Then there are some rare complications. We can have vascular occlusion, emboli, and vasospasm, and many a times, particularly with novices, we can have misplaced catheters or coils. So in such a situation, what we do the reverse of bleeding. We increase the blood pressure so that the blood flow it increases through the collateral bloods, and the effects of ischemia they are minimized. IV aspirin, it's not yet available probably in India. It has a role in such a situation, and a definitive treatment would be to retrieve these misplaced coils or catheters. We should remember that once these patients are listed, we have to remember 2 to 3 things in our preoperative assessment. The first thing is the aspirin. Aspirin has to be started before the day of coiling all the times. And if we are planning to put in a stent, particularly the carotid stent, we should add both aspirin and clopidogrel. This aspirin is continued for the patient's life, for the rest of the life, and clopidogrel is to be continued for 3 months in the post-operative period. Then once we're dealing these patients in the intensive care unit, many of these patients, they can have vasospasm. So subarachnoid hemorrhage patients, there are mainly 2 killers. One is the bleeding, the second is the vasospasm. Once we have clipped or we have coiled the aneurysm, the patient will not have a rebleed. So the second thing that can kill them is the vasospasm, which is very tricky. If we have a high Fisher grade, we have the presence of blood in the ventricles, the incidence of vasospasm is very severe. So how should we manage such a patients? The previous approach was to go for a triple H therapy, hypertension, hypervolemia, and hemodilution. But with the introduction of the positive emission tomography, it was seen that the first two, hypervolemia and hemodilution, they caused more of harm rather than good. So the current strategy involves only hypertension. So we should only give eovolumic hypertension to these patients. If we have a clipped aneurysm, our target blood pressure should be 160 to 180 millimeters of mercury. And if we have an unclipped aneurysm, we should keep the blood pressure around 140 millimeters of mercury. We should not forget to give nimodipine for 21 days to these patients, and then there is a role of drugs like simvastatin and erythropoietin has been recently introduced, which helps to ameliorate the effects of cerebral vasospasm. The gold standard being the balloon cerebral angioplasty or the intraarterial injection of nimodipine, which reduces the cerebral vasospasm significantly. Stellate ganglion block has been also used in many situations where we have refractory vasospasm, and it's helpful in improving the clinical condition in such patients. The second group of patients that we have in interventional neuroradiology is the arteriovenous malformations. Many of these are congenital defects, and what we see there is a shunting of blood from the arterial to the venous system, and these patients, once they come to us, we have two options, either embolization or open surgery. Once we go for embolization, there are some 2 to 3 modalities of treatments that our interventional radiologist may decide. We have the glue embolization. The glue embolization, it has the advantage that once we inject this glue, it very rapidly sets into the nidus of the AV malformation. The second thing what we can use is the cyanoacrylate adhesives. The mechanism how this once it comes into action with contact with the blood or any ionic substance, it again precipitates. And the third thing is ethylene vinyl alcohol. It's the copolymer commonly called as onyx. It precipitates very slowly. So why is it important for us as an anesthesiologist? These 3 things, whatever the neuroradiologist is using, we have to manipulate our blood pressures accordingly. So if we have a substance which is very slow in action, as we use the ethylene vinyl alcohol, we have to cause a flow arrest. So that the flow is very slow and the substance it precipitates slowly. Otherwise, we can result in complications to the patients in the form of this glue. It may go into the draining vein, it may cause venous outflow obstruction, a cerebral hemorrhage, and pulmonary embolism. And if it goes into the arteries, we can have various types of strokes. And again, once we are dealing with these patients, once the procedure is over, we should not forget that the blood pressure in such patients, it has to be in the lower range. If we increase the blood pressure, we keep it near normal or slightly normal, what may happen in such patients, we may have a normal perfusion breakthrough, which may result in cerebral hyperemia and a lot of cerebral edema. One of the commonly performed procedures that we do in the interventional lab is carotid artery stenosis. Once we deploy this stent, we should remember that it can again cause hypotension and bradycardia due to parasympathetic stimulation, which is to be adequately cared for by the neuroanesthesiologists. And one of the things that is now being practiced worldwide is the treatment of hyperacute ischemic stroke. Now, even in many centers in India, even in the peripheral health centers, this modality of treatment has started. Within the golden period, if we give a recombinant tissue plasminogen activator within 4.5 hours, it may improve the patient outcome. If we have skipped, we have not been able to manage the patient within this golden period, we can consider giving this drug by the intra-arterial route within 6 hours for anterior circulation stroke and within 8 hours for the posterior circulation stroke. So once we are managing these patients as anesthesiologists, what should we remember? These were some of the guidelines that were made by the Society of Neuroanesthesia and Critical Care in the United States. We should never delay these patients on the basis of some non-availability of investigations. The procedure has to be performed very quickly. Whatever investigations can be done as soon as possible, they have to be done, and we have to shift the patient to the neuroradiology suite. And then most of the times it has been seen that these patients, they should be operated in under local anesthesia. There will be a study that has been, that may come in the December issue of Indian Journal of Anesthesia that has been published from the United States. And the authors in this study, they have studied they have compared the harmful effects of general anesthesia versus local anesthesia. Probably once we subject these patients to general anesthesia, there are a lot of changes within the blood pressure and carbon dioxide, which change the carbon dioxide reactivity to the brain. that has a profound effect on the mortality and morbidity. So we should prefer general anesthesia whenever it is possible, and local anesthesia whenever it's possible, and reserve general anesthesia only for patients who are confused or who are not cooperative for local anesthesia. Then we should remember that the oxygen saturation has to be always above 92%, PO2 has to be greater than 60, blood pressure, systolic arterial blood pressure has to be greater than 140 millimeters of mercury, and post-procedure these patients should be monitored in a high dependency unit. Many a times once we go for a carotid artery balloon test occlusion, particularly for patients in which we want to ligate the carotid arteries to reduce the blood loss during major skull-based surgeries, we go for a carotid artery balloon test, and this is again performed under local anesthesia, and it's performed with an anesthesiologist in presence. We need anesthesiologists primarily for two things. One is if we give hypotension to these patients, it increases the sensitivity of this test, and second, while doing this test, the patient may suddenly become unconscious. So an anesthesiologist is the best person who can care for such a patient in such a situation. And last of all, we have patients who undergo sclerotherapy for various venous angiomas, and these angiomas, many of these angiomas, they may be present around the airway, and the neuroradiologist, once he injects alcohol or any sclerosing substance, once we extubate the patient, we have to be aware that before extubation that the patient has to have a minimal airway edema. So last of all, this is a slide that will try to summarize the intracranial catastrophe that occurs in such a situation once we are in the neuroradiology suite. Sorry. We can have two types of complications. We can have either an ischemic complication and we can have a hemorrhagic complication. The management of hemorrhagic complication, once we have a hemorrhagic complication, we have to immediately reverse the effects of antithrombotics, particularly heparin. And if we have an occlusive complication, we go to reverse of what we do in a hemorrhagic complication. We increase the blood pressure, and at the same time, we increase the carbon dioxide. Once we increase the carbon dioxide, we go for a permissive hypercapnia. We take the carbon dioxide to around 60 millimeters of mercury in such a situation. So any substance that has inadvertently got into the brain, once we dilate the venous channels, it facilitates its egress out of the brain from the extracerebral circulation so as to minimize the harmful effects. Thank you.
Well, the time is short. We'll invite one or two questions from the audience.
What type of anesthesia machine you have? You have got a
So we have a detect-omeda ventilator. We have a workstation with a remote monitoring facilities. Yeah, we are using inhalation. We use a balanced anesthesia technique. Depends on the case to case. We use sometimes total intravenous anesthesia. We use inhalation. Depends on the particular situation. In AV malformations, we do not use inhalation, but once we have aneurysmal subarachnoid hemorrhage, we use inhalation. Pediatric patients, we use inhalation also. Once we get vein of Gallen malformations, we use inhalation.
No more question? So that's how we saw that the radiology, neuroradiology has made our job more interesting, rather more demanding. Especially this stroke treatment has come into our purview now. Intraarterial thrombolysis or thrombectomy can be done at any time. It is usually emergency, demanding more from us, but also nevertheless it is more paying, more satisfying, more in fact interesting professionally. So that concludes the presentation of Dr. Zulfikar Ali.
What type of mortality you had last year?
Pardon, sir?
Mortality after the neuroradiology.
Mortality.
In invasive neuroradiology. procedure?
So it depends on the cases. In diagnostic angiography, there is no mortality, but once we go for this aneurysmal subarachnoid hemorrhage, we have around 20% mortality. Not on the table. In the ICE table, we don't have.
Table, no.
On table, I remember just one. We had a bleed in one patient. That's one mortality in around 4 years.
No. So thank you, doctor. Thank you so much. Very informative. Little lengthy. That's why we could not get time for questions. So over to Dr. Aditya for the next speaker.
Our next speaker is Dr. Mohan Manoranjan.
Mohan Maharaj.
He is medical director in HOD, Department of Anesthesia and Critical Care and Care Hospital, Visakhapatnam. He is chairman of ISCCM Visakhapatnam. His topic will be disease and donor management. What is the Indian perspective? I'll request you to stick to time. It is 25 minutes so that we can have some time left for the discussion later on, question and answer. Thank you.
So, sir, just before going to the talk, I just want to ask the audience that how many of you have been having experience of declaring a death and donating organs? Can you just raise the hands? Very nice. Thank you very much for your. I'm sure, sir, your experience is going to count as a lot, and I'm sure. Because this is one of the important, and neuro anesthesia has come, but the important point here is that what is in India? Because in India the population is very high, and we know there is no safety gateways properly into the Indian system, and we don't respect that properly. At the same time, the population is, even though it is high, and the life importance is less in the common public because insurance system, other activities, and the people what they do, lot of bad roads. In this system, whatever it is having, you are going to have a lot of almost 5 deaths per day is going to occur. So in this scenario, if you really have a proper system of all the system of doing, declaring or identifying and donating, that really gives us a lot of demand supply is going to reduce. So I feel the problem here is the hostile environment of the doctors and patient relationship in the present scenario, and also the tension of the doctors to declare a death, also ask for the organs. And over and above, we have a difficulty in having a green corridor and making the transportation system and the time, and only 300 there are centers in India who are going to perform this organ transplantation or only recognition of retrieving. So all these things put together, it's a very difficult to have a number of patients and having the organ transplantation as far as like other countries. If you come to the Iran, where they actually have a legalized system where the government gives the money, at the same time a recipient gives the money and they can still donate officially. So whereas like the good promotion in Israel and Netherlands are actually having a good promotion of this. But still, in spite of all these problems, these are the heroes who have had a brain death, and particularly relatives have given the consent about giving organ donation, giving the life to the further people. But the skill set is very important, where you really have to have a lot of different skills of communication as well as convincing method. And finally, Buddha says, chaos is inherent in all compounded things, strive on diligence. So, coming to the death, we all know before 1960, only the death is because of the cardiac death. We never knew about, not very much particular about donation after neurological determination of death. So it has come only after Minnesota criteria, and it has been confirmed, and we got all the criteria, how you are going to diagnose, how you are going to say, the different 2 types of diagnosis of death and where they can do. But like in India, other than the living donor, we have a donor after cardiac arrest and donor after neurological determination. It is not available in India, it is available in abroad because the time duration, the costs involved, and the teams are what is going to do in the operation theatre just before, and having it should be separated from the end of life issues, because that conversation is different from that to the patient and the families and doctors and after, because you will take to the patient in the theatre and wait for 1 hour, and after 1 hour it doesn't die and come back. So that system is not available in India yet. So, but at the same time, India, in Maharashtra actually in 1995, the court has been told compulsory that if the determination of death of neurology occurs, you have to declare the brain death. But all other states has to follow. But India follows UK concept of brain death system. Coming to the history of transplantation, 67, the first kidney transplant done in New Delhi and AIMS heart transplant done, but we could able to do in our center only in 2010. And other centers of Chennai and regarding heart transplant and multi-organ, 1999 pancreas in Ahmedabad has been done. The system in India is that we have a Minister of Health and Family Welfare, who is going to be there, who is going to take care of this, and the National Organ Tissue Transplantation Organization. What it is presently in India, tomorrow on 27th, there is a 9th organ donation day is happening in Chanakyapuri in Delhi tomorrow. So, and it has a regional organ tissue transplant association is there for every region, and SOTTO, that is a state, each state will have its own. But particularly in South India, it is very active compared to any other states and other than the Gujarat and Maharashtra. The maximum number of transplants are occurring and maximum number of organ donations are happening, and each organization hospital can recognize either for the only retrieval or for the organ transplantation, depends on the availability of all the systems of skill and equipment as well as the permissions. They call it as a Gazette of India. It has been given in March 27 of, particularly it is come in 1995 Act. Later on it has uploaded and approved by the 2014. I don't know, maybe they call it a Chaitra Masam 6 1936 is a local number, what they give it is as per Gazette of India. And for a living donor, the difference is that who is going to give the priority, because it's particularly only actually there's a lot of racket is going on in many places happened, and people have been problematic and giving legal problems have occurred in particularly in some areas. In recently something you must be knowing about how they have been conducted and put the people into the bar, behind the bars for many doctors as well as the medical directors. And but with this situation in India, to improve the system, there is a proper legal system in Gazette of 2014. If you go through that, each point is clearly mentioned. That's the best way of doing it. To do this program, you need to have a permission with this type of example of permission what they will give after having inspection by the concerned authorities and the medical team. And only thing is, whenever you have a donor screening, laboratory test and procurement of other procedures, and this is the particularly, as I said, documentation and communication is very important in the system. You need to have one fulcrum of the person who is going to be associated and passionate towards doing that, otherwise difficulty, and maintaining the quality management of it is very important. And recipient information should be official, and where people has to be communicated and said that who is going to be allotted. If you see about it, when you come, like after this, all these things, the patient has been have a motor vehicle accident, or there are three types of which can happen, because it has happened because of either you see aneurysm bleed, or because of the hypoxic difficulties, or because of the brain accident, and which is going to be irreversible damage. These kind of people will give the brain death, will cause, and that when you have doing that after maintenance, we will come to know the pathophysiology. But prerequisite of apnea testing doing is core temperature should be normal, and evolemic or positive fluid balance should not be there for previous 6 hours, and normal PaCO2 and normal PO2 of pre-oxidation for 15 minutes to be done, and do the pre-oxidation test, which is very difficult and which is need to be particularly is a role of intensivist. And before doing that, we should do oxygenate the patient and baseline ABG to be done, and look the difference between the 20 mmHg of difference should be there whether it's high or COPD or normal patient, and make sure that the complications can occur because of the hypotension, or the people who are having the age of less than 18, you should have a different protocol, and significant oxygen desaturation or desaturation arrhythmias can occur. When you are doing that, you should follow the ACLS guidelines. Interpretation is that we know that when you are doing apnea testing, once there is an increase in 20 mmHg of difference of PCO2 without any respiratory stimulation, and it is being confirmed, that means there is a other than the deep reflexes of the brain or brainstem. Particularly when it comes to this one, there is a lot of facets, including the doctors. We have a problem sometimes when you are mentioning with the patient admin, you should be able to say that yes, there are spinal reflexes can occur, and normally it happens like this. Just can you please can you just do the video regarding video. So it's just only 10 seconds of it. Normally this is one. Normally whenever the patient is having a brain death, sometimes there can be spinal reflexes can mix, which is misleading. That's more dangerous. It can happen to the plantar reflexes. It can happen to the hands. It can happen to the movements of this one. Look at this patient when they are doing it. Only the neck movement is happening. It's not happening with any other movements. So sometimes because of this, because you put a pressure into the jaw or TMJ joint as well as a glabella, but still there is no movement. Even the sternal pressure, there is no movement. But only when the spinal reflexes at the neck, when you are turning the neck, he is having a very clear-cut movement that is actually considered as spinal reflex, should be informed to the patient before itself and patient attenders. So these are the things normally can happen. Hemodynamic instability can occur, or pulmonary dysfunction can occur, or chronic CO2. When the COPD is there, there can be misleading of the CO2 will be there. So you have to monitor or mention or treatment by doing this vasopressor, the pre-oxidation and target CO2. This is how normally we do the pre-testing. And if we have it legally, we have a very standardized protocol for Jeevandan program, which has been there for 2010 in Andhra Pradesh, in Hyderabad before splitting Andhra and Telangana. Now in AP, Jeevandan again is there in 2015. Particularly these things are very compulsory, where you are supposed to do after having a proper documentation. All the reflections should be checked. Almost 10 points has to be there, which can be done by the intensivist or neurophysician can be done, with which looking into all the nerves of the cranial nerves. Then confirmation of that to be done. Then we have a local system where the authority, the permission has given little more liberalized to improve the organ transplantation. That's why even the physician, treating physician, previously only the neurologist and the second neurosurgeon has to be confirmed. Now in India, it has been liberalized, saying that even the practicing doctor who is treating the patient in intensivist can declare the patient brain dead, and the hospital authority should be able to do sign and confirm this. And online has to be uploaded before, and it goes to the LOTO and they allot the organs. So this is what is brainstem death confirmation. After doing that, they will allot according to the waiting list of the patient who is going to have this one. How it happens in the flow chart? Once the brain death occurs, there is a Form 8 and that's called Tissue Human Organ Transplantation Act has come in 2014, and you have to fill the Form of 8. Near relative consent has to be taken. Please understand near relative consent. I would like to be very happy to say that we have experience of 50 organ transplantation program in our institute for last 8 years, because we are the maximum number in our state, and that's why we have a lot of legal problems have been faced. We understand the problem of this one. Only thing is spouse is important person to give consent. Otherwise the parents, next the siblings, next comes to the whoever is going to be as per the whoever and the position of the body. And the second brain death has to be done after 6 hours of the time first brain death is confirmed. And normally if it is a pediatric, it decreases to 12 hours, and if it is a neonate, it goes to almost 72 hours. But there is no below 37 years cannot be declared brain death. And there is an inquest officer. The 4 people are important here, particularly other than the coordinator. There is a police people to be informed. We have to tell them beforehand where they can come and do panchanama in the hospital itself. And the forensic medicine, who does the forensic medicine or postmortem in the hospital itself at any point of time, we are giving the authority by the collector. Then the organ retrieval occurs. And depends 24/7, because that again have a lot of problems. The patient is telling them, no, I want the body by tomorrow morning, otherwise I don't want an organ transplant. These are the problems we face it, and then the body is handed over to the patient itself after postmortem. He is a one important person in any program, particularly for transplant coordinator who has to take care of this one. His position is like that, everybody is pulling. If the liver transplant program, people coming that they ask for that, no, you wanted a sodium low. And the heart lung transplant people will come and say that, please reduce the fluid, I want dry lungs. And the kidney fellow says, give the more fluid, I want more urine output. And the heart fellow says that I want echo and wait for another 12 hours because there is a sudden storm is there, the heart dysfunction is there, I want to improve it. But still all this coordination comes with the transplant. He has to go with the family, and the documentation is very proper to medical legal, surgeons and anesthetists and clinical people, and the transplant physicians, hospital people. Everybody has to coordinate, and donor consent form retrieval allocation transplant follow-up has to be done, and following up and uploading the system is very, very important. It's one of the important person where he has to take. Consent, as I told you the rules, the consent has to be from the whoever is in the authority position, and next to kin is important. But here I have been seeing that we got into the court of recently, the parents have given a consent, but wife could not attend. She put me into the court saying that no, I have not given consent. It happens like that. So this is what is the form what should be full, and taking the consent. Even the video consent is not sometimes valid. The document is more important, including attaching the video consent may be useful and more beneficial. Death declaration, every one of us knows after MBBS feeling that when we do the death declaration, cardiorespiratory arrest we write. We are not supposed to write that. There should be proper way of writing a death declaration, and it is not called a death certificate, it is called death intimation. Death certificate given by the authority of municipality. So here what we need to write is that what is supposed to be done of all 3 causes has to be written properly. Finances, I know, to conduct this conference is almost 2 to 3 crores of expenditure. The same way when you have finances of the patient, when you are doing the organ transplantation, once the brain death is declared, then the money the donor is not going to pay, the patient is not going to pay. Either hospital has to take care, or the recipient has to take care, or the system has to take care. Administration takes care of it, and for the protection of the law, it is the responsibility of the hospital, and nobody is going to protect us. So this is what, as per the gadget has been mentioned, how you are going to take care of the finances. Handing over, please understand this. As I told you that the cause may be medical legal and non-medical legal, because like aneurysm bleed can be medical, non-medical legal. There the body will be given, handed over to the patient and attendants, not to the police. But whereas all others it has to be handed over to the police, then they will hand over to the patient. That should not be missed. Very, very important. So this is how normally should be done. And for this procedure of donor organ tissue, medical legal cases has to be properly followed the rules. Challenges, there is a huge gap between the demand and supply, we all know about it. Almost lakhs of people are dying because of not having it, and the present scenario of end-stage renal or kidney or lung or heart diseases, what's happening, and having age is increasing as well now, the people's expectancy of life is increasing, the supporting system is increasing medically, so all this is going to be one of the important things. So that's why intense-based role who has been participated in the system of this organ program is actually improve the recovery of the organs and improve the graft sustenance or graft improval. It has been proven study by Anglo. And the issue is that in this, what is the number of patients allocated, a number of organs, not only the cardiac, other things. So here comes the optimization of the patient after the breakthrough is declared. The problem is that you have been changing from ICP management to the optimization of the management. The antagonistic requirements, I don't know that kidney requires more fluid, lung requires less fluid. And resource management, because every hospital may not have all the resources need to be, and license takes important. The role of intensivist is very, very important, where he is going to change from the CPP pressure of monitoring or maintaining to the hemodynamic stability and diagnosing the neurological death not only before itself, like you understand that who is going to die, who is going to die. I mean, the outcome, as he was telling that when the Jesus is falling down, not improving, when you go to the theatre, we know that we go for a decompressive cranial, by the time we decide, no, it cannot be done. So the counseling of end-of-life issues is a separate issue, and preserving the option of organ donation, like what you are going to do, because they may say no. So that's why you need to have a separate people. The same doctor is asking, they may say it is some problem with or they are going to sell the organs. That's how the people say. Like for example, whenever we are having the blood you are going to pay the money and get, even if you donate, because this system is going to cost. The same way you have to explain them properly. And maximizing the likelihood of successful organ retrieval, it's in the place of hands of intensivists, and implementing appropriate management of strategies. Hemodynamic management is one of the important key factors what we need to understand. Perfusion, we understand to maintain the perfusion, to have the proper organ perfusion, to have a long-term good recovery and replacement, and also after transplant there is an early transplant rejection or long transplant rejection. And early transplant rejection is more problematic compared to the long duration of transplantation. Intravascular stenting is the euvolemia is the state of art today, and it has to be should not be given, always maintained either by the static or dynamic measures, and cardiac output should have a 2.2 index to be maintained most of the patients. Crystalite, there is a lot of debate between the normal saline and linger lactate as well as the colloids of HES. When there is a study between the 100 kilodaltons HES and 200 kilodalton LDL, HES you are given, but it is beneficial because what happens is when you give HES, it can cause coagulopathy, it can cause acute kidney injury, also in the liver cells it can absorb and can cause edema. That's why better not to use it and give only the normal saline or linger lactate. Keep it in mind that keeping the normal saline more sodium may increase, it should not cross more than 155 is an important point. And particularly whenever we know that from almost all the guidelines we are not supposed to use immediately, even in 2003 study when they said, because that was the time where we are still using a dopamine. So 10 micrograms per kg what you are giving it, that was a chance of improvement they said. Particularly for heart, if you have a noradrenal more, the recovery is less. But the normal dose what you are supposed to maintain after fluid perfusion properly given should be used, and vasopressin can be used not only as a vasopressor, even for the HRT harmonic replacement therapy. So this is the maintenance of MAP, we all know that, and particularly for not only routine patients of less than 40 years, heart transplant is one of the important modality where we can see 2D or TTE or TE, because particularly because of ventilation and PEEP effects, you may have to use more of TE compared to TTE. And looking at the fluids, mixed venous oxygen saturation, lactate, we have to measure and look into that. Normally what happens normally we don't call it as a brain death, we call it as a determination of neurological death. So here what happens is there is a catecholamine storm. Catecholamine storm is not going to occur for long term, it is most probably only for 8 minutes to 30 minutes, but in this there will be a lot of deterioration, so you should prevent it at that time, you should be alert. But it should not be more aggressive, because later on it may go into hypotension, indirectly as direct or indirect measures of this one, cerebral systemic inflammation can occur. So the both methods, what is going to happen when there is a coning and the foramen magnum, the coning is occurring, almost it's converting from the cerebral anoxic metabolism. When it's going to the oxygen metabolism, anaxic metabolism, this is what is going to reduce. Hormones are going to reduce. There is no release of the hormones. That's why you are supposed to support from externally what they say. But how far it's going to be useful as per the mortality has not been benefited proven. But there is a few studies, particularly when you look at Papsworth Hospital in Great Britain, the one study when they said it is going to be useful and they have used it. Hemodynamic instability and metabolic failure can occur and deleterious effects on the potential organ donors. There is a lot of inflammatory response and that causes this problem. And 80% of the patients of brain dead patients will cause diabetes insipidus, and in this normally we can just see polyuria and hypernatremia. This is the two things which you know. Normally we need to maintain of 1 ml per kg body weight, and if it is crossing more than 3 to 4 ml, 4 liters or 2.5 to 3 ml per kg, we should suspect diabetic insipidus, and you can treat with vasopressin, or sometimes depends if the less and not having a hypernatremia is not an issue, then you still can use a low dose of desmopressin. And the dose you can use is arginine, vasopressin and desmopressin can be used concurrently if the patient is having other electrolyte imbalance, particularly hypomagnesemia, hypophosphatemia, all these things occur because of the high urine output. But still you have to consider that when you are using this vasopressin and desmopressin. Steroids, as they were discussing, our chairperson previously discussing about spinal cord injury, or whenever they are doing a discussion about steroids, there is some rare centers they are using. The problem here, you need to keep it in mind that when you are using steroids, be careful that when you are sending for a kidney HLA mapping, it can suppress the inflammatory system, so you should not use or take the blood sample then to use a steroid. Normally we give is methylprednisolone. And thyroid, as we know that there is a hypopituitary axis of where is having hypoxia and having this problem, and also after resuscitation of the fluid, if the hemodynamic instability, still that can be managed and maintained with the thyroid. That's one of the thyroid hormone you can replace. In India, not regularly available in IV, only one or sometimes they get it from outside and use it, but here we normally give 300 whatever you are giving the thyroxine through rice tube 3 times a day, normally we give in our center. And we all know about ICU protocol of hyperglycemia should be avoided. When they have studied almost 73% of the patients post-transplant, when they did, it was almost 200 above milligrams of grams of deciliter glucose was been found in the retrospective study. Only 29% of people had more than 250. So the issue here is that maintaining the glucose, because osmotic dialysis occurs, that's the reason that we maintain below 180. And it is difficult to avoid dextrose containing solutions, because you say that whenever you are using sodium more than 155, it's difficult for the liver because the graft rejection is more. So that's the reason that you have to give dextrose or free water to the rice tube. So very difficult, but still avoid. This is all organs we are actually doing. We are doing heart, lung, liver and kidneys, and we have not done lung, but we did 2 heart and kidneys and 31 livers, almost 300 kidneys. And the conflicting data of here is that no concession on the ability of the monitoring cardiac enzymes in a cardiac donor, because there is no proper way that cardiac enzyme is going to give us information. It has to be only the 2D a regional motion abnormality. If the ejection fraction is less than 45, better to give a steroid. And also you support with the system of, and after 12 hours again reassess the patient. Because, and if the arrhythmia occurs, always use a short acting, maybe like Esmolol. Kidney imaging, previously to say imaging very important, because whether edema is there or whether any tumors are there, anything is there particularly. Now it's not of much of useful, only looking at the urolemic state. And please, 2018 paper, there is no term called CAN, contrast induced nephropathy. It has recent paper has come, we have to keep it in mind that. So actually it is only the fluid to be given before anesthesis, we are giving it, but in the patient type is actually giving a nephropathy, not really. The contrast has been studied recently, the new paper has come. So optimal use of vasopressin is always beneficial and important. For liver, I know that you need to maintain as organ perfusion of 60 to 70 and avoid hypernatremia. And part of the nutrition, gluconeogenesis and store of the glucose occurs in the liver. So that's the reason that continue the nutrition till the last minute. And imaging, particularly living donor, is more important for a donor of the patient. Of deceased donor, it's not much of important, but only the looking at if required, you send for the biopsy. You see the frozen section and see if any problem is there. Lung, only 15% of the patients will come actually these men. When you look into all these criteria, all the lungs will not be useful. So when you use all these criteria, only the 15% lungs are useful. But there, what has happened is that when you are using that now, there is a lung donor management protocol is there particularly, either giving a lung protective mechanism, giving it, and so that more use of lung, and like compulsory thoracoscopy, either removing the blood clot or removing the secretions or removing that is improve the lung transfusion or also accepting the lung which is not acceptable. And particularly when you are doing some patients, they have actually removed the lung from the brain death and did outside ex vivo, and still some are being useful, and it is a retrograde study of 27 patients have been studied, and there they said that the outcomes are going to be almost same as 70% of either this or not. Pancreas is one of the low flow organ. Yes, be careful about edema. And small bowel, we are not particularly doing in India much. Maybe one are doing Mysore, I heard last year. And in India, actually, if you remember Nirbhaya case in Delhi, they have been sent to Singapore for medical legal case, but otherwise we are not doing much. And the povidone IV should not be used. And simple way of crux of it, which is going to be more useful, which is going to be less useful, which is actually not, but it still we follow all these things. Matter of time pushing it fast. And analgesic should be used, particularly because when the patient is having a storm or having it. Muscle relaxation is actually not required brain death, but still because the spinal reflex is problematic for the surgeon, it should be used. And hemodynamics maintained till the last moment. Very, very important, because that is what maintained useful for the organ donation must. This is how the organs will be taken on order. And this is the time what we have before, whether you make a green corridor, when you make the patient transplant, so how you have to make the 2 theatres ready, or the logistics, what you think about mind, this time should be maintained. Weight listed allocation heart to heart depends on the patients, there is all, it's been written. And the position statement of the ISCCM, what is available, or if you have the 2003 article of what you can do, or 2014 TAO Act, these are the 3 things which give you a lot of information of how the allocation has been done, whether liver, heart or lung or liver, and the small intestine as well as the pancreas. Particularly they match the blood grouping, accordingly they look at this, whether government or private. If it is government, it goes to private, if it is private, it goes to private, and depends on the waiting list. These are the criteria, they look at the scoring system. For a kidney, this is the scoring system they follow, but there is a previously they are going to add this more towards saying that the previous organ donor we are going to improve the point plus 5 month points are going to be given. So this is one point I wanted to remember. This is how the allocation of the kidney has been done. So particularly whenever you remove the organ, examination reduces the intravascular thrombosis, and you normally use a lot of solutions you have come to know, and hypothermia reduces cellular metabolism, and you say reduction of oxygen species mediated damage after reperfusion, because you have a ischemic perfusion re-injury, that reperfusion injury will cause, and you should be able to do that. Susceptibility to cold ischemic injury, and just be careful. And particularly you have University of Wisconsin solution, and you got it as a, when you have a HTK solution and custodian solutions which are very costly should be kept in your organization, so that which is very going to be useful. Depends on 1 or 2 for liver, maybe you require 2 or 3. Each one costs almost 25,000. There is a supply demand problem in India, and particularly if you look at our center, almost in Andhra Pradesh 50% of organs is given away only in our center. You can see in the internet. So particularly any work you need to measure, there is a quality system. So this is how it is going to be: donor detection, declaration, viability, maintenance, individual recovery, distribution. And these are all things which should be maintained in the protocol, like how you are supposed to take care of structured process of any quality management of the patients of any organ, procurement or transplantation when you are doing it. So in our hospital we have done 2 heart transplant, and we have done 5 heart retrievals and given to some other states, particularly in Chennai. And almost 300 out of this, only the cadaver is only around 20, and when come to the 2 living donor and deceased donor of 29 livers we have been done in our center, and we have retrieved 3 but we did not do. So our experience is almost 50 cases which we have done for the last few years. Finally, we all know that the problem here is the people who should be very much aware. The press media is very, very important how positive they are going to take, and he is going to decide the time. No, I want my body, I have to do the puja. So they will come and say that no, this time I want it. So that's one of the important things we should take. The police should come to the hospital, and the postmortem should be done in the hospital, and the lawyers should be aware of it. Otherwise, they will put you into the nonsense and uses of the time of this one will happen. So be careful about it, make them aware properly beforehand. This is our team, what we use for all these years. And this in Netherlands, they are actually having a statue himself who is having a memory of organ donation, and make sure that we all should pledge ourselves saying that yes, we will be giving after, because we don't know who we are going to be born. At the same time, we don't know when we are going to die and how we are going to die. So better we give a pledge of our organs, because if it is a brain death, still it will be used for other 8 persons to live the life of a
Maharaj, your time is over.
Over. Like, this is the last time. Thank you.
Also,
thanks.
So friends, we have been advised by the organizers not to go for any question answer for this session because we already have taken the time for the question answer as well. It was very, very informative. Yes sir, why not, why not? It was very informative talk by Dr. Mahajan. He put a lot of effort, he has taken, in fact he has taken a lot of effort and done justice to the talk, but the time unfortunately is not in our hands. Yes sir, very brief questions.
Please sir. There is actually, if you see 2000, no separate book sir. Even the guidelines are not approved. Only the Position Act and ISSM it is available, how we can manage. In the website of Jeevandan, there is a guideline how you are supposed to optimize the patient of brain death or organ donor management. Yeah, as a Jeevandan, it is available. That's what is what we said about optimization of everything is available, sir. Yeah. Thank you very much.
Thank you so much.
It should be done in the hospital. No. Police people will inform the forensic people beforehand. There is a collector and the forensic person will come to the hospital and does it and give the report there itself. Yeah. Any point of time, 24/7. Thank you. Thank you so much.
This brings us to the end of this session.
One important announcement to make: all the quiz will be held in Hall F. Instead of this hall, it will be held in Hall F. Now I would like to call Dr. Anurag Gupta and the chairpersons and the speakers to collect the memento. On the basis of the theme Green Agra, we decided to plant trees. These trees will be given as mementos to you and they will be planted under the name of Isagon 2018 and will be taken care of. Dr. Aditya Kumar, Dr. L.D. Mishra, Dr. Akhilesh Gupta, Dr. Zulfikar Ali, Dr. Mohan Maharaj. We would request you all to come on the stage, please. Thank you everyone. Our next session begins at 3:45. Thank you.
Last session of today about pediatric anesthesia. We got two important topics. These are important not only for the postgraduates but also for all those who are in pediatric anesthesia. First, we got a lecture on regional anesthesia and pain management in pediatrics by Dr. Ajit Gupta. He is professor and HOD of Department of Anesthesiology and Critical Care, Indira Gandhi Institute of Medical Sciences, Patna. He is professor and HOD since 10 years and he is Dean of Research. He has been guest faculty to many medical universities. He is a postgraduate MD, DMD examiner in different universities. He has his credit Lifetime Achievement Award by Times Group in 2016 and he has got 22 index publications. Over to you, Dr. Ajit.
Respected Chairperson, sir, and I'm thankful to the organizers for giving me the opportunity to speak before you. And I'm coming up with a topic which in the past is being discussed a lot, because one of the modalities of treatment, especially in the pediatric age group, regional anesthesia, and of course the pain management in the pediatric patients. In the last few years, say 20 years, I will say that there was a myth that pediatric patients do not feel pain. Usually this was proved unscientific, and if the pain is not relieved in the patients of that age group, adverse consequences and outcome is there. And this was because of the insufficient knowledge among us, inadequate research, lack of pain assessment protocols, and fear of sedation and side effects of the opioids. Initially, we were having only opioids and some analgesics for pain management in this group. And there was a disparity between the adult and the child pain management. So the things didn't move very forward. After a lot of research in the past 2 decades, it was proven that after 26 weeks of post-conceptual age, there is sufficient maturation of peripheral and spinal afferent nerve transmission. And of course, younger children, even after being opioids and benzodiazepines, they develop tolerance. So all these things led to us how to manage the pediatric patients. With the development of so many validation of the different pain protocols, encouragement of the research in analgesics, and definitely the multimodal approach of any management, either it is pain management or whatsoever in the way we manage the patients in the perioperative period and in the ICUs. This has developed, we have developed suitable analgesics for pediatrics. We have improved our central nerve blocks in pediatrics, and different peripheral nerve blocks are now, it is very being used common. So I won't go into these things, but there has been some controversy between how to assess these patients between the verbal and non-verbal groups. This includes the psychologically deficient patients also, who have not developed different, mentally not up to mark children. And that led to the development of the various pain assessment tools. These were validated, cross-checked, and are now being used very regularly. Some of them are very well commonly used every day, Homebakers or Barry Face pain scale or Manchester pain scale or vertical visual analog or transverse visual analog scales, horizontal one, and outserts, that is in different groups, geographical is places. This differs. This is for the Caucasians only, this face pain scales. And the pain, what is it? Pain is a complex thing. Nociceptive stimuli from peripheral part goes to the spinal cord and cerebral cortex and influences the emotion, behavior, and it is affected by the emotions, behavior, past pain experience, and different synapses in limbic, frontal cortex, and thalamus. So that led to development of our pain management protocols. Opiates and other pharmacological methods are good for moderately severe pain, but for severe pain, use in a higher dose. and that leads to a multiple side effects. Even in the lesser doses also, it can cause pain, different side effects. So in the last 2 decades, regional nerve blocks has gained popularity, and it has added up to the pain management group with the development of different pain, pediatric pain, pediatric surgery departments. A lot of demand has been done. A lot of pediatric surgery is being done everywhere. Different departments are there as a super specialty pediatric surgery. So the pain management has also a burden, say, demand from the surgeons and the society for the anesthesiologists to develop this skill and to use and keep the children pain-free. So the regional blocks gain popularity. All this in a nutshell have demanded for better management of the pain. Regional techniques reduces the need of the opioids and other analgesics. Discharge delay of the daycare surgery. PSU resource demand also reduced. Nursing demand in PSU is curtailed. Hospitalization is also curtailed. Associated cost is curtailed. And rehabilitation time is also reduced. So, the foremost consideration in the regional block, before we go for the regional block, few things should be very clear. What we have to do. Don't give too much of hope to the understanding child or the parents. Parent and parental consent is a must, whether they accept it as a modality or no, or they refuse. Are there any absolute contraindication? Most are relative, except a few. All of us know original techniques. Discuss the procedure with the parent and understanding child. Then never gives expectation of absolute pain-free window. Because if suppose your original block has decreased, you have to supplement it. You have to top up. So they will expect, you had told me that it will be completely pain-free procedure. So no, don't give too much of hope. A limb or part of will remain without sensation or with some certain motor block for certain period. That will pass off. Beforehand, you warn them that this may be the reason. And moving the child from, say, bed to stretcher to bed will be a bit of part of concern. So they may not get distressed of that. And of course, the children with substance abuse and rehabilitated children need more, modalities and alternative analgesics also, even for the psychological, satisfaction. So children need more precision during the regional block, as needle length, anatomical depth, drug volume distribution, termination of a spinal cord and epidural sac, and total dose of a local anesthetic and adjuvants are quite different from the children, adults. Nerves are easily blocked in the children because thin myelin sheath is there, thinner diameter, and loose surrounding tissue. So the spread and block is usually in a better with a lower volume, lower drug dose of the local anesthetic and adjuvants. So there had been a lot of controversy whether to practice regional block under GA or deep sedation or not. Should it be given? But the American Society of Regional Anesthesia guidelines always preferable to have an immobile child. Protests because they protest needle prick, nerve stimulators, cold transducers, transducer. And that was from in the 2008 that evidence came on. So another, whether there is, complications rate is more or less. So central or peripheral blocks, single shot or continuous infusion, perioperative complication and found in regional anesthesia is less. It is a safe technique. Some articles came that regional blockade when performed properly carries a very low morbidity. Another This is a big study. That also regional anesthetic technique in their clinical practice, they provided superior and long-lasting anesthesia without risk of respiratory depression. Opiates always give concerns. Then another study that is all suggested that it is a safe technique. So overall, the regional anesthesia is a safe technique, safe modalities, while either you add it with general anesthesia or you use it with say time tested the opiates and another drugs, analgesic drugs as a supportive treatment or as a main treatment of pain management. It will be always be a beneficial one. And local anesthetic with another drug prolongs the efficacy and duration of block, usually blocks impulse propagation, but the systemic absorption and the chances of seizure is always there, is increased. Apnea may be there, arrhythmia and cardiac collapse may be there. So always you have to be very careful. So maximum dose calculation in children is a must. Chances of toxicity is more with the infusions, prolonged elimination half-life. If there is continued infusion, we are using for longer period. Decrease of seizure threshold, of course, in cases where there is history of convulsions, there you have to be very careful, reduce the dose. Infants have low albumin and alpha protein, glycoprotein, so poor binding of local anesthetic and high free circulating drug. So the toxicity may be more if you exceed the dose. You all know about the different doses. Bupivacaine, cardiotoxicity is high, but still the first line choice. Usually single bolus dose you have not to exceed more than 3 mg, 2.5 to 3 mg. Infusion 0.4 to 5, but in infants and neonates you have to reduce it to half. Usually we reduce it. Bupivacaine is usually intramarically pure LA, less cardiotoxicity, less motor blockade. Equi-analgesic dose is 0.2 to that is with bupivacaine. Loading dose for epidural 0.2, and volume concentration should always be there, not exceed more than 1. So Levo is also in use. It is also a isomer of bupivacaine, has less cardiotoxicity, but not very much tested in say not too many articles in for regional anesthesia and children. More needs more. Chlorpropene just come few years back, 2, 3, 4 years. It is also under trial, and both the drugs needs more study. So it always be considered to that regional blocks are used in child under general anesthesia. In our setup, we prefer to do it. Hence, a diluted concentration of local anesthetic gives a good analgesic effect by supplementing the pain of reducing the dose of analgesics. At the same time, safety profile is increased. It is always better to calculate bolus and infusion doses beforehand so that toxic doses are not raised. So adjuvants like morphine, fentanyl, butyrophenol, clonidine is also good. Local anesthetic we add with the local anesthetic. These are the doses which we use with local anesthetic to add these adjuvants. And regional block cards should always be ready with whenever you are going for regional block. All the needles short beveled because the anatomical depth is less, so short beveled, shorter length. Sometimes you need to use the peripheral nerve stimulator, so insulated nerve needles, and peripheral catheters. Preferably we use nylon or polyamide because that one is kinkable, but the chances of kinking, unless you force it, it is less. So chances of misplaced catheter tip is very less. Even the imaging has reduced it. Fluoroscopy, X-ray with contrast or ultrasonography. A bigger study with 724 epidurogram showed that there is only 11 misplaced catheter tip. So it is a good safe technique, and if you use diluted say contrast, it can give a better result of the catheter placement. Commonly vector blocks, you all know. Caudal, lumbar, epidural, thoracic or spinal. Nowadays, with the because it causes the age, more sympathetic blockage. So you avoid, because we are getting a better result, blocks in a better way, better managed. Most commonly used is the caudal. Still, in our center also in the pediatric surgery department, and we use a lot of caudals, preferable in children up to 7 years, easy to have less failure rate, but the failure rate overall is approximately in caudal is 20%. These are the locations of the catheter tip for the different types of surgeries for epidural. So, alternative to neuraxial or intravenous method of pain relief, the peripheral nerve blocks. Ease of block, side effects are less than IV analgesics. Minimal sympathetic blockade is there, less hemodynamic instability, better sensory block, less motor block, and chances of catastrophic hematoma or PDPH is minimal. So, you all know, I don't need to repeat, but still, for upper extremity, brachial plexus block, interscalene, supraclavicular, intraclavicular, axillary we use. Now, I will escaping the blocks can be individually be blocked. Truncals, these are the list of the truncal blocks, paravertebral, tap, rectus, hernia, penile, and for lower extremity, femoral, sciatic, popliteal, saphenous, ankle blocks we use. Useful in lower extremities, long bone fractures and any trauma of the lower and inflammatory pains in the lower limb. These may be helpful. So, suppose I talk about the interscalene or tab block, whatever it is. There was a workshop yesterday on the regional blocks. So, talking theoretically on these blocks I think it's not going to mean anything. It is a hand-on training program that the regional blocks should be practiced on the patient or the spot on the mannequin, and it will give a better idea. But there are some cautions. Local anesthetic may spread to the C3, C4. Used for anesthesia over the soleus and clavicle. Vertebral and carotid artery are closed, and hence minor IV injection may be catastrophic. Injection in the nerve root may cause complete spinal anesthesia. Phrenic nerve may get blocked and cause respiratory depression. So any child having some respiratory compromise, better avoid it. Recurrent laryngeal nerve palsy may lead to the airway compromise. You have to be ready for that. Unilateral Horner syndrome, usually an accompaniment, and it is not taken as a complication. So, even in the brachial plexus block, suppose we are going for single prick technique. Usually we block the roots and trans. Septas are there are seeds are there. They divide the one from the other roots or trans. So, you may not be able to very successfully block all. So, if you use it with the nervous stimulators, it's good. Otherwise, you have to do 1 or 2 or 3 pricks, because you have to watch ultrasonographically the spread of the drug. From one compartment, second, other compartment, the drug may not spread, and you may have an incomplete block. Even if you have successfully given, the drug the proper course. So always be careful on that. Some supraclavicular block, trunks and divisions are blocked. Useful for anesthesia of surgery below soleus. Supraclavicular nerve escapes the block. Area over the acromion is not anesthetized, so you have to do a free block. Chances of pneumothorax IV injection is there. Phrenic and recurrent nerve block may occur. So the respiratory distress may be also a chance, and airway compromise may be there. So infraclavicular, when you are not in a very good position to block supraclavicular, you go for infraclavicular approach, because the blood vessels are coming in between. So it makes it easy from the lower end. So you try to do that. And axillary block, it's a easier technique, and but the position of the hand is to be in a position in fracture of the upper hand or injury in the upper extremity. You have to abduct the hand at 90 degrees. So gives a satisfactory anesthesia to the arm and below. Proximal tourniquet pain is not blocked. So you have to do some field block. You have to block the local infiltration. Axillary lines, artery lines, superficial and other nerves are lying around the artery. So you have to do few pricks, 1, 2, 3 pricks, and usually the musculocutaneous lies behind. So you have to do inject again. The best thing is you don't have a chance of no chance of pneumothorax, so it escapes. So truncal blocks, transverse abdominal spleen blocks, very common nowadays for anterior abdominal wall surgery and anesthesia, and but there should not be any intra-abdominal manipulation. In that case, you don't use truncal tab blocks. Risk of peritoneal perforation and visceral injection is always there if we are not very careful. Other truncal blocks are paravertebral trap, rectus block, hernia blocks, penile blocks, others. Usually in the cases of circumcision and other surgery on the penis, it is a very good technique to give penile block. Lower extremity blocks, femoral, usually we do that safety, and saphenous blocks we are all give. So talking about the residual block is just a theoretical part. The best thing is it is a topic of workshop. How to do it? But one thing, it is always be kept in mind before going for any regional block. The anatomy should be very clear, because if you are not knowing the landmarks, even with the ultrasonograph, different probes, whether you are doing linear or whatever, in line or beyond the line, so you have to know the anatomical landmarks, where to put the prick, what should be the direction, how much you feel. The feel in the fingers gives you the better chances. If you are in doubt, go for nerve stimulators, and a lot of my colleagues, senior colleagues, who are very much practiced, they don't use ultrasound. They go with the anatomical landmarks and with the feel, and they are also achieving a good blocks. What we are doing with the ultrasonograph. So it is a technique. This is the best instrument equipment we are now having for last few years. The ultrasonographic machines, equipments, portable one, very handy wherever you want, ICU or OT table or in the ward, you can do the blocks. And this is the really a help to us. This is a big study.
Last 1 minute.
Yeah. This is the last study, the biggest study, 2010, where they have given a very good number of cases of the regional block. The study revealed that an overall of complication was 0.12%, very negligible one. So, what is the take-home message? Potent method to providing anesthesia in children. Minimal risk and side effects if used with ultrasonography. Less dependency of opioids and other analgesics. Never exceed the dose of the local anesthetics. Useful as single bolus as well as long-term infusions. Reduces workload of the PSCO and daycare. Better nursing efficiency and very cost effective. Thank you.
Thank you for the beautiful presentation and highlighting the points of regional blocks importance. Now the topic is open for discussion.
You mentioned about the come to the center and then So you mentioned about butorphanol being used as an additive with local anesthetics.
Pardon?
You mentioned about butorphanol being used as an additive with local anesthetics.
Yeah, few studies are still there, but we are using maximally the fentanyl or clonidine. We don't use, but there is articles.
Is it FDA approved? Because the message was very wrong. Is butorphanol addition to local anesthetic, is it FDA
I have not studied any article that is contradicting the use of butorphanol, but there are articles use of butorphanol in regional anesthesia.
Is it FDA approved? That's what my question is.
Okay, maybe. Which journals you are putting?
As far as I know, butorphanol is not FDA approved, and there are a lot of students in the audience.
There are so many drugs.
The message that's my question.
There are so many drugs which is not to be used in different scenarios, but we are using. Regarding the butorphanol, there are
national conference, please.
So we are using clonidine. Butorphanol, there are the studies. That's why I have mentioned it.
Nowadays, dexmedetomidine is also adjuvant, can be used in pediatric patients.
Even in private practice, we are using spinal analgesia for children very frequently nowadays. With the advent of finer needles, now you have the fine bore needles. We are using a lot of spinals.
Okay.
Thank you, Dr. Rajit Gupta. With that, we'll go to the second topic now.
Thank you, sir.
Now it's my pleasure to invite Dr. Mahesh Babu, who is Associate Professor in Kankaraya Medical College, Kakinada, for the topic Anesthetic Management of Common Pediatric Emergencies. Sir is a PG teacher for 19.5 years. He is invited faculty at 9 ISA national conferences, 10 ISA AP state conferences, 3 ISA Southern conferences, 9 times at Sri Ramchandra Anesthesia CME. He is a scientific committee chairman twice for ISA. He has 9 national publications. Now he was a past president of ISA state.
Good evening, respected chairpersons, for good introduction. Thank you very much for that. At the outset, I would like to thank the organizers for giving the opportunity, and good evening all of you. Let me confess one truth that this topic is prepared for the benefit of postgraduates and not for the consultancy pediatric practice, and not for the pediatric cases. I apologize for that first, because basically in CME what we prefer is for the postgraduates only. So in the coming 25 minutes, I will be dealing about the endodontal physiological aspects related to neonates and children in particular, the pharmacological aspects, perioperative fluid management, veteran products, and confined to the topic, the emergencies in neonates pediatric age group, the anesthetic management of the emergency procedures in general, and the summary of all the things. So when you talk about the neonate, you can take it as small adult, where there are some changes in the cardiopulmonary factors like the VO2 is almost 5 to 8 ml when compared to adults 2 to 3 ml, and the increasing respiratory rate facilitates carbon dioxide elimination. So when you decrease the rate, there will be hypercarbia. The alveolar ventilation in the pediatric period is approximately 130 ml per kg per minute because of the increased respiratory rate when compared to 60 ml per kg per minute adults. In the neonate, the apnea decreases the gas exchange in the lung and is associated with hypoxemia and bradycardia. This is to be kept in mind while you ventilate a child during the period of the blockade with neuromuscular blockade. If you can't ventilate immediately, the chance of getting desaturation is very high. Apnea is the one common thing which is going to occur even after successful recovery from the neuromuscular blockade. The apnea can be classified as a central apnea because immaturity of the depression of the respiratory tract in neonates very particularly. Obstructive apnea due to infants inability to maintain a patent airway, and mixed apnea because of the two factors together. Nearly 20% of the premature infants can be expected to have apnea in the postoperative period, even though you successfully extubated after moderate neuromuscular blockade. And most important thing is your drugs, the anesthetic drugs, your IV anesthetics, water anesthetic, neuromuscular blockade, they can all produce apnea. As you know, this is the fundamental anatomical reflex to see about that. narrowness, anterior and separate plot space, C to C3 in children and about 4 to adults. Large span, a cricoid cartilage is a narrow span. It's a subglottic stenosis is a common problem. Low FRC, closing capacity more than FRC. The other ventilation capacity ratio is about 5:1 and compared to 1.5:1 adults. Add to that, the difficulty is further there because of slanting vocal cords with omega-shaped epiglottis. The chest wall respiratory difference is the ribs are horizontal in neonates when compared to vertical adults. The ribs and cartilage are more pliable. The chest wall collapse more with increased negative infrathoracic pressure. Erectus is more common because decreased FRC and decreased number of alveoli. A tidal volume and almost dead space are equal when compared to volumes. The problem is here, as I told, the VOT is more. The OD curve is situated to the left because of the fatal hemoglobin and high affinity of the oxygen. The newborn must overcome a negative inspiratory pressure up to 46 centimeters of water to overcome surface tension. There is a problem of the surface because the negative pressure formula is a common problem. As you know, renal function, the GFR and tubular functions are immature. They get alkalis only at the age of 2 years. They are the obligate sodium losers and cannot concentrate urine, hence exogenous sodium and water is provided. The ability to extract volume are slow and more susceptible to overload. The decreased renal function leads to delay and extinction of drugs which depend on metabolism on the renal pathway. So renal function, decreased GFR, decreased concentrating capacity, decreased sodium absorption, decreased CO3 and H+ exchange, decreased free water clearance and increased urine loss of potassium and chloride. The immature kidney has diminished ability to handle a solute load. The newborn are more with they born with excess sodium. That's the reason why you are not supposed to give hypertransfiltration and isotransfiltration initially up to 7+ hours. For replacement of insensible losses and loss because of the surgical trauma, you have to use isotonic fluid separately, not as a maintenance fluid. So what means ultimately the newborn kidney has limited capacity to compensate for the volume excess or volume depletion. Temperature regulation is very important. They always think about avoiding hypothermia because they cannot shower like adults and they cannot depend on this maintain the body temperature. They always depend upon their brown fat. If you take a premature child where the brown fat develops only 26 to 30 weeks, when they are very premature, they can't maintain the body temperature. Even simple covering of the head is sufficient to maintain the body temperature when not able to cover the entire body immediately. So fluid management very important. You know very pretty well, you always think about the maintenance fluid, replacement fluids. The maintenance fluids, which are the things which have been given, cover the maintenance pre-operatively, intraoperatively, and the maintenance fluids ought to be given throughout the surgical procedure and post-operatively also, along with replacement fluids which are isotonic in nature, like renal lactate. The highly variable body fluid composition, degree of renal immaturity, neuroendocrine control of intravascular fluid status, all the things makes them, the requirements are very unpredictable and quite challenging. So maintenance fluids in the old children are given as per the Hardy-Sager regime you will know about. And for premature children, very particularly first 3 days of the 7th hours, you have to add glucose to them. The maintenance fluid therapy, this is actually given by the Royal College of Children, Australia, in Melbourne. They give like this: the day 1, 50 to 60 ml per kg per day, you give dextrose 10%. Day 2, you add 1.2 half normal saline, is 0.4% normal saline. More than day 7, you have to give 100 to 150 ml along with D5 to D10 along with 1/4 of normal saline. The water chill you have to give 4 to 1 rule. The Royal College of Children, Melbourne, they strictly gave a warning not to give the fluid which is marketed earlier in the UK and Australia. They used to market 0.18% normal saline along with 4% dextrose. They strictly banned that both in Australia and UK because they found a lot of hyponatremia when youth is so very hypotonic dose of 0.18% sodium chloride. This is the classical Hardy-Sager you know about, and we have to add these fluid deficits, third space losses, hypohyperthermia factors, unusual metabolic fluid demands to be taken into consideration when deciding a fluid therapy. So total intraoperative fluid replacement is 1. It depends on maintenance fluid, estimated preoperative fluid deficit in case of vomiting and diarrhea-like factors, insensible loss throughout the procedure, very particularly when intestines are wide open. You have to think about that loss. Estimated blood loss depends upon surgical procedure and surgeon also. So the blood and blood products, the individual change blood volume can be calculated by multiplying the body weight, say about say 15 kgs, 10 kgs into 65% as the blood volume, you can determine the minimum level of blood loss like this. You take the initial temperature of the child, maybe for example, in this example, is about 38%. If you want to allow the worst possible temperature is 25%. If you allow the temperature and blood loss to occur, the amount will be coming about 360 ml. So 360 ml of the blood can be allowed in a child weighing about 15 kg with the initial empathic value 38%. If a child directly brought with trauma with hemorrhage and that empathic value further decreased to 25 or 30, then the volume is still less. You can't replace with crystallized. You have to go with blood and blood only. So when you want to give blood, with a child when there is a lot of problem with the whole blood, you have to go for PRBC, packed RBC. So the packed RBC can be calculated like that. The desired hemoglobin 35% theoretically, and the present hemoglobin estimated blood volume, for example, same thing as said here, you can have to give 262 ml PRBC for a child with a hemoglobin of low value. To bring it up to 35%, you have to give this amount of packet cells. If you want to give blood, you have to give 3 times of that. Then the child may have fluid overload and pulmonary edema. So this is the one, you know particularly about the calculation of the tubes, how you are going to give the umbilical tube and the different types of blades here, additions of insertion, how much you have to go. And nowadays, everybody is now using LMS and IGS. We got a lot of experience using them. And there are a lot of studies saying about the superiority of IGL over posterior LMA. A lot of publications have come now. You can safely use LMS in children, or you can use IGL as long as there is no problem of full stomach, like you see with the pelvic stenosis. So monitoring is very important, very particularly temperature monitoring along with the simple thing, pre-cardiac stethoscope is the one which is available in any type of hospital, along with your pulse oximetry, capnography, NIB, PCG. And the pulse oximeter should be placed on a pediatric side. The second one can be cased on backup, the right to left hand should there. So monitoring you not put a Pullman's cardiac output is always advised infants having major surgery. So in critically ill children, you are thinking about two things: intra-arterial catheterization important to continuously monitor. That can also give you continuous blood sampling for measuring electrolytes, and ABG can be done. And you can keep a CEP catheters also to know about the volume status. The problem is, if you want to give only drugs, you can use PICC lines also for giving drugs, but monitoring is possible only with the CEP lines. So coming over the pharmacology, the body weight is about 91%, the bond weight with extracellular fluid of 40%, when compared to adults 33%. A drug that is water soluble has larger volume of distribution like succinylcholine. You have to give increased dose initially. And the low serum protein is one factor leads to increased volume of distribution. As there is less fat, the drug like thiopentone depends on redistribution. The fat should be given again low dose, because normal dose will have long duration of action. A drug that distributes to muscle layers may have longer clinical effect, like in fentanyl. You have to keep it in mind. So the important things are large volume of distribution is large, renal function is immature, the physical anemia occurs about 9 to 12 weeks. Spinal cord ends L3 because my previous speaker talked about the renal blockade. You have to keep this in mind. You want to give spinal anesthesia. Non-severe emergencies to be kept in mind. So rapid induction and recovery rate to increase the cardiac output, one important factor when you use water elastics. They will increase MAC the first 2 to 3 months of old children. They need high MAC values. Immature hepatic biotransformation to be kept in mind when the lung depends upon this cerebromy 43 mechanism. So pharmacology of opioids, immaturity of blood barrier, there will be higher CSF opioid concentration to be careful about that. And because immaturity of brain system always leads to respiratory depression, increased post-operative apnea. Remifentanil is coming in a big way. All the speakers talking about remifentanil is the one which is to be used in the future. But careful attention to be taken place when you use opioids for the bradycardia and chest wall rigidity. So muscle relaxants increase sensitivity of receptors, but no difference in initial dose because of the increased volume of distribution. So succinylcholine, as you know, you can give even the two drugs which are accepted for pediatric usage, biomeruta, succinylcholine and atropine. You can be given as IV, IM, but always think about that factors like hyperkalemia, mastospasm and increased pressures. And there are different doses of your NDMS can be given safely, and different dose of albuterol can be given like this. And edrophonium is not used routinely, but neostimulant one you can use of 0.0 to 0.6. Always, if you have a neuromuscular monitor, you can effectively monitor neuromuscular blockade. IV injection agents, it depends upon the child and the condition and the type of surgery. You can use an inhalation technique or IV injection. Your classical type pattern, you have to do it. You have to preferably give 10% concentration at twice kg. It can be given rectally. And other drugs like propofol, initially you have to give high dose. Laterally, when children grows for 6 to 12 years, you can give more. That is because the volume distribution is high there. Ketamine, the sole anesthetic, can be used as sterile anesthesia, can be given in the form of IM, IV or different. But one thing is you have to think about the increased ICP and open globe injury and the cardiac conditions you are aware of. Inhalation agents increase cardiac output, as I told earlier, increased uptake, and initially there will be 20% less needed than infants. But in the first 2 to 3 months, you are very careful about the MAC value, your particular cancer that they may require more initially, but the problem is that residual respiratory class will be there. Isoflurane is less mild depression than halten, preservation of heart rate and CMO reduction is there. And desflurane, the coughing, larynx spasm irritation is the one important factor which will not make it used for induction. And you are concerned about hypertension, tachycardia from sympathetic activation due to desflurane. The one water anesthetic which is fancy to use for children is sevoflurane. You can safely go for induction and maintenance for this one. But initially, as I told, the neonates will require a MAC of 3.3% compared to old children of 2.5%. It will produce a dose-related respiratory depression by decreasing the both tidal volume respiratory rate. You have to keep this in mind. So, coming to emergencies proper, when I asked the organizer to comment about the topic, what I was given, the pediatric emergencies, they asked me to cover everything in that group, neonates and children together. So the thing is, if you talk about that, I am avoiding the medical emergencies like seizures, status asthmaticus, status epilepticus, trauma, poisoning. All the things are not discussing because major things are monitored by intensivists and pediatricians. So now let me confine the topic where we have got direct interaction with the pediatric surgeon. So we will confine my topic to these things like the premature infant will have necrotizing enterocolitis, intestinal obstruction, and neonatal emergencies like tracheal fistula, CDH, hypertrophic peritonitis, omphalocele, gastroschisis, duodenal obstruction, Ishmael disease, and so on and so forth. So having working in a government setup where all types of cases come, we have got opportunity of giving anesthesia to all types of emergencies in neonates and pediatrics for the last 20 years. So this is the minimum fasting fluids. Now the thing is always infant formula 6 hours breast milk and clear fluids can be given 2 hours. Even the cesarean patients also know 2 hours is the one they can give clear fluids which in glucose. Coming to esophageal ectasia and tracheal fistula, as you know, the third one is most common where the upper one ending in the blind pouch of the esophagus ending in the trachea. Esophageal ectasia and tracheal fistula are often associated with the conical abnormalities and no water association where there will be vertebral abnormalities, imperforate anus, and tracheal fistula, radial aplasia and renal abnormalities. And the third new one is vagal association where the congenital heart disease and liver abnormalities are added. The affected neonates usually present with excessive oral secretions, regurgitation of the feedings, occasionally respiratory distress excited by the feedings. In the most common form of TF, the esophagus ends in a blind plasma pouch with the distal end of the esophagus connected to the trachea. We use about 85% of times to see this. So the diagnosis is confirmed by the inability to pass a moderately rigid orogastric tube into the stomach or the demonstration of the blind esophageal pouch by air contrast the radiopaque dye and radiographic studies. The neonates should be nursed preoperatively prone sometimes or in lateral position at inclination of 30 degrees to decrease the risk of pulmonary aspiration. A some suction catheter placed in the upper esophageal pouch should continuously dry the secretions. To establish an airway for general anesthesia, infant with TF may undergo intubation while they are awake sometimes based on the condition of the child. The topical anesthesia of the airway or they are medically stable, you can go for intravenous sedation. To properly position the airway tube, An intentional, deliberate, right mainstem bronchus endobronchial intubation is initially performed. You have subsequently pulled the tube down while auscultating so that the tip of the tube is just above the carina. This position it will be just above the carina and below the fistula. When the endotracheal tube is secured in this location, less gastric insufflation is likely to the fistula arteries. A gastrostomy is occasionally performed when the condition not good. You can do a sequential repair of the things. With a gastric vent in place, infant may undergo inhalation induction because there is no point of increasing the stomach capacity there. Always keep a stethoscope over the left chest so that you can monitor continuously the breath sounds both bilaterally. Preferential ventilation to the fistula can also be done but not effective. Then you have to keep a forwarding catheter pass retrograde on stomach tube and the oral gastrostomy tube, and you have to block that fistula. An epidural catheter can be threaded, just like previous speaker was telling about the importance of the caudal epidural. You can pass a caudal epidural so that tube can be passed up to thoracic level and render posterior anesthesia. Early expiration of surgery is desirable because it prevents the prolonged pressure of the ET tube on the suture line. But sometimes the child may require help to posterior ventilation or re-intubation is a common problem there. The coming to the second thing is that congenital diaphragmatic hernia. The incidence of the CDH range from 1:2000 to 1:5000. The failure of diaphragm tissues to fuse approximately most often appears. The posterolateral bogdalar type hernia 90% are commonly seen. The compressed efforts make the lung hypoplasia further and further worsen. And abnormal compression of pulmonary structures is the hallmark of the CDH and the cardiopulmonary sequelae which occur even post-operatively. Ultrasound examination now is depicting quite effectively the CDH before actually the birth of the child. Hypoplastic lung is with CDH, there are fewer functional alveolar units and a grossly diminished surface area for effective gas exchange. The resulting functional surfactant deficiency is one important factor, particularly premature children. The surfactant deficient, that's why they are more prone to respiratory syndrome post-operatively. So CDH most often manifests as severe respiratory distress in the neonate, a direct consequence of lung hypoplasia and inadequate pulmonary gas exchange. Clinically, tachycardia, tachypnea, cyanosis that can be observed shortly after the delivery. The abdomen may appear scaphoid because the organs are bound to the diaphragm. The midexternal may be shifted as a result of the herniated viscera. The initial management of neonatal respiratory failure with CDH is improving the oxygenation and ventilation. The mask ventilation is generally avoided because further distends the stomach and makes the condition worse, ultimately passing pneumothorax may occur. After securing the airway and instituting the mechanical ventilation, a nasogastric tube is needed to decompose the intestinal contents effectively. So currently, surgical repair is delayed until the neonate has been optimized. Unlike in the past, where CDH is maybe rushed in theatre, now you can wait for some time, meanwhile optimize the child, then you can go for CDH repair. There are a lot of new modalities of treatment come like high frequency oscillation, surfactant therapy, nitric oxide therapy, and ECMO. All are improving survival rate now in a conceived child, which require prolonged mechanical ventilation post-operatively. So what are the predictors of the successful survival of CDH repair? The classical Bond's index, oxygenation index is there where you calculate that we have been affected by PaO2 less than 0.8 predicts a 94% survival. A modified ventilation index with the peak respiratory pressure, respiratory rate is to be 1,000 less than 40 predicts a 91% survival rate. These things you know, intraoperatively and postoperatively, you know how far the child is going to survive. Hypertrophic pulmonary stenosis, the one condition where you treat like a full stomach condition, approximately 1 in 500 ribos, occurs more in males. It represents hypertrophy of the muscular layer of the pylorus and can often be pondered as olive-shaped mass between the midline and right upper quadrant. The lesion is most commonly delineated by ultrasonography or rarely with a barium shallow. It is advisable to maintain intravascular volume because depending on the prolonged vomitings, the child will have a lot of severe dehydration with electrolyte imbalance. That's going to prolong the neuromuscular blockade when you do general anesthesia. With the protracted vomiting, there will be hypothalamic, ophthalmic. Immediately before induction, the stomach is aspirated using a large bore orogastric tube. They should not have excess anesthetic induction because that will definitely increase the vomiting. So IV induction is preferred. A rapid sequence induction is preferred here. That the reason why you better to use IV injection based on the condition, based on the volume starts with child. You may go for a ketamine if there is hypovolemia is there. The intubation is expected to be difficult. Awake intubation is preferred. Inhalation advanced anesthesia may be used subsequently for maintenance, not for induction. Extubation is done when the infant is fully awake and vigorous. Local infiltration of incision site with the long-acting local anesthesia can be provided to produce prolonged post-op anesthesia. The feedings are usually begun throughout surgery as early as possible to prevent this epidural imbalance. Imperforate anus quite commonly seen where you have is associated with the Baxter syndrome. They require a decompressive colostomy. You can go for regional blockade like your caudal valve block can be given for imperforate anus. And the worst possible scenario occurs necrotic enterocolitis, very particularly premature children with very bad prognosis, even of mortality to the best interest possible up to 30% mortality rate there. It is not an anomaly, but illness found predominantly in preterm infants. The morbidity associated with necrotic enterocolitis include the short bowel syndrome, sepsis, adhesions associated with the bowel obstruction. Associated conditions include birth asphyxia, hypertension, RDS, EDA, recurrent apnea, intestinal ischemia, umbilical vesicular cannulation, all the things may be associated there.
So you have only 1 minute.
Oh, sir. Early signs of necrotic enterocolitis include temperature instability. They should be continuously monitored and they are allowed to for maintenance sometime. There will be gas in the intestines due to this tight appearance. You have to treat hypertension, metabolic acidosis and give volume load. They may require blood, vascular plasma, platelets. They have to optimize. Other things are influencing gastrostasis. They are present like this. They will have like their patient like this. A lot of tissue exposed. They will have electrolyte disturbances and they have to cover them. But if you give fluid overload, you have to a plastic wrap is decreasing evaporate bowel volume is applied. You have to sequentially close it, or else there will be adrenal hypertension will occur. And you have to use tissue expanders for reducing them. This from disease again associated with a bowel with absence of passive ganglion cells, Hornbeck and Memphis. They require initially functional decompression, they need colostomy, and subsequently you have to use these surgeries for the transanal pull-throughs. The front board and airway is a common scenario seen in ENT practice where you have rigid bronchoscopy. And the other thing is the positive pressure ventilation makes sometimes the front board more difficult. We have discussed with the ENT surgeon whether it is spontaneous or controlled ventilation and decide accordingly. You can give lotus candle and the sterile front body can be removed. Coil atresia, stenosis again in one procedure. And upper epiglottis, all the things need steroids and immediate intubation immediately. So in the past, many conditions classified as emergencies, now they can be expeditiously optimized and can be taken to theatre later. In most circumstances, there is time to medically optimize the child condition and do surgery later. And always it's a multidisciplinary approach between a pediatric surgeon, neonatologist, intensivist, and a pediatric anesthesist. All work together. You can have baby like this. Thank you.
Thank you for not only the anesthetic management of pediatric emergencies, you have taken us through the entire pediatrics. Thank you for the good presentation. Now the topic is open for discussion.
Exhausted.
That's no questions. You have dealt with the subject so well. Thank you, Mahesh.
Hello sir, you are about to say about the emergency epiglottitis child for intubation. Could you please tell us about that?
And the time is very short, madam. If you can give me a chance, I can go for that. With the permission of the chairperson there, I can go for that. Madam, what epiglottitis? You want this? Epiglottitis? No. No. But what you want to avoid intubation or intubation? What do you want to do? Yeah, but definitely. This is a very emergency situation where, particularly in a pediatric department, rushing to a theatre, it takes a lot of time. It is very important. Whenever there is a upper obstruction with inspiratory stridor retraction of trichopnea, they classically assume that tripod position demonstrates trolling and difficulty. And immediately you have to secure the airway. Sometimes it is difficult for them because difficulty in intubating also. And surgical resource may be needed sometimes to emergency tracheostomy may be needed. Along with the ENT surgeon, you have to do that. But the most important thing is you have to see that airway is taken into your care and you have to provide oxygen immediately or you will do the chair immediately. And here, epiglottitis, the corticosteroids has no role at all. It is immediate intubation and maintenance the airway is important as the corticosteroids. Other things like laryngothical bronchitis, there is no role of corticosteroids. Epiglottitis, there is no role of corticosteroids at all. In laryngothical bronchitis, you can give a single dry dose of corticosteroid where you can maintain that. And lower airway obstruction also, there is no role of corticosteroids, much depends on ventilation. Other thing like status osmosis, everything is now a combined effort of intensive pediatricians with you together. Thank you, ma'am, for making me to speak about those slides also. Thank you.
We have to remember about the complications of pediatric anesthesia. First, bear in mind, and then accordingly to the patients. Because diagnosed person is too common in pediatric patients.
So, contrary to the earlier phase where you use 0.4% sodium chloride, now in grown-up child, you can safely use renal lactate everywhere now. Coming in big way now, it is the fluid of maintenance fluid of choice for the children also, not in the units.
One important announcement to make, the quiz will be in Hall F after 5 minutes. Also, I would advise the chairpersons and the speakers, Dr. Ajit Gupta and Mahesh Babu, for the memento, and Dr. K.R. Tagore, Dr. Mahesh Kumar Sinha, Dr. Srinivasan, Dr. Bhusha Bhatt. These plants will be grouped and kept in outlets.
Back this way.